morning.
या दिसत नाही. Okay, then we
दिसलं ना?
Good morning, all. We are meeting today on the occasion of World Heart Day. We have with us the President of IMA Maharashtra State, Dr. Ramkrishna Lunde, sir. I welcome him. Also have the Honorary Secretary of IMA Maharashtra State, Dr. Pankaj Bandarkar, Dr. Jitesh Mehta, President of our branch, Dr. Girish Lad, Secretary of Mumbai branch, Dr. Vitisha, the chairperson of this World Heart Day, Dr. Usha Shah, who is the Director of IMA CGP Mumbai Sub-Faculty, and all the members who are there with us. We begin this program with a speech from our Secretary, Dr. Girish Lad, sir. Over to Girish Lad.
Yeah, good morning, everybody. I, on behalf of Indian Medical Association Mumbai branch, welcome you all for such a wonderful webinar, which is going to be witnessed by all of you today on behalf of IMA Mumbai branch. And see, World Heart Day is always celebrated because in today's world, heart diseases, maybe congenital or acquired, are very important issues because congenital issues are mainly not in our hand much, but acquired diseases are in hands of patients. They can prevent heart disease, but many vices, overexertion, and whatnot, all this can cause heart disease, and therefore we need good team of cardiologists. And today we are having such a wonderful team who will definitely enlighten us about not only the treatment, but to some extent prevention of heart disease. So now first of all, I thank Dr. Ramkrishna Lunde sir and Dr. Pankaj Bandarkar sir, the President and the Secretary IMA Maharashtra State respectively. And I hand over the mic to Dr. Jitesh Mehta, our President of Mumbai branch.
Thank you, Dr. Girish Lad. And good morning to all and a very warm welcome on behalf of IMA Mumbai branch. I thought World Heart Day, when Girish was mentioning, I thought he will say that World Heart Day is being observed because people have forgotten. See, there is a heart. They don't use their heart nowadays, they just use their minds. So this is philosophically. So I think that also needs to be addressed. If your heart is working well and your mind is also, in tandem with your heart, I think you listen to your heart and then you act whatever accordingly. And that will really relax yourself and it will give you a better life, as Dr. Girish Lad said, the secret to a healthy heart. Because heartbeats we don't really realize normally, but when there is something wrong with the heart, we start realizing so many things happening to us. And with this COVID pandemic, the heart along with the lungs has been very severely affected. I'm sure all of you will agree that we have been seeing a lot of cardiac problems in this last 1.5 years. And all the cardiologists have been very busy, including Dr. Vitisha here. So it is definitely worthwhile listening to all this and discussing about all these heart problems and revising our knowledge and updating our knowledge. So I welcome Dr. Ramkrishna Lunde sir and Dr. Pankaj Bandarkar sir, the leaders of the IMA Maharashtra State. Dr. Lunde sir is very busy just now doing the tours and trying to tie up all the IMA branches in one thread. A wonderful job you are doing, sir. Thank you very much. It's a great service. I'm sure you and Dr. Pankaj Bandarkar both are stretching yourselves to the limits. And when I'm seeing a Pankaj always running around, I'm sure Dr. Lunde sir is also doing the same, rather more than him. So kudos to you. And with that, I will hand over the mic to Dr. Ramakrishna Lunde, sir.
Pankaj.
Pankaj.
Yeah.
Pankaj, okay, the secretary. Fine. Over to you, Pankaj.
Yeah. Thank you, Jitesh bhai. Good morning, everybody. Respected President IMA Maharashtra State, Dr. Ramakrishna Lunde, President IMA Mumbai Branch, Dr. Jitesh Mehta, Secretary, Dr. Girish Lad, Chairperson of this World Heart Day Committee of IMA Mumbai Branch, Dr. V.P. Shah, Assistant Director of CGP IMA Mumbai Branch, Dr. Usha, my friend, Dr. Anil Awad, President-elect of IMA Mumbai Branch. I welcome you all on behalf of IMA. As you all know, IMA Mumbai branch is known for its grand CMEs, physical CMEs. But because of COVID, this is not happening for almost 2 years, last 2 years. But that tradition we have kept in arranging all these webinars, grand webinars, started since last August with AMS conference, breaking all the records. Thanks to you. As you all know, last 2 years, mainly we were focusing on the COVID, but now it is a time. I think temples are going to open, schools are going to open, and we can focus more on the other elements other than COVID also. I congratulate all the cardiologists who have done a lot of good work against all odds during this COVID period. I know how they have suffered admitting patients in hospitals when all the hospitals were full with COVID patients. Today, we have many eminent speakers. I welcome them all. Dr. Of course, V.P. Shah is there, Dr. Narendra Bansal, Dr. Ajit Menon, Dr. Maulik Parekh, Dr. Nihar Mehta, Dr. Manoj Mashru, Dr. Neeraj Kamath, Dr. Bipin Chandra Bhamre, Dr. Bharat Dalvi, Dr. Shiv Prakash. So I'm sure this is going to be very informative and wonderful CME today. I congratulate Dr. Jitesh Mehta, Dr. Girish Lad, Dr. Anil, Dr. V.T. Shah, Dr. Usha, and everybody from the IMA Mumbai branch for arranging such a wonderful CME. And I know that the support is there from the Reliance, HN Reliance Foundation. And I hope that they will continue the same support in future endeavors of IMA Mumbai as well as IMA Maharashtra State. So once again, thank you all for inviting us to join with IMA Mumbai branch. And we will be happy to join again, associate with IMA Mumbai branch in future also. Now I request our President, Dr. Ramakrishna Lunde, who is at present in Dhule, as he is always traveling, last 6-7 months, he is continuously traveling and trying to cover all the branches, collecting funds and giving information, increasing the membership of IMA. So I welcome Dr. Ramakrishna Lunde, and over to you, Dr. Lunde, sir.
Okay, am I audible, sir?
Yes, sir.
Am I audible? Okay.
Yeah.
Good morning. Good morning to everybody. First of all, I congratulate IMA Mumbai branch for arranging this wonderful webinar on caring of heart. Really, it is a very noble cause. To say from IMAMS and through, I mean to say IMAMS from Dhulia branch. IMAMS and members of all Dhulia branch, I wish you all the best. Honorable Jitesh Mehta ji, Girish Lad, our very dynamic secretary, Dr. Pankaj Bandarkar sir, and his colleague. Once again, I wish you all the best. Thanks, sir. All the best. Okay, I have to attend this meeting very urgently. Okay, sir. Over to you.
Over to you, Anil.
Thank you.
Thank you.
Thank you, Dr. Ramakrishna, for joining us and giving your good wishes to our program. So, friends, first of all, I thank IMA Mumbai branch to give me this opportunity to host this session of World Heart Day. I think we have done for the last 20 years, we have been conducting this program. on the eve of every World Heart Day, which is on 29th September. And before that, every Sunday, the Sunday before that, we conduct this World Heart Day. Of course, last year and this year, it's all digital, but it was physical all along. So friends, this time the logo or the message from World Heart Day organization is to take the help of digital technology. So harnessing the power of digital health to spread awareness of prevention of heart diseases globally. And fortunately today we are using this digital technology to propagate the messages of the heart diseases, the prevention and treatment part and all that. And today we have a wide range of subjects which we are going to address. I hope you all participate actively and put your questions on the chat box so that we can address during the discussion. So friends, with this, we start first of all, before we start the first lecture, a small inauguration ceremony, which we do physically, but now we will do it digitally. Dr. Award and Dr. Girish Lad, can you play that?
Just a minute, sir.
Is it possible?
Just a minute, just a minute. Before we go on to the lighting of the lamp ceremony, I'll just introduce briefly the chairperson of World Heart Day, because everyone should know who is Dr. Vitisha. They know, but still, I'll just introduce him shortly. Dr. Vitisha is an interventional cardiologist attached to Kambala Hill, Bridge Candy, Prince Ali Khan, Nanavati, and Jupiter Hospital. He is attached to many corporate offices like SBI, RBI, Air India, MTNL, Mumbai Police as a cardiologist. He has authored many chapters in cardiology textbook and has several national and international publications to his credit. He is a very popular speaker and has been a guest speaker in many conferences, CME programs, national and international workshops. So that is our Dr. Vitisha. And now I request Piyush to start the video, and I request all the dignitaries to join for the lighting of the lamp. Piyush?
Life.
Sharing,
Can
sir.
also lead to the depression and affecting sexual desire and also socio-cultural factors, limited relationship, financial difficulties, lack of exercise can add.
Right. So thank you very much to the DigiShield people, Mr. Piyush, for that short inauguration and lighting of lamp. It was really wonderful. I hope we all get the best wishes for that, for this program, and to lead a healthy heart. So now we start with the first lecture from Dr. Narendra Bansal, and the topic is chasing the silent killer, that is hypertension. Dr. Narendra Bansal, as we all know, is a retired professor from the professor of cardiology from JJ Hospital and is currently at the Sir H.N. Reliance Hospital.
Sir, I request Dr. Usha Shah, who is the Assistant Director of IMA CGP, Mumbai Sub-Faculty, to introduce Dr. Narendra Bansal, sir.
वीडियो चालू नहीं हुआ।
डॉक्टर उषा,
मतलब उधर से कंट्रोल कर रखा है।
Dr. Usha?
Yeah,
Yes,
shall I start?
yes,
Yeah.
yes.
Dr. Narendra Bansal is a consultant cardiologist at Sir H.N. Reliance Hospital. Dr. Bansal specializes in doing all type of angioplasties with use of advanced techniques like rotablator, IVAS, OCT, FER, etc., and primary angioplasty in acute heart attack pump. He has so far done more than 10,000 coronary angioplasties and has performed more than 1,000 permanent pacemaker, both single and dual chamber, and implantable defibrillator, ICD, CRT. He has undergone training in angioplasty in France. He is postgraduate teacher for cardiology for more than 2 decades at Maharashtra University of Health Sciences, an examiner for DM, DNB, FNB cardiology at several universities across India. He is an inspector for cardiology course approval appointment by Medical Council of India. He is a president of Cardiology Society of India, Mumbai chapter, and secretary of Indian College of Interventional Cardiology. He was cardiologist to governor of Maharashtra. He served as a member of Organ Transplant Committee of Maharashtra. He has organized several heart camps in Maharashtra, including annual camp on World Heart Day each year. Today, he will be speaking on chasing the silent killer, hypertension. Over to Dr. Narendra Bansal. Thank you.
Thank you, madam, for those kind words. I must tell the people, my colleagues who are all listening to me, that hypertension is the commonest disease today seen worldwide, globally. You will find almost, once you see a patient 60 plus, 1 in 4 hypertension incidents is known to occur. And hypertension is such a problem that remains silent. Unless and until you check the blood pressure, you will not know that you are a hypertensive. But the hypertension disease process internally keeps on damaging the blood vessels and results into an impact after 10 years, 15 years, 20 years, affecting the heart, the brain, the kidneys, the eyes. So I begin with my talk. In the next 20 minutes, I will give you an overview of how hypertension damages our body organs. How do we make a quick diagnosis of hypertension? What are the cutoff points that we need to label the patient as a hypertensive? And in brief, what are the investigations and the management of hypertension, the commonest problem? It is called as the silent killer because it causes damage without symptoms. Most of the patients of hypertension are asymptomatic. It is the myth that if you have a headache, the pressure is high. No, it is not true. More often the pressure is high and less often you have the headache. Now look at my slides. In the corner, I have shown you the incidence of hypertension as detected in the United States, that as the age increases, the incidence of hypertension increases. In a 20-year-old, it is 5 to 6%, which goes up to almost, for a 75-year-old, to a 75%. That is the magnitude of the problem, which is going to affect the population at large, and it is going to have its impact on the various end organs, as we call them. It affects your brain, resulting into a stroke, which may be an atherothrombotic stroke, or it may be an intracranial bleed, and these can be fatal, or it will compromise the quality of life. It attacks the heart, resulting into heart attacks, which we see day in and day out as the commonest medical emergency, or it can result into heart failure. Left undetected, undiagnosed, untreated over a period of 1 to 2 decades, it is bound to impact the kidney resulting into renal failure slowly. It is also an important cause for sexual dysfunction, and it can result into ophthalmic damage. So these are the various areas or the organs where the hypertension has its attack, and it results into dysfunction of the organs which are going to be attacked by hypertension. And we have the various clinical problems resulting from stroke, heart attack, heart failure, etc. What I told you just now. Just to show you once again, what are the target organ damages? And then when a person has diabetes, overweight, hypercholesterolemia, he's a smoker and a hypertensive, the problem gets magnified. Essentially, there is peripheral vasoconstriction, there is vascular hypertrophy and disturbed endothelial function leading to atherosclerosis. This starts targeting the heart, the brain, and the kidney, as I told you. And it can result into left ventricular hypertrophy, which we commonly look for when we take an ECG or we do an echocardiogram. Of course, the fibrosis can only be seen by an MRI. We cannot see the fibrosis clinically. And what is the clinical impact? The clinical impact is getting a myocardial infarction, heart failure, and arrhythmias. And those patients who get this, some of them may not make it up, leading to a mortality. Similarly, it can have an impact on the brain, which can result into stroke, which can be hemorrhagic or a non-hemorrhagic, and it can lead to cognitive dysfunctions. Again, an important cause for mortality. Similarly, it targets the kidney, which leads to a decline in the GFR, proteinuria, albuminuria. See, it is a good practice nowadays. All the labs are assessing for the proteinuria when you send a simple routine urine sample for evaluation. What is the pathology underlying? There is a glomerulosclerosis, which ultimately causes rise in the creatinine values. So even don't neglect small rise in the creatinine. Let it be 1 renal failure. And then if you don't take care of the renal failure, it is going to advance, resulting into dialysis and long-term morbidity and mortality. So these are the end organs which are going to be targeted by hypertension, resulting into fatalities. And friends, it is very important to note that if you apply corrective measures and control the blood pressure, even a small reduction in the blood pressure by 10 millimeters in the mild hypertension will give you a stroke benefit of 27%, coronary artery disease benefit by 12%, a heart failure benefit by 25%, and overall all-cause mortality by 11%. So even small reductions in the blood pressure are beneficial. This is a study from Canada, which shows that if you reduce the blood pressure 10 millimeters systolic and 5 millimeters diastolic, the stroke incidence reduces by 35 to 40%, the myocardial infarction by 25%, and heart failure by 50%. So we have ample data now. There is no question that correcting the hypertension is going to be beneficial. What is the scenario? We are always lacking in data in our country, but we do have some work done by people and a publication in 2017 in the International Journal about the scenario in India. Look at these bar diagrams which show the dark one is referring to the urban and the lighter one is referring to the rural. The awareness at best in the urban is 45%. Treatment is offered to only 37%. And what is it? The control is extremely poor. Hardly 15 to 17% people are showing a good control in the hypertension. Similarly, there is a right side diagram which is showing some studies carried out in Bangalore, Chandigarh, Chennai, Jaipur, and Trivandrum. And from these charts, you will realize that patients who are in the south are better cared for than the patients in north. Particularly the Jaipur data is very dismal. In the year 2017, the prevalence of hypertension in India was almost 30%. And this is what we see every day in our practice when we are faced with acute coronary syndromes. So what is peculiar to India? In India, we see an early onset of hypertension in life. We have a divide between the urban and the rural. We have a clustering of multiple cardiovascular risk factors. So remember that diabetes, hypertension, hypercholesterolemia, smoking, sedentary life often go hand in hand, making the candidate a perfect victim of coronary artery disease and strokes. There is a rise in the average blood pressure of the general population. As we are doing more and more studies, we are finding the people living longer and longer, you have a rise in the average blood pressure. As I showed you in my previous slide, the awareness is low, the treatment offered is low, and the control rates are very, very poor. And this is what leads to early end organ damage, which brings the patient commonly to you and me. Now, there has been a good meta-analysis conducted. More than 1 million patients in the age group of 40 to 70 with a blood pressure more than 115 by 75. You find that if we take 115 by 75 as the basal blood pressure and you consider the risk of getting vascular disease as one-fold, as the blood pressure increases to the right of the screen, you see 1 by 20 millimeters, it increases to twofold, another 20 millimeter rise to 155, it becomes a fourfold, and at the pressure value of 175 by 105, you are having an eightfold risk of getting cardiovascular and the neurovascular problems. And this data has been published as early as 2002 in the reputed journal of Lancet, and the situation hasn't changed even after 20 years. So risk of CV mortality doubles up with each 20 by 10 millimeter rise in the blood pressure. So let us see what the new guidelines have to say. We have international associations and societies which keep on collecting the data, study them thoroughly, do the epidemiological studies, and they keep on coming out with the definitions for hypertension. There is a small difference between the way the Americans look at it and the Europeans look at it, and therefore I decided to put both the charts side by side. If you can appreciate that the Americans are more aggressive and their cutoff point for the hypertension is 130 by 80. So stage 1 is 130 to 139 and stage 2 is more than 140. But the Europeans are a little more conservative, where you will find the cutoff point given as 140 by 90, and then they have graded it into 3 grades, 1, 2, 3, and they have also taken into consideration isolated systolic hypertension, which is seen commonly in the elderly, more than 140 systolic. So the take-home message is nothing but that the blood pressure normal is more or less the same in both the guidelines, but the categorization into grade 1, grade 2, or stage 1, stage 2 is slightly different between the European and the American recommendation. Here are the recommendations from the International Society for Hypertension, which more or less matches with the ACC recommendations. Now I talk to you on the Indian guidelines. We are a mix of both. We have taken something from the Americans, we have taken something from the Europeans, and we have done some studies of our own, and on the basis of that, we have come out with a paper that 140 by 90 should be considered as hypertension, and we stage it into 3, stage 1, stage 2, stage 3. And we have also graded the systolic hypertension into grade 1 and 2 as 160 dividing line from stage 1 to stage 2. So the normal value in India should be 130 by 80 or 85 and below. Even though there are differences between the various guidelines, but ultimately everyone wants the same goal to reach when you treat a patient, That is, values below 130/80 is the goal. What are the various factors that can elevate blood pressure? I will quickly run through this busy slide. High sodium, caffeine, alcohol, even herbal supplements can be there, which can be responsible. So don't think that the Ayurvedic drugs don't do it. Recreational drugs, nowadays very popular, cocaine, oral contraceptives, serotonin, NSAIDs, cyclosporins, cough mixtures, asthma medicines, they are all responsible for it. Now, this is for us to know. Most of the hypertensives are asymptomatic. If they get a headache, what is important headache? Posterior, nuchal, early morning. Not any headache over the vault of the skull, it is not very important. Instability of gait, effort intolerance, breathlessness, nocturia. Check the blood pressure. I'll show you how to do it in my next slide. Check the pulse rate, the heart size, any murmur which is unusually there, or the lower limb pulses, rarely to rule out coarctation in a young person. This is the methodology which has been advocated by the International Society of Hypertension, how to measure the blood pressure accurately. The recommendation now is in favor of using electronic instruments and lesser mercury manometers. Make the person sit on a chair in a quiet room for about 5 minutes. He should have emptied his bladder and should not have smoked or taken coffee or exercise for at least half an hour prior. Once he is relaxed, tie the cuff appropriate for his arm, and then you press the button on the electronic instrument and you take 3 readings at 1 to 2 minute intervals, and the average of the 2 measurements should be considered as the blood pressure for the patient. Commonly, the cuff will cover 70 to 100% of the arm, and that is what is the appropriate cuff. Those who are already on treatment, particularly the elderly and the diabetics, you should rule out postural hypotension when you are treating the patient. So please record the pressure 1 minute and 3 minutes after standing up, because it is very important to make sure that the elderly man does not have a postural drop and he will have a fall and break his bones and have head injury. There are certain subsets. When you have a normotension, whether you measure at office or whether you measure at home, the pressures are going to be normal. Those who are hypertensive, again, office measurements and home measurements, you will have high blood pressure. So what is masked hypertension? Hypertension is no blood pressure rise in your office, but when you do the ambulatory blood pressure recording at home, you find the person is hypertensive. And the reverse is the state with the white coat hypertension, which gets detected in the clinic due to an anxiety that the person has. The pressure is high, but when you measure it on the ambulatory blood pressure at home, you find that the pressures are normal. Do not subject the patient to a long list of investigations. Look at this. These are recommendations not given by me. This is American College of Cardiology and the American Heart Association, recommending that you should check the glucose, blood count, lipid profile, serum creatinine, sodium, potassium, calcium, thyroid stimulating hormone, analysis of the urine, and an electrocardiogram. This is all what is recommended as a routine. Rarely we might ask for an echocardiogram and a uric acid and urine albumin to creatinine ratio. This is all what we need to do as a routine. Do not test for the secondary hypertension because it is really, really rare. This is a little busy slide. Now, how do we proceed to the treatment? You have a normal pressure, which is on the higher side. You have a grade 1 hypertension, grade 2 hypertension, grade 3 hypertension, as per the ESC and the European Society of Heart guidelines. Look at the second panel. All of them recommend lifestyle advice. The lifestyle advice should be vigorously pursued in all patients that we see. And we must give the patient an opportunity for at least about 3 months to control his pressure by lifestyle management rather than hurry with the drug therapy, except in the very severe hypertension where we will try to hurry up with the drug therapy in the Indian scenario. So what do the Indian guidelines say? The Indian guidelines say that you give only 3 to 4 weeks for lifestyle modification, because we see more malignant hypertension, more hypertensive heart damage and the brain damage. Therefore, give about 3 to 4 weeks for the lifestyle modification and then initiate pharmacotherapy if the blood pressure is high after 1 month. And the blood pressure be recorded in both the arms, in the lying down and the standing, before starting the therapy. And those who are stage 2, stage 3 hypertension, you can only give a short period of waiting and you start with the therapy so that you don't have the target organ damage. The cutoff point used is 140/90, but in the coronary artery disease and the heart failure, the cutoff is lowered to 130/80 by the Indian guidelines. So for the general population, I take the guidelines that 140/90 is a hypertension, but for the high risk population, that is the heart disease, the kidney disease, those who have the stroke or those who have associated problems like diabetes particularly and renal failure, etc., I would take the cutoff as 130/80 and start treating any patient above that. Now, coming on to the management of the patient of hypertension, you must take the body weight of the patient. And if the BMI is high or the body weight is high, you must encourage the patient by giving him repeated advice that he should reduce his body weight to normal and the BMI should come down to what is recommended, 23 and 24 for the females and the males. Go on a low-calorie diet. Reduce your dietary intake by 10 to 15%. So if you are eating 4 to 5 chapatis, you can reduce 1 chapati. Reduce the quantity of the dal, rice. If you are a non-vegetarian, please bank on the lean meat. Take more of fresh fruits and vegetables, particularly the yellow-colored fruits and vegetables like capsicums, carrots. Take more of the fruits. Take leafy vegetables. Avoid eating the fried fruits, fried food like chips, pasta, pizza, farsan, sweets, ice creams, chocolates. What about the oil? In a small quantity, 20 to 25 ml per day. Take the oils which are rich in the mufa and pufa. The recommended oils as per the Western literature is the olive oil, but our own oils, the sunflower, the curdy oil, and maybe the till oil, these can be good substitutes. Keep your ghee, butter, cheese, malai intake to the negligible or to the minimum. Important thing is to exercise regularly. A simple recommendation where you don't need any training is to give the patient an advice to walk 4 kilometers per day in 1 hour's time, or 15 minutes, 1 kilometer. If the person cannot walk 4 kilometers at a stretch, he can divide it into 2 portions, 2 kilometers in the morning and 2 kilometers in the evening. Those who can jog, those who can swim, 30 minutes of jogging or swimming or cycling. Playing games like cricket, badminton, table tennis, doing treadmill for about 20 minutes, stationary bicycle for 20 to 30 minutes, or simple thing. If you're staying in a multi-story tower, you can go at least 10 floors up and down twice. These are some simple measures of the exercise rather than going to the gym and doing exercise. Yoga, pranayam, meditation, our age-old 5,000-year-old practice, you must practice it for 30 minutes. In fact, those who don't have hypertension, they should also practice yoga, pranayam, meditation for 30 minutes. It is going to be very useful, make them physically fit, and a feeling of overall well-being. Tobacco in no form is good. In India, people eat tobacco, people chew tobacco, people sniff tobacco, and then, of course, smoke. No form of cigarette, whether e-cigarette, the regular cigarette, the imported cigarette, the chillam, the hookah, the pipe, all of them are dangerous because all of them contain tobacco. And tobacco is an enemy of the man. Not only it causes cardiovascular problems, it has many other hazards. Alcohol is certainly not recommended because alcohol has a direct relationship to hypertension. And also you tend to gain weight because of the empty calories. And the same story is with the carbonated waters. One drink of 200 ml of Thumbs Up, Pepsi, Colas, whatever you take, will give you straight 100 to 125 calories because it contains almost 25 grams of sugar in 200 ml. So therefore, drinking the aerated waters is also no good. Most important, please keep your salt intake to less than 5 grams or 1 teaspoon per day. Or in terms of sodium, it will be 2.3 grams sodium per day. Try to eat more fruits, fruit juices, so that your potassium remains higher. Anywhere between 60 to 100 milliequivalent should be the intake of the potassium. And I will show you how all these features are going to help the patients. And here is the chart. This is again given by the American College of Cardiology and American Heart Association, that if you comply with the weight loss, you benefit blood pressure by 5 millimeter reduction. If you take a DASH diet, that is the healthy diet rich in fruits, nuts, vegetable, whole grains, low fat dairy products, saturated fat is low, you can benefit as much as 10 millimeters. If you cut down on the sodium to 1500 milligrams, you benefit by 5 to 6 millimeters. If you enhance potassium, you benefit by 5. If you do all these together, doesn't mean you will get a 25 millimeter benefit. You are going to get a 10 to 12 millimeter benefit in your blood pressure control. So therefore, these are measures which we need to emphasize upon the patient. Every time he visits you, please literally hammer it into his head that he should lose weight, he should stop alcohol, he should go to a healthy diet, he should reduce his sodium, he should increase his potassium. All these are simple measures. Do regular exercise. This is going to be very helpful to you in the long term. Drug therapy, I shall not bore you too much with that because all of you all are experts, and we have been using drug therapy ever since it began in the 1950s and the 60s. But I wish to convey the message that use minimum drugs. We are in an era of long-acting drugs and combination pills. These help to reduce the pill burden and more compliance, and also the bill burden, so the compliance is better in the long term. I do not believe in using expensive new drugs because treatment of hypertension is going to be a long-standing treatment. What are we using these days commonly? Telmisartan, 20 to 40 milligrams, rarely 80 milligrams. Olmesartan, 10 to 20 milligrams, rarely 40 milligrams. But please make it a habit to check the creatinine and potassium periodically. Similarly, acting drugs are the ACE inhibitors like Ramipril, particularly the patients with the ischemic heart disease. A 2.5 to 5 milligram, go up to 10 milligrams, rarely even up to 20 milligrams. Same story repeats with the enalapril, and please have a check on the creatinine and the potassium. Cough may be nagging in 10 to 15%, leading to withdrawal of the drug. Sometimes loss of taste or angioedema may compel you to withdraw the ACE inhibitor. Calcium channel blockers, particularly preferred for the elderly, because it is a low renin hypertension in the elderly. The standard amlodipine 2.5 to 5 milligrams may be stepped up to 10 to 20 milligrams depending upon the need, and particularly the CRF patients may need a higher dose. The newer molecule is elnadepine, 8 milligrams to 16 milligrams once a day. And of course, you have the ifnodepine, etc., and all available for the treatment of hypertension. In the younger population, particularly with high heart rates or those with the ischemic heart disease, use of beta blocker becomes imperative. So if you have a thyroid patient, you have a young patient, you have an ischemic heart disease patient, use of beta blocker is very useful. What are the options? Metoprolol, atenolol, bisoprolol, and the newer ones like nebivolol. Use the smallest dose which will control the heart rate and add value to your antihypertensive treatment. You can use the diuretics, particularly as the second or the third line drug. And remember, The dosages that we are using do not cause electrolyte imbalance or metabolic disturbance. So chlorthalidone 6.25 to 12.5 milligram, hydrochlorothiazide 6.25 to 12.5 milligrams, and the indapamide SR 1.5 milligram, a truly metabolically neutral diuretic, which can be very safely given. A very mild diuretic causes sodium loss, gives you good blood pressure control as an add-on therapy to the other drugs. We also have certain drugs, the age-old drugs like clonidine, alpha-methyl-dopa, prazosin, which are sparingly used nowadays, except when you fail to achieve control with the regular 5 drugs that I have mentioned to you earlier. We may be called upon to use this once in a while. For a mild hypertension, you can start with 1 drug, but generally for the moderate, you will need 2 drugs. And there is enough data to show worldwide that 70% of the hypertensives need 2 or more drugs to get a good blood pressure control. What are the combinations which are very useful? ARBs with CCB, ARB with CCB with a diuretic, but don't forget the goal. 130/80 is the goal pressure to be reached. In resistant hypertension, we might go to 4 drugs, and it is better that you refer the patient to the specialist. Secondary hypertension, seen in less than 5%, commonest cause is renal failure or renovascular. What are the special situations you may have to treat? If you have a CRF patient, renal failure patient, and hypertension, you will avoid the use of ACE inhibitor and the ARB. I would use more of the calcium channel blocker, diuretics, and sometimes add minoxidil in 5 to 10 milligrams or up to 20 milligrams. If you are faced with a coronary artery disease and hypertension, use the ACE inhibitor beta blocker as the first choice. If not controlled, then add amlodipine. If you get cough with the ACE inhibitor, change over to the ARB. If you're dealing with a COPD, avoid a beta blocker. And the pregnancy is a real special situation that we need to have time-tested drugs like labetalol, hydrolazine, aldomet, calcium channel blockers, or beta blockers may be used. I have shown you the average dosages which are used in the pregnancy, and this demands a good control for the well-being of the mother and the child both. As a routine, all hypertensives must reduce their risk of coronary artery disease. So small doses of statins may have to be given, even though you might not have a rise in the lipid parameters on lipid profile testing. So I believe that a small like 10 to 20 milligrams of atorvastatin or a 5 to 10 milligram of rosuvastatin should be given as a routine. Home monitoring of the blood pressure, I recommend very strongly. I tell all my patients, please buy a digital instrument and you measure your blood pressure, even if you are stable, at least 3 times a week. Chart it out and send the WhatsApp to me so I can tell you what to continue, what to delete, what to add. If you find that the blood pressure control is difficult or the patient is non-compliant, doing an ambulatory 24 hours blood pressure monitoring is worthwhile to decide about the drug therapy. If the target is not reached with the 3 drugs, please take the opinion of the specialty people, which will help. This is nothing but whatever I have told you as a repetition from the European Society and the American societies, that you can use either ACE inhibitor, ARBs, calcium channel blockers, or diuretics at the first step. You can go to the second one in the second step, and you can go to a triple combination. Sometimes, when the resistant hypertension is seen, adding a small dose of spironolactone has been found to be very useful. Secondary hypertension should be considered, and we should look at it when you get resistant, sudden onset, particularly below 30 years, or a previously controlled blood pressure patient, his blood pressure goes out of control. One of the cause could be a renal artery stenosis or deteriorating renal function. Malignant hypertension, onset after the age of 65, or you have potassium wasting, then you should look for a secondary hypertension. Of course, this is a comprehensive list. We do not see it very commonly, and therefore I have charted it out as per the American recommendations, common causes and uncommon causes. Commonest is, of course, renoparenchymal and sometimes hyperaldosteronism, sleep apnea, and alcohol-induced hypertension. All the uncommon are really uncommon, which only need to be checked up in the specialty clinics for abnormal hormones or coarctation of aorta, etc. So when to refer the patient to a specialist? When the blood pressure is truly refractory, there is a secondary cause of hypertension suspected, patient does not tolerate many medications, or there is an end organ damage which requires more specialized care. Suppose the patient runs into a renal failure, I would need the help of a nephrologist. If the patient runs into a stroke issue, I would need the help of a neurologist. These are some recent things which are being tried out in the laboratories. They have not come to our clinical desk. Renal denervation being tried for the last 10 years, but so far it has not become a routine to use this. Carotid sinus activation, carotid body ablation, median nerve stimulation. These are all various modalities of approach to get the blood pressure under control, but they have not seen the light of the day so far. So friends, to summarize whatever I have spoken to you in the last 20 minutes or so, that commonly we have 5 classes of drugs to be used as the first line treatment. It includes ACE inhibitors, ARBs, calcium channel blockers, diuretics, beta blockers. Combination therapy is the order of the day. Long-acting drugs are the order of the day. Younger patients have more renin, therefore ACE inhibitors and ARBs are preferred and the beta blocker is preferred. Elderly people are more of low renin, therefore I prefer to use the diuretics and the calcium channel blockers as the first line therapy. Do not think that there is disagreement between the Europeans and the Americans. Ultimately, all of them want the pressure to come down to 130/80 or below. All guidelines are similar. The newer thresholds to diagnose the pressures, 130/80, are especially relevant to India in the high-risk population, particularly with diabetes and with cardiovascular disease. But yes, if you have an isolated hypertension, even in the Indians, I would take the cutoff as 140/90 if there are no other comorbidities. The aggressive blood pressure goals may be difficult to achieve in all Indians. The medical community must take a concerted effort to embrace these recommendations. Thank you very much for your patient hearing.
Thanks, Dr. Bansal, for that comprehensive review of a vast topic like hypertension. You covered almost all the topics relevant to the general practitioners and in their day-to-day practice. So there are a couple of questions in the chat box about, so again, people are confused whether to use mercury or electronic blood pressure instruments. That is one. Somebody is asking, what is the significance of uric acid in hypertension? And the last thing I want you to comment is the role of MRAs like aldactone in the treatment of hypertension.
Yes, good questions. I think each one demands a good answer to it. As far as the instrumentation is concerned, the world is going against the mercury. In the United States and Europe, majority of the centers have replaced the mercury manometers with the electronic instruments. And the documents which are released periodically by the American and the European Association, they are comprehensive documents on hypertension with the recommendations of almost 60-70 pages. There is only recommendation to use the electronic instrument which are validated by the associations. I'm not saying that the mercury manometer cannot be used, but since mercury is toxic to the human race, the use of mercury should go down, and we are getting some good companies In fact, in my practice, I recommend all the patients to buy the digital instruments. And at least I'm not a brand ambassador, but I would say companies like Omron, companies like Medilife, companies like Medtech, they are making standardized blood pressure instruments. If you make the patient sit quiet, tie the cuff properly, ask him to relax, and do the blood pressure measurements, you will find that they are fairly accurate. So I think that answers the question to the use of the type of the blood pressure instrument. The second question is this use of spironolactone, you said. The spironolactone, I use it as a fourth drug. I don't use it as a first drug. I always use either an ACE inhibitor, ARB, or a calcium channel blocker and diuretic. So between these three, we try to manage the blood pressure in at least 80 to 85% of the population. As I told you, if it's an ischemic heart or a young patient with a high resting heart rate, beta blockers are also to be recommended, particularly in the Indian scenario. It is only if I fail with this, then I believe that many a times a small dose of spironolactone to start with, like 25 milligrams, can be given to a patient, and if required, stepped up to 50 milligrams. There is a market preparation which I like very much. I will not use the name. It is available as 25 milligram furosemide with 50 milligrams of spironolactone. I tell the patient, you take half a tablet of that in the morning. It will serve the purpose of the diuretic, and it will be potassium sparing also. In fact, in my earlier slides, I showed you that having a little higher potassium, something in the range of 4.5, 4.8, below 5 milliequivalents, has a beneficial role in controlling hypertension. So either you take spironolactone or you consume adequate amounts of fruits and fruit juices and nariyal pani, which will keep your potassium adequate. So therefore, potassium sparing diuretic spironolactone is worth a try. But yes, check the creatinine, check the serum potassium before and after, so that you don't land up with a hyperkalemia situation, which will become a medical emergency. Can I have the third question repeated?
Yeah, about uric acid, role of
Yes.
uric acid.
It is a common practice amongst the family physicians to ask for uric acid. There are some variations from lab to lab. Some consider 6.8 as the cutoff, some consider 7 as the cutoff, some consider 7.2 as the cutoff. I generally don't treat the patients unless and until it is a value of 9 to 10. I'm not in a hurry to give a Febustat or something like that to reduce the uric acid if it is just 7.5 or 7.6, because we really don't know what is going to be the impact of this. The uric acid plays a very, very small role. You ask the patient, particularly if he's a non-vegetarian, to cut down on the non-vegetarian diet, hydrate himself adequately. He should be drinking plenty of liquids, and that itself will help the marginally raise uric acid to come down, rather than add one more molecule, which is pretty expensive. But yes, if the patient is symptomatic, he has had history of gouty arthritis, or he comes to you with the gout actually, then I would not hesitate in treating the patient with hyperuricemia. Yes, you are right. The question is very valid, that hyperuricemia is also one of the factors, a minor factor, when we evaluate a patient for coronary artery disease.
Good. Excellent, Dr. Bansal. Thank you very much. And just to add to what you said, please remember that all these trials are conducted on electronic BP instrument. All these recommendations are based on that. As Dr. Bansal said, the guidelines give you volumes, but they are based on that. So with that, we end his lecture, and I request the IMA to invite Dr. Ajit Menon for his lecture.
Thank you, Dr. Vitisha. I now request Dr. Sarita Devi, who is a member of IMA CGP's Mumbai subfaculty, to introduce Dr. Ajit Menon.
Yeah, good morning. Dr. Ajit Menon is an experienced interventional cardiologist with over 15 years of experience at various reputed hospitals in Mumbai. Apart from his extensive experience in all types of cardiac catheterization, he has also been involved in clinical trials and has several publications to his credit. Dr. Ajit Menon has performed around 10,000 coronary angiographies and angioplasties and currently performs around 15 to 20 angioplasties per week. He has performed independent permanent pacemaker implantation by cephalic vein approach and also performed cardiac catheterization. He has expertise with elements like abdominal aortic aneurysm, angina pectoris, arrhythmia, atherosclerosis, cardiomyopathy, coronary artery disease, heart failure, hypertension, myocardial infarction, and peripheral artery disease. Today, he will be speaking on pharmacoinvasive management of STEMI. Welcome to you, Dr. Ajit Menon.
Good morning, ma'am. Thank you very much, Dr. V.T. Shah, Dr. Anil Ahwad, Dr. Girish Lad, Dr. Deepesh Bhai. I'm not able to share my screen at the moment. Okay. I'm sorry, some reason I'm not.
Dr. Awad?
Yeah.
No, I'm sorry. I think it's my problem with my laptop.
Okay. Vitisha sir, please unmute yourself.
So can we go to the next lecture, Ajit, in the meantime?
I'm just joining. Give me a minute. Yeah, please go to the next lecture. Then I'll join after this, please.
Yeah. I think maybe we can go to Dr. Maulik Parekh. I saw him joining.
Dr. Maulik, are you ready with your presentation?
Yes, I'm very much ready. Thank you.
Yeah. Okay.
Shall we wait for 2 minutes if Dr. Menon can connect, or we should just go ahead? I'm okay with.
Just give me a minute. I will.
Yeah. No problem.
Let's just wait for 2 minutes.
Sure.
Only if I don't share, he will be able to try the sharing option.
Yeah. No problem.
Just wait. Let's just wait for 2-3 minutes.
Yeah. So I can see Dr. Narendra Bansal still there. Maybe he can take up one more question.
Sir, can you read the question? I'm sure he will answer.
Yeah, I think he's there, but maybe he's on mute. Dr. Bansal, so there is a question about doing renal artery Dopplers.
Yes.
So, but once upon a time, it was quite a big fashion to do renal artery Doppler in all patients of hypertension. So what's your take? Should you do at least an ultrasound or should you do renal artery Doppler?
Dr. V.T. Shah, you know that we as interventional cardiologists would like to put stents wherever required, if they are going to benefit the patient, of course. So there was an era about 15 to 20 years back that any person whose blood pressure was not controlled with 2 to 3 drugs, we were routinely asking renal artery Doppler. And I was also routinely doing renal angiograms in patients where coronary disease is suspected, and we were doing the coronary angiography on the way out, just take small renal shoots so as to pick up the renal artery stenosis. But after the availability of couple of trial data, that renal artery stenting does not really help the vast majority. and it is equivalent to a medical therapy controlled blood pressure. The mania for doing a renal artery stenting has died down. And if you do not want to do any invasive procedure, routine renal artery Doppler is not a must. But yes, I would still say it has got its own place. Difficult to control hypertension with 2 to 3 drugs. Patient is middle-aged, elderly, 50 plus. Atherosclerotic renal artery osteostenosis is fairly common. If you do the stenting where the gradients are more than 20 millimeters, the patient will stabilize his blood pressure. Hypertension will not go away. The eGFR will stabilize. There will be no renal deterioration. So from that point of view, very young patient below the age of 30 or above the age of 60, they get the hypertension detected for the first time or sudden worsening of hypertension, I would definitely go in for a renal artery Doppler because it is a simple test. And then if it shows something, maybe an invasive angiogram will be required.
Thank you, Dr. Bansal. I think
I can join. Yeah.
Yeah. So please go ahead.
Thank you very much. I'm sorry for the this thing. I was using another new laptop, so I had something wrong with it. So thank you very much to all the IMA members for this opportunity for me to talk today on something which is very dear to me, and that is a pharmacoinvasive approach in the management of ST elevation MI. What we need to realize is ST elevation MI is an emergency, and if it is not treated on time, you have major complications that arise not only in the short term but also in the long term. Our aim is to protect the muscle, and as we realize, the heart muscle is one muscle which does not give you time to play around with it. And once it is damaged, it never recovers. Whatever you try to do, that muscle is always dead. So what are the options when a patient comes with an ST elevation MI? One, of course, is primary angioplasty, which is, I fully agree, it's a gold standard for treatment. And it does form the backbone of therapy as far as ST elevation MI is concerned. But the question is, how many people in India can really have access to a primary angioplasty center? And how many patients can afford a primary angioplasty and a second procedure subsequently if the patient ends up with significant 2-vessel or 3-vessel disease? Therefore, fibrinolytic therapy has a major role to play in the Indian scenario. And it has always been there in terms of the management of heart disease and ST elevation MI. One, of course, has been you thrombolize a patient and subsequently do take them for an angiography to find out what are the lesions involved. And thereby, we have over the past so many years, we have generated many terms like an rescue angioplasty, an immediate or facilitated angioplasty, which is within 3 hours, a deferred PCI, which is after 24 hours, and now, which is something which is coming to the guidelines, is something called as pharmacoinvasive angioplasty, that is within 3 to 24 hours after thrombolysis. How do we combine the two strategies? One, of course, the pharmacoinvasive approach has been a major goal setter in this, where you have patients who undergo fibrinolysis and subsequently ship these patients to a center which is capable for doing an angioplasty, and thereby that the approach got its name as pharmacoinvasive, where you combine the pharmacological intervention along with an invasive approach. Rescue angioplasty, of course, is in patients who have failure of fibrinolysis. There's less than 50% resolution of the ST segment elevation in these patients after fibrinolysis, ongoing chest pain, hemodynamic compromise. Of course, you need to send these patients for an angiography and angioplasty as soon as possible. What is a pharmacoinvasive approach? It basically means that you first administer early fibrinolysis and then subsequently you perform an angiography in all of these patients, and then an angioplasty if needed in these patients within 3 to 24 hours after commencement of our fibrinolytic therapy, regardless of whether fibrinolysis results in successful reperfusion or not. In the event of a fibrinolytic failure, of course, you need to undergo a rescue PCI within as soon as possible, and there you do not wait for the initial 3-hour window. So this is extremely important in patients coming into non-PCI capable centers, or you come into a PCI capable center, but the cath lab is not available. In these patients, this is an extremely good way of treating these patients. Why is there so much stress in this approach? Basically because time is myocardium. For every 30 minutes delay in treatment of a STEMI patient, the 1-year mortality, mind you, increases by 7.5%.
The mortality benefit of primary angioplasty is lost if the delay for PCI exceeded 60 minutes. And practically, early fibrinolytic therapy can compensate for this delay in the angioplasty. This is a diagrammatic representation of how the mortality, the benefit of mortality reduction drastically reduces as the time passes. And if you do not treat within the first 60 minutes, there's the subsequent few minutes, of course, worsen the overall mortality and the benefits of myocardial salvage. What we are looking at is not only the survival of the patient, but also the extent of muscle that we can salvage when we treat these patients. What are the indications? It is appropriate for patients with ST elevation MI, where the transfer time from a non-PCI capable hospital to a PCI capable hospital is more than 30 minutes. We often see that patients are transferred, the transfer time is almost 60 minutes, 1 hour, 2 hours. It's always better to fibrinolyze these patients. Or the door to balloon time, which means the first medical contact to balloon time is more than 120 minutes, or the door to balloon time from the hospital where the patient comes to the balloon is 90 minutes. And that door, even when we talk about 90 minutes, it is the first hospital that the patient goes to. Or there's something called as a PCI related delay, where the door to balloon minus the door to needle time is more than 60 minutes. When I say door to needle time, the time that a person can get a needle in and can thrombolize the patient. If that delay is more than 60 minutes, thrombolize these patients and send them for a pharmacoinvasive approach. It's an optimal repercussion for a strategy for certain patients with ST elevation MI. Of course, there are going to be pros and cons. There's going to be a slightly increased risk of bleeding, there's slightly increased risk of thrombotic state. The cost marginally goes up because the cost of the thrombolytic agent also increases, puts up the cost. And of course, the stroke rates are important. The STEMI treatment guidelines do mention that primary angioplasty is the gold standard for treatment. But where this is not possible, you should fibrinolyze the patient as soon as possible, within 10 minutes if possible from the STEMI diagnosis, and along with antiplatelets and anticoagulants. That means use of low molecular heparins. And these patients subsequently can be transferred to a PCI capable hospital for subsequent therapy. This is a very, very smart diagram which shows that in the first 3 hours, primary PCI, if it is not possible, please thrombolize these patients. And the studies have shown that in the first 3 hours, fibrinolysis and primary PCI have very little to choose from. From 3 to 12 hours is the early phase of STEMI, where again, primary PCI is the gold standard therapy. But if it cannot be performed within 120 minutes of STEMI diagnosis, please fibrinolyze these patients. Subsequently, of course, the effect of thrombolysis does go down, and angioplasty does remain the mode of treatment in the first 12 to 48 hours if the patient still has ongoing symptoms, or if the patient becomes hemodynamically unstable. This is a very clear flow diagram which shows that there are certain patient-related delays in terms of the patient delay and the EMS delay. But once the patient is diagnosed, the total ischemic time should be kept as low as possible. And if you cannot maintain that less than 120-minute strategy, please, again, these patients can be fibrinolyzed, and subsequently they can undergo a reperfusion with an angiography and angioplasty. This is another the target times that can be achieved. Again, the goal is less than 120 minutes. And mind you, this is the first medical contact. The first time, even if a general practitioner goes home to do an ECG, that is the first medical contact. From there to when the patient has a wire across the coronary artery and a balloon and some flow is established, that is the time taken as door to balloon time. Various studies have been done in the past regarding pre-hospital fibrinolysis and in-hospital fibrinolysis. Most of them have shown that patients who receive pre-hospital fibrinolysis had better outcomes in terms of death or recurrent MIs. And another factor that needs to be taken into account is not only the perfusion that they see on a coronary artery. You see that the artery is open, the artery is flowing very well, but the tissue perfusion, the blush on the myocardium, which is extremely important because that determines whether the muscle is getting the flow or not. Just having an open artery does not mean anything. It just means a cosmetically open artery. The tissue perfusion grade should be grade 3, and that is something which we can grade when we do an angiogram. And unless the tissue myocardial perfusion grade is grade 3, you have not achieved what you have set out to achieve. And there, pharmacoinvasive has proven to be better than primary angioplasty. Again, there have been the various studies which showed that thrombolysis plus early routine PCI showed results similar to primary PCI, equivalent in terms of preserving myocardial function, and higher frequency and earlier myocardial perfusion was seen in these patients. The transfer AMI was a landmark study which compared the outcome of pharmacoinvasive strategy with standard treatment for high-risk STEMI patients receiving thrombolysis at non-STEMI centers. And this is the general flow diagram of how these patients were treated. What it ensured is that in terms of the pharmacoinvasive strategy, it showed that they had significantly fewer ischemic complications compared to standard treatment of thrombolizing the patient and then taking for a late treatment or primary angioplasty. And secondary outcomes in terms of bleeding complications and efficacy, as death or reinfarction at 6 months, there were no significant differences seen in either of these two groups. What is the Indian scenario? What about the Indian scenario as far as STEMI is concerned? We know that STEMI is rising exponentially as far as India is concerned, and we expect that nearly 3 million STEMI patients are there in India per year. And despite advancement in reperfusion therapy, the overall utilization, system of care, and timely reperfusion remains drastically suboptimal. Primary PCI is available to less than 10% of patients in India. Why? Lack of awareness, lack of transfer facility, casualty to the cath lab. Then you have finance issues, obtaining consent. Obtaining consent is a major issue because they take 10-15 minutes to get a consent. They have to ask different people. They have to take. I mean, what do we realize is that is time lost in the cath lab. And of course, the only way that we can do that is patient awareness and education for early symptom identification, and education for physicians. And of course, PCI is a gold standard, but remains inaccessible to a majority of patients. Most of the complete data about contemporary trends in STEMI patients comes from two registries. One is the CREATE registry, and the second is the Kerala ACS registry. The CREATE registry is a registry from 10 regions, 50 cities across India. The Kerala registry of 25,000 patients from in 2007 to 2009 in 125 hospitals in Kerala. What do the CREATE registry show? Look at this. The median time of for arrival to hospital symptom onset in India is almost 300 minutes. Fibrinolytic therapy was in 59% of the patients, and primary PCI in 9% of the patients. In the Kerala registry showed that inappropriate thrombolysis happened even in ACS patients, patients who did not have STEMI. And out of those who had STEMI, thrombolytics were only used in 41% of the STEMI patients. A lot of patients did not get the care that they needed as far as the treatment, the standard of care is concerned in ST elevation MIs. So this is a major study, which is, I'm going to quote a study from my colleague in Chennai, who studied the pharmacoinvasive management based on the fact that less than 10% of STEMI patients had PCI. And this was a multi-center study in 5 hospitals in Tamil Nadu. The primary objective being to assess the efficacy of prompt fibrinolysis coupled with contemporary antiplatelet and antithrombotic therapy at first medical contact, followed by timely catheterization or rescue intervention in STEMI within 12 hours of symptom onset. Secondary objective, of course, was to monitor the emergent adverse effects. This is the 5 hospitals. There were 2 groups who were either underwent thrombolysis with PCI and another group which underwent primary angioplasty. And this is the flow chart that was seen. Primary endpoints: death, reinfarction, repeat revascularization, congestive heart failure. And secondary endpoints, what we're more bothered about, TIMI major bleeding. I will not explain this chart. This is a general scene of all these patients who underwent the procedures. We had 45 patients in group A, 155 patients in group B. The infarct-related artery patency, which we were more bothered about, as the artery was more open in these thrombolized patients. Successful thrombolysis was seen in almost 82% of patients. Primary PCI, of course, had a smaller number, but then that is expected. If you look at the results in terms of what we call as the TIMI flow post-procedure, significant improvements in TIMI flow in both the groups. There was no major change in the TIMI flow. That means the extent of flow on the coronary arteries, whether you thrombolize the patient or you underwent a primary angioplasty. Bleeding complications, no significant change in bleeding complications in either of these two groups, because most of the procedures were done radially. This is the paper presented in the BMJ, and there was a 2-year follow-up on the STEP AMI study, which basically studied the endpoints at the end of 2 years. And mind you, look at the endpoints. No significant differences in the overall endpoints, and also in singular endpoints of death and death reinfarction. There was no major change in the two groups, even at 2 years. Historically, various studies have shown that fibrinolysis of primary PCI in ST elevation have reasonably good results in both these groups. And this is a paper presented in 2013, which showed that pharmacoinvasive strategy may successfully alleviate the logistical and geographical barriers of primary PCI in the treatment of AMI. The Tamil Nadu STEMI project is a very important and very landmark project which is done by our colleagues in Chennai, Dr. Ajit Mulasari and Dr. Thomas Alexander. It was a study of a hub and spoke model of primary angioplasty, where there was multiple hubs within some major cities, and there were different spokes from rural areas. So these patients were thrombolized and then transferred to the hub centers, and this was a landmark protocol, which showed that thrombolysis still today is makes up for a large part of patients, and streptokinase is still used in a majority of patients in rural India. And that is where a majority of populations stay. We look at only Bombay, but if you look at the major populations, they still have a lot of issues. In terms of in-hospital MACE based upon interventions, no significant difference in when they were thrombolized and taken for angioplasty as compared to primary angioplasty. If you look at a sub-study of this thing also, the TIMI3 flows, there is good flows in the coronaries, was seen in most of these, in most of the thrombolized patients also. Well, what does literature tell us about pharmacoinvasive strategy? This was in the Circle of Cardiovascular Interventions. ST elevation MI receiving pharmacoinvasive treatment compared to primary angioplasty has shorter time to reperfusion, higher culprit vessel patency, and similar to 12-month clinical outcomes. Another paper, which is presented in an abstract, quoting an abstract from this, basically showed that primary pharmacoinvasive approach is equivalent to a PCI strategy with no major bleeding risks, no major stroke rates, differences in this population. This was an editorial comment where even in major centers, 40 to 75% of the patients transferred from a non-PCI center were not treated within the guideline recommended treatment time of 120 minutes. We often see patients waiting in the cath lab for a primary angioplasty, and the cath lab is busy, and almost 1.5 hours to 2 hours is lost in shifting the patient for a so-called primary angioplasty. Again, another editorial comment, which basically showed that there was a significant efficacy of using a half-dose alteplase versus primary angioplasty in ST elevation myocardial infarction. This is from a Korean group, over 344 patients, which basically said that there were no significant differences in the frequency of individual components of the primary endpoint. There is another editorial, which was basically, we are looking at recalibrating reperfusion waypoints. And there, the point is that we should treat these patients and look at trying to open the artery as soon as possible, whether it is fibrinolytic or whether it is by primary angioplasty. Do not wait for an angioplasty. Do not lose time for an angioplasty. If you cannot do it, thrombolize a patient and then do the procedure within the next 3 to 24 hours. There are various questions which come in when we look at a pharmacoinvasive approach. We still have majorly look at community interventions across international borders and also in the Indian subpopulation as to which would be the most effective pre-hospital utilization of these drugs. The FAST AMI program also came out with the 5-year outcomes, which showed that even at 5 years, patients who had timely primary angioplasty, that is less than 120 minutes from the first medical contact, did well, but otherwise, late primary angioplasty, more than 120 minutes, did worse than intravenous fibrinolysis. So, mind you, this is a 5-year follow-up of the FAST AMI trial. So if I were to conclude this talk, I would say that pharmacoinvasive strategy is as good as primary angioplasty in a majorly low-risk population. It widens the time window for coronary angiography, logistically easier to accomplish during, especially off-duty hours, ideal strategy in India because transportation times can be long in India. Cath labs are located in metros, not in this in smaller cities, in smaller towns. Of course, that is not that may change over the next few years. And primary angioplasty is superior to for high risk angioplasty, high risk AMI, or patients who can undergo primary angioplasty. Mind you, within 120 minutes of first medical contact. Thank you very much, and I'm open to questions.
Thanks, Ajit, for that review of pharmacoinvasive and the importance in practice, especially in a country like India, where, as you said, less than 10% of STEMIs get PAMI. Now, a couple of questions to you. The first is regarding symptom onset to first medical contact. How important is it in our practice? Because patients, as you know, their level of awareness and by the time they contact the first medical person. Then the other question which is commonly asked by a physician is by a general practitioner is, can we give this fibrinolytic therapy at home or in ambulance?
Good questions, because basically I'll come to the first question first. In terms of the onset of symptoms to first medical contact, that is something which is beyond our control. Patients need, and unless there is a vast patient education program which makes the patient understand that these symptoms are cardiac and they need to get to a hospital first, is something which is extremely important. The second thing that I can advise is that any patient calls up a physician with symptoms which may sound cardiac, may sound like acidity. It's always good to get an ECG done and rule out a cardiac event rather than waiting with antacids and saying that wait for 2 hours, wait for 3 hours, we'll repeat another ECG. It's always better to get a timely ECG done, which may help in differentiating the symptoms. But otherwise, that is something which is beyond our contact. All we can do is from first medical contact to treatment is something which is in our control. And whether we have access to an angioplasty center or we don't have access, we have both modes of treatment available. The second, what is the second question, sir? You're muted. You're muted, Dr. Vidisha. So you're muted.
Yeah. Whether a general practitioner can give fibrinolytic therapy at home, clinic, or ambulance?
We still don't have any guidelines on that. We had tried to get these guidelines in place, but we have not met with any success as far as getting guidelines and treating patients in the clinic is concerned. So it's always better to take the patient to at least a medical center which has medical facilities, an ICU, and of course a defibrillator when we thrombolize these patients. To date, we do not have any guidelines on treating these patients in a clinic, though that is something which, if it happens, it'll be a fantastic thing, because we know that with the use of the newer drugs, the short-acting drugs, like tenecteplase, the side effects are very low. Complication rates are very low. Of course, primary VT is a challenge, so everyone should have an AIC and an ICD in their clinic.
So the last question is, do you recommend now that general physicians should have ECG machines with them, and with WhatsApp and all this available digital media, you can always get opinions of physicians and cardiologists on the ECG?
That is how the Tamil Nadu STEMI project works, where the physician takes an ECG and transmits the ECG to the hub. And there is there they treat the patients based upon the ECG. The guideline, the doctor there in the center is advised as to how to go about treating these patients, and that is an extremely effective way if we can implement it. Even in Bombay, if someone can take up the project and implement the project, that will be a great thing to do in terms of saving lives and saving muscle.
Absolutely. Thank you very much, Ajit, for your enlightening lecture. I hope all the attendees enjoyed that, and thank you very much. So may I request Dr. Awad now to announce the next speaker?
Yes. After that very enlightening talk from Dr. Ajit Menon, we have a very young and handsome cardiologist, Dr. Maulik Parikh, and I request Dr. Kajal Ahuja, who is the Assistant Secretary, IMA CGP Mumbai Sub-Faculty, to introduce Dr. Maulik.
Dr. Maulik Parekh is a consultant in the Department of Cardiology at Sir H.N. Reliance Foundation Hospital and Research Center. After completing his MD General Medicine with first rank, he did DNB Cardiology at the PD Hinduja National Hospital, Mumbai. He has trained at the reputed Göttingen Georgi Hungarian Institute of Cardiology, Budapest, as the postdoctoral fellow in transcatheter valve therapies and structural heart interventions. He has performed more than 200 TAVR and is proctor of TAVR. He is also trained and certified for other structural heart interventions like mitral clip, PFO closures, AST closure, left atrial appendage closure, etc. He has performed more than 2,000 diagnostic coronary angiographies and more than 1,000 angioplasties. He is well trained in implantation of single and dual chamber pacemakers and ICDs. He is the founder member of Indian Academy of Echocardiography and is well trained in basic and advanced echocardiography, including contrast echocardiography, speckle tracking 3D echocardiography, and transesophageal echocardiography. Today, he'll be talking on valve replacement without open heart surgery, TAVR, and beyond. Over to Dr. Maulik Parekh.
Just sharing. Am I audible?
Yes, yes.
Okay. Can you see my slides, sir?
Yes.
Okay. Thank you very much. So I thank IMA Mumbai and thank you, Dr. VT Shah, sir, and thank you all the delegates for attending this session and inviting me to talk on this World Heart Day CME on IMA platform. So my topic today is non-surgical valve replacement, TAVR, TMVR, and beyond. So I always start my slide with this photograph of my institute in Budapest, where I trained, and also with my mentors in the left bottom corner, under whom I trained. So also, when we talk about any new therapy, we should look at the history of mankind, that evolution, as per the Charles Darwin theory, is the rule. Once there is evolution, there will be refinement, right from just covering the stones to the bikes, just rounding the edges of the stones to bikes. This is the New York City, which was there in early 1800, full of traffic with horse carts and everything. But at the end of the day, the roads were full of horse shit. So there was an urban planning conference, which was done in 1898, which said that if the same level of horse carts continued and same level of horse shit accumulation continued, by 1930, a horse maneuver would reach the level of Manhattan's third-story windows. So what would you want? Then came the groundbreaking innovation, the motor car. And Henry Ford, who invented the motor car, once said that if I had asked people then what they wanted, they would have wanted faster horses. But no, it doesn't work that way. You have to have a groundbreaking innovation. So this is the Manhattan of early 1900, and this is the Manhattan of today. The world is moving so fast these days that the man who says it can't be done is generally interrupted by somebody already doing it. So now let's talk about evolution, refinement, and innovation in the treatment of valvular heart diseases. So this is a CT scan of a person. So we all know this valve is a metallic valve, a caged wall valve, Carpentier-Edwards valve. So now this is the first valve that was first invented to offer to a patient who had aortic stenosis. And this is on the right side, is a CT scan of an 83-year-old man with this Starr-Edwards valve, which was implanted 33 years ago and still working completely fine. So after this, so this was the evolution. Then came the refinement, various types of mechanical valves, which had smaller profile, better performance, longer life. And then came the various types of bioprosthetic valves, the tissue valves, because metal valves have their own problems, and you will have to continue with blood thinners and anticoagulation, warfarin, and a lot of other issues. So then came the tissue valves, which were found to be very good for people who are
old, who are more than 55, 60 years of age, because these tissue valves have a problem of degeneration. That means they're in 10 years, 15 years, they will degenerate. So this was the refinement in the technology of aortic valve, or rather valve replacements. And then came the groundbreaking innovation, transcatheter valve replacement, or valve replacement without surgery. So I will talk about aortic stenosis first, because aortic stenosis is the commonest disease that we see in day-to-day life. As the life expectancy is increasing, the degenerative or senile aortic stenosis is increasing in frequency. So we all know the normal aortic valve area is 3 to 4 centimeters square, and narrowing of the aortic orifice is called aortic stenosis. It can be of various etiology, that is congenitally abnormal bicuspid aortic valve, senile degenerative or calcified valve, or rheumatic heart disease. In our population, rheumatic heart disease is also very common. However, isolated involvement of the aortic valve in rheumatic heart disease is very uncommon. It is almost always associated with mitral valve disease. Then comes bicuspid aortic valve. So bicuspid aortic valve is very common in our country and Asian population compared to Western population. Almost 30 to 35% of our normal population have bicuspid aortic valve. These valves are likely to degenerate faster. So patients with bicuspid aortic stenosis would present with aortic stenosis much earlier, that is in 50s and 60s, compared to a normal tri-leaflet valve, which gets degenerated in late 70s and 80s. Bicuspid aortic valve is often associated with abnormalities like coarctation of aorta and dilated ascending aorta. Then degenerated or calcified aortic stenosis. I will just hide the. Okay, degenerated or calcific aortic stenosis, which is common in elderly population beyond the 65 years of age. So according to an estimate, 25% of patients with age more than 65 years have some evidence of echocardiographic aortic stenosis, mild, moderate, severe. And so out of this 25% people, 10 to 20% of these people will develop severe aortic stenosis. So imagine the size of the population and the size of the problem. As the life expectancy is increasing, aortic stenosis is going to become a larger and larger problem. And 30% of these patients who have degenerated aortic stenosis also have coronary artery disease. Okay, yeah. So this is aortic stenosis of the rheumatic origin. So now I want to just say why aortic stenosis is so important and why it is so much of a problem. Because when you have aortic stenosis, there is LV outflow obstruction. That means LV is not able to eject all its content into the aorta. When this happens with LV outflow obstruction, left ventricular systolic pressure increases. So LV has to contract more vigorously to get rid of the obstruction and empty out its content into the aorta. This causes left ventricular hypertrophy, and this left ventricular hypertrophy in long term causes left ventricular dysfunction. Also, along with increasing the pressure in the LV, as we know, the cardiac cycle is systole and diastole. The amount of systole, the duration of systole also increases. That means increase in the left ventricular ejection times, because LV takes more time to empty out its blood content into the aorta and into the system circulation. So the combination of the two, that means higher pressure, that means LV has to pump more forcibly and for a longer time. The combination of these two results in increased myocardial consumption, increased demand for blood, or increased myocardial oxygen demand. So this is the increased demand. But on the other hand, cardiac cycle is relatively fixed. As the duration of systole increases, duration of diastole shortens. And as we all know, coronaries get their blood in diastole. So on one hand, you have increased demand. On the other hand, you have decreased supply from coronary arteries because diastole is shorter now and coronaries receive blood during diastole. So this is a mismatch. Both of them together result in myocardial ischemia, left ventricular dysfunction, and ultimately left ventricular failure. And that's why this is the pathogenesis or pathophysiology of aortic stenosis and why it is so important. We all know the symptoms: exertional dyspnea, angina, syncope or blackouts, heart failure, and in some patients sudden cardiac death. On physical examination, I will not go into too much of detail, but what is important is we pick up a murmur, which is the most important finding in aortic stenosis, ejection systolic murmur, which is heard at the left and lower left upper sternal border. ECG is not very characteristic. It may just show left ventricular hypertrophy changes. X-ray also is not of very good use. The main important investigation is echocardiography for diagnosis of aortic stenosis. It will tell you about the etiology. That means whether it is bicuspid aortic stenosis, whether it is rheumatic, whether it is age-related degenerative changes, how severe it is, mild, moderate, severe, associated lesions, whether there is any aortic regurgitation, whether there are any other valves involved, LV function. It will tell you about what is the heart ejection fraction, and it will tell you about the ascending aorta and arch. So echocardiography is one most important investigation which will tell you about etiology, severity, and guide you towards further management. So TAVR, transcatheter aortic valve replacement, where we replace the aortic valve without open, till recently, till last few years, valve replacement means open heart surgery. It is no longer true. Now we have multiple valves which are crimped or miniaturized on a tube, which is 5 to 6 millimeter thick, inserted to the groin femoral artery like an angioplasty catheter. The valves are positioned in the cath lab in the aorta and opened. So these are the various platforms that are available for TAVR valves. The left side is the Evolute, which is a self-expanding nitinol valve, and the right side are the balloon expandable valves. We have various others also in the pipeline, which are being developed or already in the market. So this is just a small 1 minute video in what is aortic stenosis and how the TAVR is done. So this is the aortic valve which with age develops degenerative changes, calcification, and narrowed opening. So this is what happens with aortic stenosis. Now, what we do in TAVR is through a right femoral, most likely it's a femoral procedure from the femoral artery. However, we can also do it from subclavian or direct aortic or LVL also. So from the femoral artery, we take a puncture, put in a small catheter, which goes from the abdominal aorta, descending thoracic aorta, across the aortic arch into the aortic valve, across the aortic valve into the LV, and go there, position the valve. You can recapture and reposition the valve if you don't like the first position. All this is happening under local anesthesia. Patient is completely conscious. Typical duration of the procedure is 1 to 1.5 hours. And the new valve is deployed. And once you are happy with the position and performance of the valve, it is released. So now a patient who had a degenerated or severe aortic stenosis has a completely new valve without any open heart surgery. So this is the typical TAVR or TAVI procedure. Any new procedure takes time for its approval. When this procedure was very new in the Western countries, it was only approved for those patients who were having aortic stenosis but very high risk to undergo open heart surgery. Then the experience increased, the valves became more and more crossable, more and more thin, more and more better performing valves, and new approval came for intermediate risk. That means for those patients who have aortic stenosis but are not very high risk for surgery, for open heart surgery, but intermediate risk for open heart surgery. Even for them, this TAVR procedure was approved. And recently in August 2019, for everybody, that means low risk, any patient who has aortic stenosis and is a candidate for a tissue valve, I will come to that later, this procedure was approved, even if it is a low risk patient for open heart surgery. I would go here with a small caveat that it is indicated in patients who are at least 65 years or above as per SCCH guidelines, valve guidelines. For younger patients, it is usually not recommended because this valve will ultimately is a tissue valve. It will degenerate in 10 years, 15 years time, and patient may require one more procedure. So in 2020 or 2021, who all can get a TAVR done? high, intermediate, or low surgical risk patients. Calcified aorta, patients who have calcification in the aorta, they are, for them, the open heart surgery is difficult because risk of stroke is extremely high. Chest deformity, anybody who has undergone previous chest or breast cancer radiotherapy, previous open heart surgery, and now has aortic stenosis, so one more redo surgery will be required. Anybody who is very frail or small aortic annulus, where surgeons can put a very small valve, but with TAVR we can put a larger valve. COPD, previous open heart surgery. A patient who has undergone aortic stenosis surgery earlier has a tissue valve put before earlier with surgery, and in 10-15 years that valve is degenerated. So now, rather than doing an open heart surgery again, you can do a valve-in-valve TAVR. So almost everyone. But there are patients for whom TAVR is not indicated, and you can do a surgical aortic valve replacement or a SAVR. When there is a CABG with AVR recommended, when there are double valve replacement recommended, when there is severe AR, not AS, when there is infective endocarditis, a younger patient, and unsuitable TAVI anatomy. So I'll just show you a couple of cases. It's an 84-year gentleman, has diabetes, COPD, severe calcified aortic stenosis. So this is a basic root aortogram which we take. This shows the aortic valve which is not opening well. This is the done from left femoral artery. So this is the sheath that goes across the large 14 French sheath. So this is the aortic valve which is crimped on a balloon which is being crossed across the aortic arch. This is still not open. This has gone through that 14 French sheath from the groin. Then we position the valve across the aortic valve, take injections, and then under rapid ventricular pacing of 180 beats per minute, we open the new valve, which is mounted on a balloon. This whole procedure is done under local anesthesia without any general anesthesia. So this is the new valve which is deployed, and this is the final picture which shows beautifully deployed new valve, no leakage, and well-functioning valve. And the patient, most important, patient goes home 48 hours after the TAVR. Another subset of patient, because we have rheumatic heart disease, which is very common in our country. So a patient who's undergone previous mitral BMV, after BMV has undergone mitral valve replacement. After replacement has undergone one more mitral valve replacement because the first valve got bad. So now this patient has undergone already 2 open heart surgeries. And now at 70 years, she's developed aortic stenosis. So you can't do a third open heart surgery. Rather, you can offer her a therapy called TAVR. So in this angiogram, you can see the pigtail in the aortic root, aortic valve. And if you see very carefully, you can see the metal mitral valve, the leaflet discs moving up and down. So first we dilate the valve and then we put in a new valve. The first one was a Merrill Indian My valve. This is a Medtronic Evolute valve, which is a self-expanding platform. You deploy the valve, then you post, if you need to post dilate the valve, you can put a balloon inside the new valve and again open it. And this is the final picture, which shows a very well functioning aortic valve without any leakage and a metal valve also in the mitral position. I will skip this case, which we had done on a very sick patient who was on ventilator, no cardiac output, had a previously implanted tissue surgical valve in aortic position, which had got completely dysfunctional. Patient came in cardiogenic shock, and we did the TAVR, rather an emergency TAVR, within 3 hours of patient consent at HN Reliance Hospital. Dr. Anvay Mule, myself, Dr. Ajit Menon, Dr. Mashru, we were the team for the case. And you can see the gradients before and after, and improvement in the hemodynamic parameters after. Patient was on 3 inotropes. All the inotropes stopped immediately on table after the TAVR. He was on dialysis. The urine output started coming within 24 hours of the TAVR. And on 7th day, patient was discharged from the hospital. And this was a very important media story, because a patient who came in cardiogenic shock on ventilator without urine output with multiple inotropes went home without an open heart surgery. So this is about aortic valve. Then comes mitral valve. So even mitral, our country is a country of rheumatic heart disease. Now we have a lot of patients who undergone previous mitral valve surgeries. So can you replace a native mitral valve with a TAVI? with a catheter? No, not yet. But a patient who has a previously implanted ring for a mitral regurgitation, or a previously implanted tissue valve in the mitral position, and that valve has dysfunctional after a few years, you can do a mitral valve in valve TAVR, or transcatheter mitral valve replacement, TMVR. So for that, it is very important that you have to do a transesophageal echo. On echo, you can here clearly see a tissue valve which is completely dysfunctional. You can see the valve here, which is not opening. And what is important is you do a 3D transesophageal echo. On 3D, you can see you are looking from the LA, you are looking across the mitral valve. See this is the suture ring of the previous valve, and the tissue leaflets are just not opening here. So this is the pre-procedure imaging. Then procedure-wise, under transesophageal guidance. So this is the valve. This is the old valve you can see here. You do a transseptal puncture on the transesophageal echo guidance. Then put a deflectable sheath from RA into LA across the transseptal puncture and across the valve into the LV. Dilate the septal puncture site. So you dilate an intraepithelial septal puncture site with a balloon. This is the TAVI valve, TMVR valve, the same valve as TAVI valve, just crimped or mounted in a reverse direction. So this valve is going across the septum into the old valve. This is how you position and open the valve inside the old valve. So patient has an old tissue valve, which is got a restenosed, and now we are putting a valve in valve TMVR. And you open under a very nice 200 beats per minute rapid ventricular pacing, very slowly, because valve can move from its position. You open the new valve. And this is how it looks after the deployment, a valve in valve TMVR. And this is the final picture here. See the beautifully opening valve and very nice flow without any stenosis in the new valve. And this is the 3D picture with nicely opening leaflets of the valve in valve transcatheter mitral valve replacement. So this is the transcatheter mitral valve replacement after aortic. Then MitraClip. My colleague and my dear friend Nihar Mehta is going to talk about this in the next session. So I will not go in the details of this therapy. So it's a clip for mitral regurgitation. Here also 3D echo is very important, but I will not go into this. Nihar will talk about this. And this was the first cases done in Western India by us. Then comes Melody valve, which is for pulmonary valve. A patient who was a congenital heart disease patient, RVOT obstruction, TOF, who has undergone previous surgery, has a conduit placed in the pulmonary artery, and or a valve placed in the pulmonary across the pulmonary valve, has undergone already 2-3 surgeries before, and now you can offer them transcatheter, that means from the groin, pulmonary valve replacement. Imagine these patients who are young, who have already suffered a lot, who have undergone 2, 3, 4 open heart surgeries since childhood. And Dr. Bharat Dalvi I and Dr. Bharat Dalvi, we do these cases at HN Reliance Foundation Hospital. We are the only center in the city which does this procedure. So this is a mitral and the pulmonary valve, Melody valve, which is being implanted, and this is the final picture of an implanted pulmonary valve. I'm sure Dr. Dalvi will be the right person to talk on this as well, because we are together on this. Also, the same pulmonary valve we had implanted in a 76-year lady. It was a news story because it was the oldest patient in the world who has undergone the pulmonary valve replacement. So now, at the end of my topic, there are various transcatheter valves available for aortic, mitral, pulmonary, and tricuspid. Many are available in India, many are in the pipeline, but going forward, valve replacement without surgery is a reality. Although it is not for everyone, surgery is still the first choice for many situations. And this is the real slide which I want to show. Thank you very much. And I will take just 5 seconds more. Today, we are launching our Center of Excellence for Valve Diseases at H.N. Reliance Foundation Hospital, which is our valve clinic. We are already a leading center in the city and in the Western region who are doing maximum number of transcatheter valve procedures. We have the best infrastructure in terms of a hybrid OR or hybrid cath lab, which is dedicated for such kind of procedures. And we look forward for your support. Thank you very much. And I'm open to questions. Stop sharing.
Thanks, Maulik, for that overview of the tower procedures and transvalvular procedures which you showed us. Just would like you to emphasize again for the general practitioners, what would be the symptoms or the use of stethoscope? Because in today's world, many people don't use stethoscopes in Corona era. So can you emphasize what symptoms or signs they could look for so that they can pick up the cases suitable for valves? Yes. And also emphasize low blood pressure in aortic stenosis. You know, sometimes patients have just 80, 90 systolic, moving around, dizziness, giddiness, fatigue, and people think that this is just because of either dehydration, low salt, or physical build. So can you just emphasize on that, and then I'll ask you the next question.
Okay, sir. So, sir, yes, very important to identify. All these options come after identifying the problem. So, diagnosis is very important. Most important is symptoms and physical examination. Aortic stenosis is, I think, one problem which can be just picked up on purely clinical background. I mean, you can send a patient to echocardiographer saying that the patient has aortic stenosis, you know. So one is angina, chest discomfort. It could be, but whenever angina is associated with undue fatigue, undue tiredness, and blackouts, you should always suspect aortic stenosis. Although we say that breathlessness comes very late in the aortic stenosis, but that is only in burnt out LVs. Even in early presentation, we see fatigue and some amount of breathlessness in aortic stenosis. And the use of stethoscope, ejection systolic or a mid-systolic murmur, ejection systolic murmur, that when you put a stethoscope at the left upper sternal border, put the patient in a sitting position and ask the patient to hold the breath at the end of expiration. This is how you auscultate a murmur of aortic stenosis. So if you hear a systolic murmur there, then there are very few, and that too is an elderly patient. There are very few differential diagnoses. One is a mitral regurgitation, and second is aortic stenosis. The next thing that you should do is ask the patient to hold the breath and put the stethoscope on the carotids. If you are hearing the same murmur in the carotids, it is aortic stenosis. If you are not hearing the same murmur in carotids, it is not aortic stenosis, it is mitral regurgitation. So there are other differences like VSD and all, but they are very rare and not seen in elderly population. So I think this is the most important clinical parameters you should look for, sir.
Yeah, the next and the most important question is the cost between the tower procedures and the surgical procedures.
Yes, yes.
So how do we justify such a big difference?
Yeah, so an open heart procedure today in a good tertiary care setup, I would like to compare the open heart procedure of a tertiary care setup versus TAVR. So an open heart procedure today with a good quality tissue valve, the valve itself, the open heart tissue valve is also 2 to 2.5 lakh of rupees. So the open heart surgery with a good quality tissue valve is going to cost you 7 to 8 lakh rupees in a good center anyway. Cost of TAVR today ranging from almost 15 lakhs to 25 lakhs because we have various types of valves in the market, various platforms. So the difference that earlier 25 lakhs and 5 lakhs has now come to 7 to 8 lakhs and 15 lakhs. So difference is not more. It is a high cost therapy, but the benefits, if you see patient in and out of the hospital in 48 hours, no sternotomy, no general anesthesia, quick recovery and back to routine, because we see many of these patients are active patients. You don't want them downtime of 4 weeks, 6 weeks.
And do you think that the cost will come down in the passage
Oh, yes,
of time?
It will. There are various more valves coming in the market. And as we have seen with the stents, sir, I mean, who else can, other than you and Dr. Menon and all, can throw light upon this? The way stents, the more and more popular they became, lower and lower cost it has now. Similar, I think, trends will follow for even TAVR and other mitral valve procedures also.
And what about long-term prognosis for these patients? I mean, any complications of putting a TAVR in terms of one question which people ask generally when they see this procedure which you were showing: can the valve slip when you are inflating and the contractions of the heart is there? Whether the
risk of slipping of valve, or in medical language we call it embolization, during the deployment, is documented risk is less than 1 in 500. And that's why it's very important to select the right case based on CT scan, which has a good amount of calcification to hold the valve. So it's very important to analyze the CT scan that we do before the TAVR and then choose the right candidate. So if you do it in the right candidate, the risk of embolization is less than 1%. And the second question about the durability and long-term outcome. Today, we have almost 10 years follow-up of this TAVR valves, that at the end of 10 years, TAVR valves are doing better compared to a surgically implanted tissue valve.
Right. Thanks. Any chance of infections? Antibiotics?
So we give 3 doses of antibiotic because it's a minimally invasive procedure. But again, you have to give proper care of like a tissue valve. Infective endocarditis chance will remain all throughout the life of the valve. But it has to be, I mean, any dental procedures, any urogenital procedures, you have to have proper antibiotic prophylaxis. But during the procedure, we usually give 3 doses of IV antibiotics, and that is
warfarin?
No warfarin, dual antiplatelet for 6 months, followed by aspirin only beyond that. And we have dealt with some patients who are awaiting liver transplant and had aortic stenosis, and we have not given any antiplatelet, and still they have done well after TAVR.
Excellent. So nice, interesting session we had. And thank you, Maulik, for all that enlightening us on that topic.
Menon and Dr. Mashru are part of our HN Reliance TAVR team. So Dr. Menon, maybe if he wants to say something.
Well, I think TAVR is definitely a good procedure, and I think it's. I only believe one thing, and I've told Maulik also this, that it should, and I'm sure Dr. Vitisha also agrees that every procedure has its place in medicine. We should not overdo it. We should not underplay it. And I think we should still have a proper heart team approach when we decide whether a patient should be taken for a surgery or a TAVR. And I still believe that we should, for younger patients, surgical is still better. For older patients, TAVR is probably definitely beneficial. But younger patients, we still have a route for surgical revascularization, valve replacement in our country. And definitely cost is going to be a major factor. And unless they bring down the cost of the procedure and the cost of the valves, this procedure will have a very niche segment of patients who can really afford this procedure.
Sure, good, excellent.
I would like to add to that younger patients, TAVR should not be done, because in our country, diabetes is a big problem, coronary arteries is a big problem. After putting a TAVI valve, future coronary access becomes a challenge.
Yeah.
So younger patients, we should try to avoid putting TAVR valves. Yes, I fully agree.
Thanks, Dr. Maulik and Dr. Ajit Menon. We now go on to the next lecture. Dr. Anil Awad, can you announce?
Yeah. The next speaker is Dr. Nihar Mehta, and I request Dr. Kashyap Dakshini, the member of IMA CGP Mumbai sub-faculty, to introduce Dr. Nihar Mehta.
Good morning, friends. Dr. Nihar Mehta is a consultant cardiologist attached to Jaslok Hospital and Research Center and Convest Jain Clinic, Bhatia Hospital, St. Elizabeth Hospital, and KJ Somaiya Hospital. Currently, he is also associated as a consultant in the Department of Cardiology at Sir H.N. Reliance Foundation Hospital and Research Center, Mumbai. After doing his MBBS and MD from MUHS, he completed his DNB in medicine and then DNB in cardiology from Jaslok Hospital. He received fellowship in interventional cardiology and cardiovascular imaging from Asan Medical Center, Seoul, South Korea. He has received training in transcatheter aortic valve replacement, transesophageal echocardiography, and advanced ECG in rhythm. He is joint editor of Dr. P.J. Mehta's Practical Medicine and Dr. P.J. Mehta's Common Medical Symptoms, as well as co-author of Clinical Endocrinology. He is also the assistant editor of Clinical Journal of Hypertension. He is a faculty member of the Master's Teachers Program for Training in Clinical Cardiology. Today, he will be talking on Mitra Clips, a novel percutaneous solution for mitral regurgitation.
Thank you, everybody. Thank you and welcome. And I would like to first thank all the organizers and everyone in IMA for organizing this wonderful program and to give us a chance to show you all what options we can offer our patients, especially when most options seem dry. So today I'm going to talk about a very novel therapy which has been introduced in Maharashtra and in the Western India by our team at HN Reliance. The Mitra clip procedure is not a new procedure at a global level, but we had the benefit of doing the first few cases in Western India. The first patient was a 79-year-old male who had hypertension and ischemic heart disease, had some stents put a few years ago. Over the last 2-3 years, he developed Parkinson's with severe progressive supranuclear palsy. He lost around 8 or 9 kilos, central sleep apnea. He had a weird kind of neurogenic dysphagia. So he would not be able to swallow any solid food. He was just on a liquid diet because he would aspirate. And in one of those bouts of aspiration, he had a recent admission, went into septic shock. We nearly lost him. During the admission, his mitral valve prolapse, which was always moderate, progressed to severe in the early part of this year. And he went into congestive cardiac failure in one of the admissions, went into his BNPs were in over 10, 12,000, 15,000. This was his 2D echo. Now, as you can see, the mitral valve is here. This is the left atrium, and this is the left ventricle. And you can see the valve prolapsing there. And this is a severe mitral regurgitation that is occurring more eccentrically. You can see this mitral regurgitation is going all the way to the upper part of his heart and flooding his lungs. Now, initially, such a patient would have only two options. Just continue medications and say, this is the best you can do, or offer him a surgery where you do an open heart mitral valve repair. And this gentleman was too frail to undergo that. Now, mitral regurgitation is a very common heart disorder. We don't realize the extent of mitral regurgitation in our community. If left untreated, it leads to LV dysfunction, heart failure, and very soon it leads to death. Surgical repair and replacement are the only effective treatments for this particular problem. And especially when people have comorbidities like LV dysfunction, they become a very high surgical risk. So we need, the need of the hour is to have a safer and less invasive option for these patients. Now, as you all know, aortic stenosis is a very common disease with aging. But if you all see the trends, mitral regurgitation is many-fold more common than aortic valve disease. And therefore, these patients are the ones who should be at least considered for the therapy of mitral clips. The only difference is that aortic stenosis is a far more aggressive disease, and the progression to symptoms and mortality is 25% per year as compared to MR, which is 10% per year. Therefore, it's again important to understand that these two subsets behave differently. The mitral valve is such a dynamic structure because the apparatus is not just the leaflets. It includes the mitral annulus, the chordae tendineae, the papillary muscles, the subvalvular apparatus, all this in association with the left ventricle and the left ventricular and left atrial junction. So all this forms the mitral valve complex, and any of these problems can lead to a mitral regurgitation. So you can actually have a mitral regurgitation with normal leaflets. That is what is called a secondary MR, where it's just the annulus which has dilated. You can have mitral valve prolapse where leaflets are hypermobile. In India, rheumatic heart diseases with restrictive leaflets are also very common. But another subset which is very common is ischemic mitral regurgitation or functional mitral regurgitation. So the simple way to classify it is primary and secondary. Primary is where your leaflets are abnormal, as in mitral valve prolapse, whereas in secondary, it is annular dilatation or a dilated cardiomyopathy, which leads to a functional mitral regurgitation. Now, this was a very important study, which was done in close to 5,000 people, where they found that amongst these 5,000 people who had either degenerative MR, which is your mitral valve prolapses, or functional MR, the secondary MRs, in the degenerative group, many underwent surgery. But in the functional group, when your LV is dysfunctional and your heart functioning is low, around 64% did not undergo surgery. And these only underwent medical therapy. Now, what happens to these 64% people? 20% and 50% respectively will be dead by 5 years, and half of these people will be gone because of the MR. And in the unoperated patients, 90% would have been hospitalized over the next 5 years with heart failure. So we have to understand that optimal medical therapy is just not a good enough option. Then came a trial called the Everest 2 trial, which determined whether mitral valve regurgitation versus open heart surgery for these high-risk patients, is it a good option? And they found that the primary endpoints were similar, meaning that the patients had freedom from death or severe MR and mitral valve dysfunction. But a large number of patients who underwent the percutaneous clip had
please mute yourself.
thank you.
Can I request the technical team to please mute all of them except the speaker? The technical team, can you mute all of them?
Piyush Kale.
Don't mute me, mute the others. And let the speaker talk.
Right, so I hope I'm not muted.
Yeah. Thank you. Thank you, Niyar. Go ahead, please.
Yes, thank you, sir. So the people, the candidates who underwent the mitral clip actually did not have as many major adverse effects as the surgical outcomes. So it showed that there was an improvement, equivalence in terms of death and reoperation. There was an improvement in NYHA class. There was an important recovery of the LV, and especially in the terms of LV remodeling. So even over 5 years, the candidates who went beyond the first 6 months did equivalent to surgery. So what this trial told us is that mitral valve, mitral clips are an equivalent option in the high-risk subsets. Please note, it's not for everyone. There was another trial called the COAP trial, which sort of put the nail in the coffin in terms of the mitral clip, in the sense that it put a very important discussion to bay, which is that optimal medical therapy was just not good enough for mitral regurgitations. The clip-related complications, which can sometimes be things like tamponades, clip embolizations. These were not too many. The outcomes with the device group were far better in terms of hospitalization, heart failure, and death from any cause. So just offering these patients optimal medical management is not right. Now, so in these trials basically conclude that our heart failure patients who have moderate or severe MR should be offered mitral valve therapy to lower their hospitalization, lower their mortality, and improve their quality of life. So the mitra clip basically is shown here in this picture, where there are two clip arms which are covered with cobalt chromium. They have a cobalt chromium implant and they're covered with a polythene material, and there are these grippers here on top which will grip the mitral leaflets between these two arms. Now this is around 2 centimeters in width, and basically it can be used percutaneously from the femoral vein, and therefore the complications of this procedure are far lesser than open heart surgery. There are also selection criteria where you have to do your echo in a lot of detail and select the patients very well, because it was found that if not selected properly, these patients actually don't benefit from this therapy. And continuing with our case, luckily our patient had a third option, which was the mitra clip. And this little video will show us how this mitra clip works. So this is a normal valve where the leaflets are coapting. In a patient with mitral regurgitation, part of the leaflets don't coapt, and this little hole leads to leakage into the LA. So open heart surgery, like I said, is obviously a better option, but when they are inoperable, we can go in from the vein, come into the RA, get into the left atrium, and then introduce this clip, which clips that opening. It will grasp the two leaflets and close that opening. So this is actually based on a technique, a surgical technique called the Alfieri stitch, where initially it was attempted to take a stitch in the middle of the mitral valve, but that was done via the open heart surgery, and that did not do too well. Now, our patient, we did a detailed transesophageal echo and found him to be a good candidate. We went through the steps. Now, as you can see, the transseptal puncture that is going from the RA to the LA, this is always a concern, and it is done under complete transesophageal guidance. As you can see, this catheter goes across the septum. Now, this is the guide catheter through which the clip will come in. And once this clip comes into the LA, this is the clip loaded here. Now, this is the delivery system. And it has so many knobs because you can actually control this clip in various angles. You can move it medially, laterally, anteriorly, posteriorly, higher up, lower down. You can rotate it at a 360-degree angle. So this device requires a lot of training, but it is you have a complete control on this. Now, whenever we do this, it is done with echo and fluoro guidance. So this is the clip that you can see here. And this is the 3D image where you can see the clip going right over the mitral leakage. And this clip is taken into the LV. The leaflets are, the mitral valve is kept onto the grippers here. And this is then closed. So as you can see here, this clip has been closed here and the mitral valve is still working well. We have to actually check the gradients, check the leakage. Now, in this procedure, we are not aiming for a zero mitral regurg. We just want the regurgitation to go to mild or moderate so that the symptoms of MR will go down. And this is the clip released. And this is the final result where the leakage of the patient, as you can see here, the clip is here and the leakage is barely anything. If you can see this, the leakage, which was going all the way up here, is now down to nothing. So this patient walked the next day. He was extubated in the cath lab. I had to tell him to slow down because he was walking faster than me. No complaints. 1 month later, his BNP went down from 15,000 to 1,600, and he's doing very well. I'll quickly run through our second case because it was done on the day after. A more fit gentleman, but mitral valve prolapse, moderate MR, started getting atrial fibrillation and a lot of orthopnea and cough. He was actually referred by a very senior physician who called me and said his systolic murmur has gotten worse. So Dr. VT Shah's question about the stethoscope holds very true here. And that is how this whole cascade started. His BNP started going up. Now, for this gentleman, it's the same. We had a severe mitral regurgitation, as you can see the turbulence here. He underwent the echo, found a severe regurgitation. We put one clip and realized that this is the clip you can see going here, catching the leaflets. And we grasped this, but after grasping it, you can see this turbulence is still there. So we had to go in and put another clip for him. So we got in a second clip, went close to the first one, and after we positioned it correctly, we again looked at the leakage, and as you can see here, now the leakage was down to very just a trivial leakage here, as you can see, like the last case. The leakage has gone down to just a whiff. So with this done, this patient coincidentally, through his transeptal puncture, he had a very floppy septum. So we actually had to put in an ASD closure device also. And this is his end result, 2 clips and an ASD closure. He also recovered equally well, walked the next morning, discharged in 48 hours, no dyspnea, walking 30 minutes, gone out of the country at present, off diuretics, and BNP is just a measly 800. So this is our team. We had the privilege of doing the first 2 cases. Dr. Maulik Parikh is part of our team. Dr. Ashwin Mehta, Dr. Handa, Dr. Nitin Burkule came for our transesophageal echo. Dr. Dalvi helped us in the ASD closure. Dr. Mule backed us up, and our anesthetists were brilliant as usual. Now, we should also know that there are contraindications. Rheumatic heart disease, infective endocarditis, patients who cannot tolerate any anticoagulation, they are not great candidates. And to conclude, I would like to again reiterate that surgery is still a better option for degenerative MR. But for those people who are not fit, there is a dismal prognosis. And these clips offer a novel solution to improve the outcomes. But the main thing is, even if the patient is inoperable, but if they are not a good candidate for a clip, they are not worth taking up. So selection of patients is essential. So for us, we should realize that moderate or severe MR in either patients who have MVP or a dilated heart or ischemic cardiomyopathy, they should be at least considered for a clip implantation if they are inoperable. Thank you so much.
Thanks, Nihar, for giving us a bird's eye view about a very complex, otherwise procedure, but an innovative procedure with dramatic results in this patient. So again, a couple of questions to you. One is, of course, the cost involved, and how do you explain it to the patients about this? And the other thing is that how much anticoagulation do you have to give to these patients post putting up this ring?
Yeah, so the cost, as usual, always starts very high when these therapies come into the market. And the cost for these clips is 25 lakhs. But they offer up to 3 clips without any additional charge. So the patient who had 2 clips did not have to pay double. So, and we always predict that as this therapy becomes more and more popular, it will start reducing in cost, and at least we can hope for that. The patients require anticoagulation only on table. They require heparinization after we've crossed the septum, and that's it. They require long-term aspirin. They don't even need to be on dual antiplatelets for more than 3 to 6 months. So in long term, they don't need any anticoagulation whatsoever. We have to be careful about infective endocarditis prophylaxis as with any implant when it comes to valves.
And the other thing is, looking at those videos, general practitioner would think any chance of the valve getting more narrow rather than leakage.
So we always, before we release the clips, so these clips are beautifully engineered. So they have so much control. You can move it millimeter to millimeter, even less than that. And you can go from 360 to 270 to, you can rotate it in various ways. So once you've grasped the leaflet, you don't release the clip. You hold on, you wait for enough time. You check the leakage, how the mitral valve is behaving with the clip. If there are increased gradients, now normally the mitral valve gradients are in single digits, less than 5. So if the mitral valve gradient goes anything above 4 or 5 millimeters, the mean gradient, we do not release the clip. We open it and recapture at an area where it does not lead to a mitral stenosis. So by no means, in a palliative procedure like this, by no means do we want to add a disease. So if the gradients go up to more than 5, we definitely don't do anything. So even when you put 2 clips, or even rarely when 3 clips are needed, you make sure that it's not causing any harm, especially mitral stenosis.
So any follow-up on the echo volumes and the size or the ejection fraction, do they improve?
Yes, sir. The LV volumes, they get much better. The heart remodels into a very nice, in a very nice way, especially when they are secondary MR and when they are functional mitral regurgitations. Most of the degenerative cases will have a normal ejection fraction, but the volumes get better. The ejection fraction should improve. The cardiac output and the hemodynamics definitely get better. And that's how these patients do so well.
So any chance of any hemodynamic support sometimes?
Yes. So when you are doing the case, suppose you have a patient with a very weak heart, 15-20%, we prefer to put in a Swan-Ganz or some kind of pulmonary monitoring device so that you can measure cardiac output, measure the patient's outcomes, and see that they are tolerating these clips well. So during the procedure, a lot of hemodynamic monitoring is required, but once they tolerate it, then they usually get symptomatically much better.
Good. Thanks, Dr. Nihar, for those new ideas and new thoughts about a new procedure. So we go on to the next speaker, Dr. Awad.
Yeah.
Can you announce?
Yes. So the next speaker is Dr. Manoj Mashru, and I'll only introduce Dr. Manoj Mashru. Dr. Manoj Mashru is the mentor at Cardiology Department at Sir H.N. Reliance Foundation Hospital and Research Center. After completing MD in medicine, just a moment, I'll just share this slide. I forgot. Yeah. After completing MD in medicine, he pursued DM in cardiology from Nair Hospital, Mumbai. He achieved fellowship from the American College of Cardiology. He did his observership in interventional cardiology at Michigan and in echocardiography at Mayo Clinic. He is designated as a clinical hypertension specialist by the American Society of Hypertension. His areas of special interest includes interventional cardiology and echocardiography. Today, Dr. Mashru will be talking to us on 2021 guidelines for heart failure management. Over to Dr. Manoj Mashru.
Good morning, friends. At the outset, let me thank IMA Mumbai branch for giving me this opportunity. And I would like to thank Dr. V.T. Shah, Dr. Awad, Dr. Jitesh Mehta for giving me this opportunity. So today I'll be talking on 2021 guidelines for heart failure management, which were released by European Society of Cardiology in August 2021. So what are the heart failure outcomes in Indian patients? Now, this heart failure is a very, very important clinical problem. We get a lot of admissions. Now, the overall admissions have gone up due to heart failure with increased longevity, patients surviving ischemic heart disease events. And coronary artery disease accounts for almost 3/4 of the patients of cases of heart failure with reduced ejection fraction. And almost half of these patients have type 2 diabetes. Almost 20% of the patients die within 90 days post-hospital discharge. 1 in 3 cases die within 1 year. And at hospital discharge, only 25% of the patients achieve guideline-directed medical treatment. By adhering to the guidelines, it's possible to lower the 90-day mortality by almost 72%. So the previous heart failure mainstay treatment was giving diuretics, beta blockers, ACE inhibitors, or ARBs, mineralocorticoid antagonists like spironolactone and ARNI. All these drugs have shown individually to reduce the mortality and hospital admissions in patients with heart failure with reduced ejection fraction. But despite guideline recommendations and available evidence, the implementation of treatment in heart failure remains poor. Majority of the patients are not prescribed drugs at target doses that have been proven to positively impact morbidity and mortality. Among others, the tolerability issues related to the low blood pressure when you treat these patients with beta blockers or ARNIs, diuretics, they tend to cause low blood pressure, heart rate changes, impaired renal function, hyperkalemia. Chronic kidney disease plays an important role as it affects almost 50% of patients with heart failure. Also, dynamic changes in estimated GFR may occur during the course of treatment, resulting in inappropriate dose reduction or even discontinuation of decongestive or neurohormonal modulating therapy. Like you give ARNIs, the creatinine may go up, the potassium may go up. So that may result in changes in the treatment. So heart failure comes with basically 3 subsets. One is heart rate. When the heart failure ejection fraction is between 50 to 60, it's called heart failure with preserved ejection fraction. Then there's heart failure with mid-range ejection fraction, which was called earlier. Now it's called mildly reduced ejection fraction, that is 40 to 50%. And typical patients with heart failure with reduced ejection fraction when the ejection fraction is less than 40%. So patients with mildly reduced ejection fraction typically have some structural heart disease like hypertension, ischemic heart disease. They have increased left atrial volume, left ventricular hypertrophy on echo, and the echocardiographic measures of left ventricular filling with sometimes elevation of pro-BNP, making the diagnosis of heart failure with mildly reduced ejection fraction. But now this mildly reduced ejection fraction has been kind of treatment-wise is essentially similar to heart failure with reduced ejection fraction. So change of term, heart failure with mid-range ejection fraction to heart failure with mild rejection. This is the new terminology which has been adopted in this August ESC guidelines. And there's new simplified treatment algorithm for patients with heart failure with reduced ejection fraction. The addition of treatment algorithm is also now devised according to the phenotypes of the patient. There is modification classification of acute heart failure, and there's updated treatment for most non-cardiovascular comorbidities like diabetes, hyperkalemia, iron deficiency, and cancer in these guidelines. And there's a role for genetic testing and new treatment for these patients. And there's addition of key quality indicators. So the key changes are, 1, the simplified treatment algorithm. It's important that the SGLT2 inhibitors have now been designated as class 1 therapy. There are 4 key drug therapies: ACE inhibitors, beta blockers, MRs and RNs, they should be initiated as quickly and safely as possible. Added treatment algorithm for heart failure with reduced ejection fraction according to phenotypes for tailored management. Primary prevention by ICD in non-ischemic cardiomyopathy is now class 2A recommendation. And there's emphasis on broad left bundle branch block in selected patients for a CRT device. So when you get a patient with heart failure with reduced ejection fraction, so these are the drugs that you would use. All are class 1, ACE inhibitors, beta blockers, MRs. And now there's addition of SGLT2 inhibitors, and you would give diuretics for fluid retention. There's a role for ICD and CRTD based on the patient characteristics. When the ejection fraction is less than 35%, but where it's appropriate, you would implant implantable defibrillator. In certain cases, even the ejection fraction more than 35 and device therapy is not indicated or it's not appropriate. And in sinus rhythm, when the ejection fraction is less than 35%, but the QRS is more than 130 seconds, in these patients, you may consider using ICD. So these are the phenotypes of patients with heart failure. So the color codes indicate the class of recommendation. So if it's green, that means it's class 1 indication. Yellow is class 2A indication. So this slide shows that patients with sinus rhythm, obviously somebody who's in failure, having fluid overload, diuretics have to be used. To reduce mortality, you would use ACE inhibitors, RNI, beta blockers, MRS, SGLT2, as discussed earlier. But patients, this phenotype where the patients in sinus rhythm, there's left bundle branch block, but with a wide QRS complex, when the QRS duration is more than 150 milliseconds. So in these patients, you should carry out cardiac resynchronization therapy and sometimes with defibrillator. But with 130 to 150, it becomes class 2A indication. Again, somebody whose ejection fraction is less than 35%, but with ischemic etiology. In these patients, again, the ICDs is class 1 recommendation. Those patients who have atrial fibrillation, they should be put on anticoagulation. In patients with atrial fibrillation, digoxin may be used to control the heart rate. Those patients who have non-ischemic etiology, the ICD may be considered depending on the ejection fraction and sometimes the presence of ventricular arrhythmias. In patients with coronary artery disease, CABG should be carried out as indicated. Those patients who have valvular heart disease like severe aortic stenosis, in these patients, and they come with heart failure, they definitely need to undergo either a TAVI or surgical aortic valve replacement. And those patients who have significant mitral regurgitation, there we just saw the example of mitral valve repair, which can be carried out with mitral clip. When the heart rate is more than 70, you should use ivabradine to reduce the heart rate. And patients with CKD, at times you need to use hydralazine with isosorbate dinitrate. And those patients who cannot tolerate ACE inhibitors or ARNI, then you have to use ARBs. And in select patients with advanced heart failure, you need to consider heart transplant. In all these patients, you must offer them exercise rehab and multi-professional disease management. So, like we have heart failure clinics for these patients. So as discussed, these are the drugs that you would use to reduce the mortality as well as reduce the risk of heart failure hospitalization. But in select patients, you can use ivabradine, vericiguat, which is a new drug not launched as yet in India. Then high dose of hydralazine and isosorbate dinitrate and digoxin in certain patients. So which are the other drugs which are recommended or need to be considered in selected patients? One is ivabradine, which I discussed, that those patients whose heart rate, despite being on beta blockers, or those who cannot tolerate beta blockers, to reduce the heart rate when the ejection fraction is less than 35%, In them, you should use ivabradine. It's class 2A indication. Lenoxin in select patients with symptomatic heart failure with reduced ejection fraction in sinus rhythm, despite treatment with ACE inhibitor, ARNI, beta blockers, MRA, to reduce the risk of hospitalization. Hydralazine and isosabet dinitrate is one in black population, but otherwise in patients who have elevated creatinine, reduced eGFR, where you cannot use ARBs or ARNI. And vericiguat is the new molecule now available for treatment for patients who require hospitalization despite being on treatment. So why were the SGLT2 inhibitors? Now all of you all must be aware that now these drugs are being used so commonly for diabetes, but now also to reduce the risk of cardiovascular outcome and reduce the risk of heart failure in patients with diabetes. So you have dapagliflozin, empagliflozin, and canagliflozin. All these drugs are now approved for use in heart failure. So this slide shows that there is almost 26% risk reduction when you use these drugs for reducing the risk of cardiovascular death or heart failure. And these drugs, they are equally effective in patients with or without diabetes. So again, now they consistently use, they reduce the risk of cardiovascular death or heart failure, regardless of ARNI use. So many of these patients are already put on ARNI, that is like your Vimada, Azmada. The patient's already on the treatment, but when you add the SGLT2 inhibitors, it further reduces the risk of cardiovascular mortality and heart failure by almost 25 to 30%. So how do these drugs act? One, they have a very favorable effect by reducing the preload by diuretic effect. It reduces the afterload by reducing the blood pressure and the arterial stiffness. It tends to improve the kidney function. It helps in weight loss in the appropriate patients. And there's definite improvement in hyperglycemia in patients with diabetes. But it has unfavorable effects on cardiovascular system. That is, by having a diuretic effect, there is volume depletion and may exacerbate hypotension. It may cause diabetic ketoacidosis and increase in hyperkalemia. But one must remember that it comes with adverse effects, genitourinary infections, risk of volume depletion and hypertension, most like in situation of infections, diarrheas, diarrhea, vomiting. And since it has potential risk for diabetic ketoacidosis, these drugs should be discontinued before major surgeries and major infections because they can precipitate diabetic ketoacidosis. So any patient undergoing major surgery, SGLT2 inhibitors must be omitted. Then is ARNI. So ARNI are good drugs for patients with heart failure as they reduce the risk of cardiovascular death by almost 20%. There's 21% reduced risk of first heart failure hospitalization, and they cause significant improvement in the quality of life with fewer heart failure symptoms. But again, with ARNI, we must remember that it can cause hypotension. So you start with a low dose. The patient is on high doses of diuretic, you need to reduce the diuretics. And if the patient is receiving some blood pressure medicines, they can be reduced so that the drug can be better tolerated. It can cause worsening of renal function. It can cause hyperkalemia, and it can cause angioedema. So one must remember the adverse effects of ARNI. Vericiguat is the new drug as not launched as yet in India. It augments the level of intracellular cyclical GMP, which leads to smooth muscle relaxation and vasodilatation. The dose is typically 2.5 milligram and gradually increase over a period of weeks to 10 milligram. And this is to be given after meal and after preferably a fatty meal for better absorption. So this is a Victoria trial which showed there was a 16% reduction in cardiovascular death and 20% reduction in all-cause death and 27% heart failure hospitalization. So this increases the nitric oxide and causes vasodilatation, reducing the afterload. The only problem is with this drug molecule is the hypotension. So among patients with chronic heart failure with recent decompensation, the patients who have been admitted to the hospital despite being on adequate treatment, this is a good molecule, and it causes almost 7 to 8%. It has incidence of hypertension. So there are foundational 4 therapies for patients with heart failure with reduced ejection fraction. So now we know there's a compelling proof of robust risk reduction for heart failure and death by these drugs like beta blockers, SGLT2 inhibitors, ARNIs, and MRAs. But each foundational therapy is effective and independent of the other drugs. Each acts through distinct pathophysiological mechanisms. Decisions about optimal sequencing should not depend on the historical discovery, but on therapeutic advantages of each drug, tolerability of each drug, and the ease of use. Clinical benefits, they occur rapidly following initiation of each foundational therapy. Introducing additional foundational drug, more benefit than up titrating the existing drug. Rather than increasing the dosage of the other drug, you may introduce the other drug so you get better synergistic effect. Early initiation of 4 foundational therapies in 4 weeks facilitates early risk reduction. So quickly you introduce these drugs, and optimal sequencing, some foundational drugs can improve safety profile of the others. So now this is one of the rapid sequencing algorithm for introducing these drugs. So now this is one of the proposed sequencing, and that is you start with beta blocker and SGLT2 inhibitors, and then you add ARNI, and on top of that, subsequently you add MRAs like spironolactone. So this is done within a month. So beta blockers, they are most effective and rapidly acting option to prevent sudden cardiac death in patients with heart failure. The most likely to benefit left ventricular remodeling in long-term treatment. It may cause fluid retention and early worsening of heart failure. Whereas SGLT2 inhibition, it causes early osmotic diuresis, rapid reduction in risk of heart failure worsening, kidney protection by slowing the annual rate of decline in kidney function. This is very good side effect of SGLT2 inhibition. It does not require specialized safety monitoring or laboratory testing. Initiated at therapeutic dose without requiring much of dose titration. So that's why this combination is very good and well tolerated. Then you introduce ARNI, where there's a rapid and profound effect to lower natriuretic peptides. It reduces the risk of mortality. It causes additive survival benefit to beta blockade. ARNI enhances the effect of RAS inhibition, reduces associated risk of worsening kidney function. Symptomatic hypertension may be possible, but can be minimized by using lower doses and slow up titration. And as I mentioned earlier, reducing the dose of concomitant diuretics and the other antihypertensive medications. If pre-treatment blood pressure is less than 100, it's preferable to initiate the ARB slowly and then establish the tolerability. Simultaneous initiation of ARNI and MRA avoided in patients with prior use of RAS inhibition, risk of worsening kidney function and hyperkalemia. Then the MRA, like spironolactone, there's significant reduction in morbidity and mortality in patients with reduced ejection fraction. It's easy to use by once a day dosing with minimal up titration, and it has a modest effect on blood pressure, but it can worsen kidney function and the main side effect is the hyperkalemia, especially when combined with ARNI or ACE inhibitor or ARB. Background use of SGLT2 and ARNI may lower risk of worsening kidney function and hyperkalemia, and increases the likelihood of long-term persistence on MRA. So it's well tolerated and can be continued for a long period of time. So this slide shows the importance of these combination of the drugs. So the first column shows you that if untreated, 1 year outpatient mortality in patients with reduced ejection fraction ischemic cardiomyopathy is 17%, which can be reduced to 9.4% with beta blocker and RAS inhibition. But when you combine all four, the mortality drops to 4.7% at the end of 1 year. So it's so important to continue with beta blockers, SGLT2 inhibitors, ARNI, and MRA. This is another important problem in patients with heart failure. They tend to get readmitted frequently, and one of the major contributor is anemia. So it's important when you see a patient with heart failure, reduced ejection fraction, to monitor their hemoglobin periodically and to look for correctable cause of iron deficiency anemia. So you diagnose iron deficiency anemia when the serum ferritin is less than 100, or when the transferrin saturation is less than 20%. So in these patients, giving intravenous iron will improve the hemoglobin and reduce the risk of heart failure hospitalization. Thank you.
Thanks, Dr. Manoj Mashru, for that excellent review on the latest guidelines. As we all know that last couple of years, there has been a revolution in the treatment, and game changer drugs like ARNI and SGLT2 inhibition have been introduced. So in practice, if you have your old patients who are otherwise fairly well controlled on your standard treatment, would you go ahead and still shift them to ARNI and add SGLT2 inhibitors, or because they are asymptomatic, would you continue the same treatment? Because there are many patients with general practitioners who are continuing their standard treatment without any problem.
Yeah, so these drugs should be used as far as possible. The benefit comes maximum when the ejection fractions are less than 30%, 35%, which reduces the risk of heart failure, hospitalization, and also mortality. So these drugs must be used as far as possible. So that's why it's important in this presentation that one must try and use all these drugs as far as possible. But again, the challenge becomes in patients with diabetes, patients with CKD, to use all these drugs at the same time.
So how useful are these renal parameters, doing them repeatedly like electrolytes and measuring EGFR, so that we can adjust the dose of ARNI or RAS inhibition?
So those patients who are on stable heart failure without much of elevation of creatinine or reduction in EGFR, you can do these tests once in 6 months. But those patients who are advanced heart failure, they do require frequent monitoring. So every 2 months, 3 months, depending on their baseline parameters, that you look at creatinine, potassium, CBC, hemoglobin, that is, to manage these patients. So these tests should be done. These patients require proper follow-up. So the ideal thing, those patients who have been readmitted, those patients who have advanced heart failure, they require management by heart failure team, where all these parameters can be monitored closely. That will only reduce the risk of hospital admissions in these patients.
And how frequently should they send for NT-proBNP and 2D echocardiography?
So NT-proBNP is only when they have any change in the clinical status, but otherwise, if they've been stabilized, then it doesn't have to be checked, and the treatment does not depend on the NT-proBNP levels. You're not supposed to chase the NT-proBNP, but after adequate control of heart failure, you need to establish the baseline NT-proBNP values those patients who have high elevated NT-proBNP values, the prognosis is not very good despite being on adequate treatment. So these patients require a periodic follow-up.
And how do you, I mean, when do you select patients for cardiac transplant?
So those patients with advanced heart failure, class 6, class 4, you need to anticipate and then sometimes work them up, but they have to be first primarily significantly symptomatic to be considered for heart failure heart transplantation.
Right. Thanks, Dr. Mashru. So thank you for those answers and interaction. So let's go ahead now. Dr. Anil Awad, can you announce the next speaker?
Yes, yes. Before that, I welcome Dr. Shivkumar Otture, the MMC president. He has already joined. We move on to the next speaker, and he is Dr. Neeraj Kamath. I request Dr. Sarita Devi, the member of IMA CGP Mumbai sub-faculty, to introduce Dr. Neeraj Kamath.
Okay. Dr. Neeraj Kamath is a consultant cardiothoracic and heart and lung transplant surgeon at Sir H.N. Reliance Foundation Hospital and Research Center. After completing MBBS and MS in general surgery, Dr. Kamath pursued his MCH in CTVS from the prestigious All India Institute of Medical Sciences, New Delhi. After completing his MCH, he worked at Fortis Hospitals, Mulund, Mumbai, where he was part of 65 heart transplants with Dr. Anvay Mule's team. He joined cardiothoracic transplant and VAD program at Manchester University NHS Foundation Trust at UK under the guidance of Dr. Raja Meyer Venkateshwaran for International Fellowship in Cardiothoracic Surgery and Heart and Lung Transplants and VADs. He also got special training in Transmedics organ care system for beating heart retrievals at Boston, USA. He also has experience in aortic surgeries and complex aneurysms of aorta, which he learned at AIMS as well as in UK. He has also gained hands-on experience in UK in thoracic surgeries, including video-assisted thoracic surgery for malignant and non-malignant diseases, lobectomies, decortication resection, pneumothorax surgery. He has submitted several papers in reputed index journals and presented papers at national and international levels. He will be speaking on evidence-based approach in cardiac surgery. Over to Dr. Kamath, please.
So you're on mute, Neeraj. Can you unmute yourself?
Yes, sir, I unmuted.
Yeah. Okay, thanks. Now, please go ahead. We can see your slide and we can hear you.
Yeah. I said good morning on supposed to be a relaxed Sunday, but I think it's going to be a very knowledgeable Sunday. and thank you very much from IMA Mumbai and IMA Maharashtra, and also courtesy to HN Reliance Hospital for organizing such a wide spectrum of talks involving. So I'm not able to go to the next slide. 1 minute. Yeah. Okay. So involving all the range of topics in cardiology, involving adult cardiology, pediatric cardiology. And I think I'm blessed and honored to work in a place where I think I'm able to see good number of TAVIs, mitra clips, complex angioplasties. At the same time, at the cardiac surgery level, we are doing a lot of minimal invasive, complex cardiac cases, as well as heart and lung transplants and surgeries for heart failure. So today's topic, I decided to go on evidence-based approach in cardiac surgery for the simple reason I was aware that all of the speakers are going to speak on various different topics. And as a broad spectrum, we all are aware about treatment strategies for aortic stenosis or for coronary artery disease or for mitral valve disease. But what I felt more important is, for we are all here for better patient outcomes and safer patient outcomes. And in this era of Google, where the family and the relatives, when they come to you as a physician, they would ask you what would be the right way to go ahead. And I would just like to enlighten, it's a very complex topic with a lot of technical numbers involved, but I won't go into too much of detail. But I'm just going to give a bird's eye view of most of the guidelines, what they say when it comes to angioplasty versus bypass, or surgical aortic wall versus transaortic TAVI, and mitral clips versus mitral wall replacements. So the majority of the presentation I have taken from the European Society of Cardiology and Cardiothoracic Surgery guidelines, which were developed in 2018 and 21, and they keep on renewing it. And also there are the American College of Cardiology guidelines, which also have the similar way of managing the patients. So before we move on, I just wanted to, before we read and understand the guidelines, they're freely available on the net. What I would like to say is the most important way to understand is what class of recommendation. So whenever we approach for any treatment to any patient, we decide on the benefit risk ratio. So when any treatment is offered, if the benefit is far more than the risk involved, it is in one way said as class 1 indication that treatment is recommended for that patient. Whenever the benefits outweigh the risks, but obviously the risks are also a little bit on the higher side, then we call it as class 2 indications, where we again divide it into class 2A and class 2B, where class 2A is more towards the treatment, and class 2B is probably we can withhold the treatment. And class 3 is definitely no for the treatment, in the form where the risk is far more than the benefits. So we tell them to be on most of the time medical management. Now, when we say the level of recommendation or the class, we have also to match the level of evidence. And there are a number of trials for the procedure and against the procedure if you search on Google or on PubMed. So it becomes very confusing sometimes to understand which trial or which papers to believe. So that's why these guidelines are very good, because they meta-analyze all the papers and they come to a gross conclusion. So the level of evidence A is the best evidence available in medicine, where we have n number of randomized clinical trials, or meta-analysis wherein they are using lot of multiple randomized clinical trials in one paper and saying that for certain such subset of patients, CABG is better than PCI, or PCI is better than CABG, or TAVR is better than surgical aortic wall replacement. So when we say level of evidence A, that is a very, very strong evidence for that treatment. Level of evidence B means we have a single randomized clinical trial, or we have a large pool of non-randomized studies to say that that is the level of evidence we have for that form of treatment. And level of C is a little poor poor pool of papers, mainly restricted to case reports, small studies, and retrospective studies. So we need to give statistical importance little less as compared to the level of evidence A and B. So now let us move on to the coronary artery disease or ischemic heart disease. We are all aware that it is mainly divided into acute coronary syndrome, which is further divided into ST elevation MI and non-ST elevation MI. And we also know that we have the stable coronary artery disease, or what we call it as chronic coronary syndromes, where patient presents with angina. So when do we say that patients, so if a patient of coronary artery disease comes, he has had his angiography, he has had his echo, how do we decide which patient should undergo an angioplasty, or this patient should probably benefit from bypass? So it is not one only angiography report or echocardiography report we decide on. It is a complete list of things we see in detail, right from the age of the patient, the history of the patient, the symptoms, the family history, his quality of life, any comorbid conditions that patient is having. So we term all those things in one assessment called as the assessment for the surgical risk. Now, when we say assessment for the surgical risk, there are mainly two scoring systems when we come to any operative procedure. Most commonly, what we used in our institutions is Euroscore, and there is an American score which is called as the STS score. I will speak to it in detail in the next few slides. So the decision for any intervention for coronary artery disease is decided on two aspects. One is assessment of the surgical risk or anesthetic risk, and assessment of the coronary artery disease complexity. These are the two main aspects on which we decide what kind of treatment will give the patient symptomatically and prognostically better outcomes. So the surgical risk scoring system, I told you about the Euroscore system. It was first developed as Euroscore 1, which was divided into patient-related risk factors, cardiac-related risk factors, and operation-related risk factors. And there are a lot of numbering systems in it. And when we fill all the numbers, we get a Euroscore of 2%, 4%, 2.3%. And then we had the Euroscore 2, which also involved poor mobility or frailty, renal impairment, diabetes on insulin, and we also added the subset of urgency of the operation in the operation related risk factors. So depending on all these factors, we calculate the logistic Euroscore, and whenever the Euroscore is less than 4%, we tend to tell the patients that they are the benefit of getting a bypass done is far more. The anesthetic risk, the surgical risk is far less, and probably they can undergo a bypass if the coronary angiography shows lesions at that particular places amenable to bypass. In the STS scoring, however, in the Euroscore system, they mainly talk about the risk of mortality in the perioperative period. They don't talk about the risk of morbidity. The STS scoring system, which is an American scoring system, it tells us also about the risk of complications which a patient can have undergoing a bypass. So they have divided into different categories like isolated CABG, isolated aortic wall, isolated mitral wall, AVR plus CABG, mitral wall, double wall, mitral wall repair. And there in that you need to fill the age, the gender, the race, and other clinical factors. And they will come up with a scoring system, which you see, which will not only tell us about the mortality, but also about chances of renal failure, chances of stroke, chances of arrhythmias, chances of deep sternal wound infection, and the length of stay, which are all equally important aspects in today's era. It is not only about the mortality, patient is paying from his pocket. So even a week stay going up to 10 to 12 days of stay with a small complication, patients are going to come back and ask you what went wrong. So, so it is better to understand these scoring systems and put it into clinical practice when we see the patient preoperatively and tell them that these are the surprises. According to the STS scoring system, he might have these complications. So be prepared for it. So that is what is the comparison of all the three systems. So then we move on to the coronary artery complexity, or how complex is the lesions in coronary angiography. The Syntax scoring system came back 10 years back in the Syntax trial, comparing the drug-eluting stent taxes versus CABG. And they developed with a complex scoring system when we do the angiography. It is an 11-step process through which the report is made. And then depending on the score, they are then divided into low risk, intermediate risk, and high risk. And now most of the guidelines are based on this Syntax scoring system. So it's very important to understand that it's not only about having blockages in particular arteries, it is also about the site, it is about the arterial dominance, it is about the number of segments involved, whether it is a total occlusion or just 70-80% blockage, what amount of area that vessel is perfusing the myocardium, whether it is a trifurcation block or a bifurcation block, what is the length of the blockage, Is it more than 20 millimeters? Is there heavy calcium also along with it? So that is how they all study, and we come up with a syntax scoring system. So that is the same slide. You can see the coronary angiography, and these are the areas. Depending on these areas, if the blockages are in those particular areas, then the numbering system, you can see these are the points which are given on the right side, the number of points depending on the area of blockage. So then we come out to the most important slide, that is when to do what depending on the lesions. So if there is reasonable surgical risk, now depending on the angiography, what do we say which treatment is class 1, class 2? So if we see, so we divide this slide into multiple segments: single vessel disease, double vessel disease, left main, triple vessel disease without diabetes, and triple vessel disease with diabetes. Now, and then we have CABG and angioplasty, class, recommendation, and the level of evidence we have to say that this is recommended. So for single vessel disease without proximal LAD stenosis, it is a class 1 indication to do angioplasty. But as soon as, even if it is a single vessel disease, but the lesion of obstruction is at the proximal LAD, CABG and PCI both are class 1A indications. So here you can decide what patient, we can explain to the patient that both are equally better, both will give you symptomatically as well as prognostically good results. It obviously depends on the patient what he wants to have. Then we come to the double vessel disease. Obviously, whenever there is no proximal LAD stenosis, PCI scores more. But whenever there is a proximal LAD stenosis, CABG is a class 1B indication. That means the level of evidence is B, and it is a class 1 indication, means it is recommended. Whereas angioplasty is also recommended, but the level of evidence is little poor. Okay. Then when we come to left main disease, this is where the new changes with better angioplasty techniques. Left main disease with low syntax score less than 22, CABG and angioplasty are class 1 indications, whereas left main disease with intermediate and high syntax score, CABG, it's obviously that they should undergo CABG according to the evidence and also according to the recommendation for symptomatic and long-term benefits. Then when we come to without diabetes or with diabetes, triple vessel disease, it is mostly CABG. For you should send patients for bypass as compared to angioplasty on evidence. However, if patient is not medically fit or has a very high surgical risk on Euroscore and STS score, then you can advise them for an angioplasty as one of the second best option. I hope this slide has been very clear. So basically, the patients which are favored for bypass are divided into clinical, anatomical, and need for concomitant interventions. So patients with diabetes, with ejection fraction less than 35%, contraindication to higher doses of antiplatelets or higher forms of antiplatelets, and diffuse instant restenosis. Anatomically, syntax score more than 23. Anatomically, where the angioplasty cannot do a complete revascularization, and severely calcified lesions, they are all will go in favor of bypass. Whereas patients preferred for angioplasty are those who are having severe comorbidities. They are of advanced age with poor quality of life, reduced life expectancy, reduced mobility. Yes, you can favor them for angioplasty, and there probably they will not do a complete revascularization. They will do the vessel which is more angiographically important, and then take the other. They might do a stage angioplasty depending on the lesions. So from the surgical technical aspects, what conduits are better and what is the level of evidence. Obviously, we all know that whenever a patient is coming for bypass, it is the Lima to LAD, which is the crux of the operation, which gives the maximum benefit in the short and the long term. So Lima to LAD is and must in all bypass operations. Now, with Lima and Rima coming into the picture, it is a class 2A. That means it should be considered in all patients if the risk of sternal complications are less. That is, if patient is not too obese, if patient is not uncontrolled diabetes, and you feel that the chances of him having a sternal complication, dehiscence or wound infection is less, you should give them the benefit of BIMA. Otherwise, you can use radial artery as conduits in selected cases. You should use it in patients with high grade stenosis, that means which are more than 90% at least, because radial artery is a very muscular artery. And if the native flow is good, the radial artery will go down because of competitive flow. So if you are using a radial artery, you may need to make sure that you're using it only for high grade stenosis, either for the left segment or the right segment. You can use in certain patients veins if patients have already been used with bilateral mammary, or they have been used with Lima radial and patient is needing a redo bypass or something like that. We can use vein harvesting, where again endoscopic vein harvesting and no touch vein harvesting, these are the new techniques which have come so that the damage to the vein is as less as possible. The most important point in doing a bypass operation is the complete revascularization. Every graft, every target needs to be grafted, and that is the most important difference between a bypass and angioplasty, where patient is having multiple level of blockages. The ease of doing a bypass and covering all the blockages is far better than doing an angioplasty. These are the recommendations for patients who are with heart failure, low ejection fraction, but a viable myocardium. And CABG is class 1 indication for patients who are having viable myocardium with multivessel disease and with acceptable surgical risk. In the long term, they will improve the EF and give benefit. Now I move on to the valvular heart disease, where it's complex. It involves a lot of different treatment options, and now with TAVR coming into the intermediate subset of patients also, it's very confusing for the physician as well as for the family to understand whether they should go. If they go to a surgeon says surgical aortic wall. If they go to a cardiologist, they say it's TAVI. So then who is right? So that's why the concept of heart team has come, where everybody is involved. You discuss the case in the team and you discuss all the points. You discuss the medical points, you discuss the surgical points, you discuss the TAVI points, and then you take the right decision for that patient. But heart team doesn't involve only the clinical personnel. It also involves a lot of other heart failure specialist, electrophysiologists, because it is not only about giving treatment to the patient. If patient develops any type of complications, the team must be able to handle those complications, diagnose those complications, and the amount of infrastructure required for it in the form of hybrid cath lab, intensive care, vascular surgeon, electrophysiologist, if patient develops a heart block. So all those things need to be available in that center, which we are doing TAVR or mitra clips or any higher surgeries. So this is the concept of heart wall clinic. So this is the referral system from the general practitioners and the physicians, sending it to the cardiologist, sending it to the center of excellence, where they all work as a team, and then into the heart wall clinic and decide the treatment options depending on the clinical, anatomical, and procedural factors. So moving on to aortic stenosis. Obviously, aortic stenosis, you need to intervene for aortic stenosis for symptomatic as well as risk of sudden cardiac death. So all symptomatic patients need to be intervened in the form of surgical aortic wall or TAVR. In asymptomatic severe aortic stenosis, there are certain points which you need to remember wherein intervention is preferred. like if the patient's ejection fraction is less than 50% and there is no other reason for that ejection fraction to go down. On exercise testing, if the patient's blood pressure falls more than 20 millimeters of mercury, patient is asymptomatic but having very severe stenosis on echocardiogram in the form of mean gradient is more than 50. Normally when we say severe, it is more than 40, but when we say very severe, it means mean gradient is more than 50 and the velocity is more than 5 meters. So the progression in these patients is faster, and that's why intervention has to be done earlier, even though they are asymptomatic. And high pro-BNP levels, which obviously cannot be justified by any other disease like cardiomyopathy or ischemic heart disease. So what are the subset of patients which are preferred or favorable for TAVR, and what are the patients which are favored for surgical aortic valve replacement? So it is divided into clinical, anatomical and procedural factors, and concomitant cardiac conditions. Now let's go from down to up. So concomitant cardiac conditions in the form of patient is having mitral valve disease or dilatation of the aortic root or tricuspid valve disease. So patient is requiring cardiac surgery for any other reason, then obviously surgical aortic valve replacement gets a priority. Now, when it comes to anatomical and procedural factors, so when you're doing a TAVI, it is now preferred to be done only by transfemoral route. So obviously your femoral arteries need to be good. Then if the femoral access is not good, patient is preferred for surgical aortic valve replacement. Then if patient has previous history of chest radiation for any form of malignancy, or if patient is having porcelain aorta, that means heavy calcium in the aorta, or patient is having higher likelihood of patient prosthesis mismatch, and patient is having severe chest deformity or kyphoscoliosis, these are the patients in which TAVI is preferred. However, TAVI is not preferred for patients with bicuspid aortic valve or high risk of coronary obstruction, because if the coronary arteries are arising very low at the level of annulus, TAVI will obviously be very technically difficult to be done. So these are the procedural aspects. And from the clinical aspects, if patient obviously is a lower surgical risk, it goes in favor of surgical aortic valve replacement. If patient is younger age, as Dr. Maulik rightly enlightened, they should prefer for surgical aortic valve replacement. And patient with previous cardiac surgery or older age or higher surgical risk, these are the subsets in which TAVR is preferable. So this is a flow chart where the patients of severe aortic stenosis, patient is symptomatic, yes, intervention is required. So then it goes to the heart team. So all patients less than 75 years of age and less than 4% surgical risk, they should be and or unsuitable for transfemoral TAVR, then they should be referred for surgical aortic valve replacement. Patients, so this is from the partner trial itself, patients more than 75 years or unsuitable for surgical AVR in view of higher surgical risk, they should be sent for TAVI. Now, all patients in between the two, that means if patient is 70 years old, they should be, if the surgical risk is less, they should be going for surgical AVR. If patient is 75 years of age, the first thing what you should think is about TAVR. But if patient is less than 75 years of age, the first thing what you should think is, can I send this patient for surgical AVR? If he is not a candidate for surgical AVR, then you find out the other options like TAVR. But in what this slide means is, any patient more than 75 years of age, the first thing what it comes to your mind, and his patient is having aortic stenosis, think about TAVI. If patient is high risk for surgical AVR, obviously, or unsuitable, then also patient will be for TAVI. So cardiac surgery probably is, I think, one of the only laid back branches in terms of minimal invasive, because it is technically little complex, technically demanding, and at the end, we don't want to do an inferior operation for a cosmetic surgery. So keeping this in mind, the minimal invasive cardiac surgery has not evolved in the extent like other urological or general surgery has evolved. However, in cardiac surgery, there are few surgeries in which MICS is as safe and equal in outcomes as compared to conventional cardiac surgery. One comes is ASD closures, and second I think is aortic wall. So here I would like to discuss one case where we have a sutureless wall, which it is a surgical aortic wall replacement, but it is a sutureless wall like a tower wall, where we don't have to place sutures in the annulus. We have to just deploy the wall like a cardiologist deploys it in TAVI, but it is in the form of surgery by opening the aortic wall. So it is a very fast surgery, low clamp time, low bypass time. At the same time, it can be done minimal invasive. So here you get the surgical advantage of a surgical AVR. At the same time, you are getting a sutureless wall, which is a good wall, and in the minimal invasive technique. So this is a Percival surgical sutureless wall, which is FDA approved, and it is confirmed to be safe, reproducible, and effective in the intermediate risk population, providing excellent clinical recovery both in early and mid-term follow-up. So I would like to emphasize on this minimal invasive aortic wall with Percival sutureless walls are giving excellent results like what in Tower is giving in intermediate risk populations. So if patient is surgically little bit higher risk, they can undergo this minimal invasive AVR with Percival, I would recommend. So it is just a 2 inches small incision as compared to the standard sternotomy incision. Either you can do it in the midline, so small incision, or you can do it at the right anterolateral third intercostal space. And you can see that it is opened up, cardiopulmonary bypass is established, you are opening the aorta and you are just deploying the wall in the annulus. There are no sutures to be taken, aortic wall closure, and you come off bypass. Aortic regurgitation, it is pretty simple. Patients, obviously, if patients are symptomatic, they are referred for surgical replacement. If patient is asymptomatic, then you need to see whether patient's ejection fraction is falling more than 50%, or if the diastolic and systolic dimensions are going beyond 50 millimeters, then you should send them for surgery to protect the function of the heart or irreversible structural damage to the heart. Mitral stenosis, mitral wall as compared to the aortic wall is little different because aortic wall is made up of 3 leaflets, but when we say mitral wall, it is not only made up of 2 leaflets. It is always called as mitral wall apparatus. And when I say mitral wall apparatus, right from the beginning of the wall leaflets into the chordae, into the papillary muscle, joining into the left ventricle, it forms a complete mitral wall apparatus. So when I do any operation on the mitral wall, it also affects the left ventricle. So when I say I do a mitral wall replacement, I'm going to cut the chordae, and in that case, the connection of the mitral wall to the LV is gone. And in the long term, they do tend to give problems. So that's why now, if you see the guidelines, they are more towards preserving the mitral wall, because there is no wall what is like what God has made for us, and we try to preserve the mitral wall in the form of being little less aggressive surgically. So given a choice of a patient of mitral stenosis, if you can do a balloon mitral commissurotomy in the form of PTMC, you send the patient for PTMC. However, there is any indication where PTMC cannot be done by anatomical, clinical, or there is a high risk of embolism, there is a high risk of hemodynamic compromise, then only you send the patients for surgery, because in mitral stenosis, the chances of repair are very less and you will end up replacing the wall. Whereas unlike mitral regurgitation, like what Dr. Nihar Mehta explained to us, the main difference between primary mitral regurgitation and secondary mitral regurgitation is primarily here the leaflets primarily are diseased in the form of flail leaflet or ruptured papillary muscle or a perforation. Whereas in secondary MR, it is a functional MR because of the LV problem. If there is some akinesia in one segment, hypokinesia in one segment, and dyskinesia, the LV will not contract and dilate properly, which will give you a secondary MR. So the way of managing primary MR is towards mitral valve repair, where you repair the leaflets and preserve the chordae, papillary muscle, and the left ventricle. It will give you excellent long-term benefits. So now what the guidelines say is for primary mitral regurgitation is you should refer a patient of mitral regurgitation to a center of excellence, to a center of heart valve clinic, where mitral valve repairs are routinely done. Mitral valve replacement for primary mitral regurgitation is not an ideal operation. And secondary MR, you need to be conservative. You need to give them on medicines as much as possible. And if given a chance, and if you find there is a patient is requiring some amount of angiographically blockages and a patient is having viable myocardium, a patient is going for bypass, you can repair the secondary MR, or else you can keep them on medical management. You can do CRT, or you can also think of doing a mitra clip, as Dr. Nihar Mehta rightly said. So these are the same slides about chronic primary MR, where you should send patients for mitral valve repair. And if patient is obviously very high risk, you keep them on palliative care, obviously, if patient is not surgically fit, or you can think of mitra clip, very thin, very small indication or very small subset of patients. But majority of the patients who are symptomatic and there is a need to do an intervention, it is in the form of surgical mitral valve repair for primary mitral regurgitation. Medical secondary mitral regurgitation, I think Dr. Niyar Mehta is nicely explained. So here mainly the problem is not in the wall leaflets, it is in the LV, and that's why doing a wall surgery is not going to correct the cause. So you need to be judicious in which patients you need to do mitra clip or mitral surgery. And there is one subset of patients which might go, if they are in the right age, then they need to go for LVAD or heart transplant for chronic secondary MR. Heart transplant, obviously all patients with end stage heart disease, dilated cardiomyopathy, NYHA class 4, class 4 angina not amenable to revascularization in the form of bypass or angioplasty, HOCM more diffuse subtype, severe decompensated inoperable valvular heart disease, restrictive heart disease in the form of amyloidosis, congenital heart diseases, and any other cardiac abnormalities that is severely affecting the normal function of or a normal day-to-day activity with a high risk of mortality in the next 2 years should be referred for heart transplant workup. So in a patient of heart failure, you see the clinical assessment, you go through the imaging, you do the right heart cath, and patient is in low output syndrome, and his patient is not contraindicated for transplant or LVAD in the form of it is a single organ problem. The other systemic organs are good. There is no malignancy. Then you refer them, you release them for transplant. And in the meanwhile, if patient is unstable, you can put them on LVAD. However, if these patients are not in low output syndrome, they can be managed medically, and you need to follow them up closely on surveillance. And if at any point of time you see that their VO2 max is falling below 14 or 12, you then can lease them for heart transplant. There are certain exceptions where you need to lease them for heart transplant in view of sudden cardiac death, especially patients with HOCM, diffuse subset of HOCM, arrhythmogenic right ventricle, cardiac amyloidosis, and adult congenital heart diseases which are Eisenmengerized. So obviously the American and European guidelines for heart transplantation, absolute. Here, by whatever indication patient is in end stage heart disease, in refractory cardiogenic shock, or is on continuous inotropic requirement, if you stop the inotropes, patient goes into heart failure. The peak VO2 max or the cardiopulmonary exercise test in which we see the VO2 max falling less than 10 ml per kg per minute they are all indications to go for transplant. Any VO2 max falling less than 14%, 14 ml, they need to be listed, and the transplant needs to be done in the next 1 year. Contraindications, obviously, patient of infection, malignancy in the last 5 years, social support, psychiatric issues where we feel that the patient is not compliant to medicines, significant renal failure, alcohol or drug abuse, peripheral arterial or cerebrovascular disease, and emotional instability. These are the major contraindications for heart transplant. There are some contraindications which can be corrected and they can be listed later on, but you cannot ignore them, obviously. But one of the most important contraindication clinically is the pulmonary vascular resistance, which goes up because of left ventricular dysfunction. The end diastolic pressure of the left ventricle goes up chronically, because of which the pulmonary vascular resistance goes up. And the donor heart is obviously in a normal body where the pulmonary vascular resistance of the donor is normal. So if you do a heart transplant for a recipient whose pulmonary vascular resistance is more than 5, then the right ventricle will fail. So obviously heart transplant, you need to rule out that the patient's pulmonary vascular resistance is less than 5 Wood units. And in that case, you can keep them on mechanical circulatory support in the form of Centrimag or LVAD, and then do a right heart assessment again after 6 months. And once the PVR comes down below 3.5, then you can subject them to heart transplant. So basically heart failure patients in 2 forms, cardiogenic shock and chronic heart failure. So chronic heart failure, you list the patients obviously as discussed before. In cardiogenic shock, you tend to put the patients on mechanical circulatory support in the form of Centrimag, initially temporary and if required durable, as a destination therapy or as a bridge to transplant. So I feel heart team approach is the way ahead for all of us to understand the disease better and for better patient safety and outcomes. All treatments should be individualized, taking the team's approach, and all of this is possible in a place of center of excellence where all amenities are available, all the clinical and paraclinical staffs are available. Thank you very much again.
Thanks, Neeraj, for that elegant review of guidelines for percutaneous versus surgery. I'm glad you brought out this topic because everyone has to go through this, and there are multiple points, or as you said, patient-related factors and anatomy-related factors, plus the factors related to the institution or the infrastructure of the institution. So many things are involved in decision-making of such kind of problems. And added to all this is these guidelines are all European or American based. Unfortunately, we don't have Indian guidelines.
Yes.
Because our dynamics are totally different. You can stop sharing. Our guideline, I mean, our situations and our dynamics and economics are all different. So if I were to ask you this question specifically related to heart transplant, I mean, what would be the average cost of heart transplant right from say evaluation and the maintenance cost of therapy afterwards?
So
just for the benefit of listeners, you see,
no, exactly.
Most important message I would say in all these talks which we had since morning and which we are going to have further is that your medical insurance should not be limited to 3 and 5 lakhs alone.
Yes.
If you were to go for the aging population and the problems of the aging further, not only in cardiac, but nephro and neuro and malignancies and everything, I think your medical insurance and top-up policies should exceed 25 lakhs. That's what I would say. Right or not? Anyway, now coming to your heart transplant, let us get a view about heart transplant.
Yeah, so like India is a very diverse nation. I think we have all the medical facilities now available in all actually metros. So finances wise, I would say normally any heart failure patient who is coming for transplant, we initially admit them for 3 to 4 days, optimize, and do a transplant workup where I would like to understand his body, not only from the heart point of view, but from overall how his neurological status is, how his immunological status is, virology, about the lungs, about the kidneys. So when it's not only about the transplant surgery, he will be on immunosuppressive medicines for the rest of his life, which is going to affect his medical fitness. So he needs to prove his medical fitness to go for transplant. And that workup cost is about 2 to 2.2 lakhs for 5 days, which involves everything. As soon as we understand that this patient is fit for transplant, we register with our government body called as Zonal Transplant Coordination Committee, ZTCC Mumbai, according to the blood group, and then they are sent home on till they get a match, a proper match. So whenever we have a call for brain dead donor is available, one team goes and assesses how the organ is. In the meanwhile, we call the recipient here for transplant. The transplant normal stay is around 2 weeks, 14 to 18 days. Most of the transplants, uncomplicated ones, simple, straightforward ones, and the cost is around 20 lakhs at our institution. It is well supported by the institute, as well as it is to some extent crowd funded also. So it is not only that patient has to pay everything from the pocket. The most important message normally when they come for the first visit, we ask them is you should be able to afford the immunosuppression after the transplant.
Right.
And the first 1 year cost of immunosuppression per month is around 15,000 per month. After 1 year, the cost comes down to around 10,000, 8 to 10,000. By third year, it comes down to around 6 to 7,000 for the rest of his life. But this is per month. If a patient is affording, from that point of view, the workup and the transplant expenditure can be outsourced, can be crowdfunded, can be sponsored, can be charitized. So all those things can be done, provided, because no agency gives immunosuppression for lifelong. There is no insurance for that. So they need to be aware about this. So this point, because all the results are dependent on surveillance. So
absolutely, I think excellently concised review, and I think the attendees would benefit from all this information. There are many more things to learn, but I think most of this can be held later. But preliminarily, we should know, first of all, the selection of patient and evaluation of the patient, and most important is the follow-up of the patients, maintenance of drugs, and
yes,
follow-up by the general practitioners in terms of avoiding infection and
yes.
trying to find out if at all there are any complications.
So I would like to thank COVID for this, because it has really helped us in that, wearing a mask, sterility, eating, all home stuff, boiled stuff.
For your transplant
For the
patients,
transplant patients, they have already enforced to do by COVID. So that has
definitely, I think that was good. So thanks, Dr. Neeraj, for
Thank you,
all
sir.
that information and a review of that.
Thank
So,
you, sir.
Dr. Anil, can we go to the next lecture?
Yes. So we are a little behind the schedule, but still I'll just take 2 minutes, Dr. Vitisha. This is regarding a small presentation on why you should become a member of Indian Medical Association. This was shown last program also, because IMA is the largest and the fastest growing NGO with almost 1,800 branches all over the India. These are some of the benefits. I'll not repeat them. You can just go through. What I want to tell you today is this good news. The good news is that the IMA headquarters and IMA master state both have reduced their membership fee by 25%. But this offer is only for 2 months, that is October and November. The new membership for single and couple members will be given shortly, not today, maybe in the next program. Also, after April 2022, there is a proposed hike of 15%. So if you become member now in the coming 2 months, you will almost save 40% on your membership fee. So hurry up and become a member of IMA in the coming 2 months. Another good news is that IMA Mumbai branch is going to start a vasectomy center in the their building. It's in the Family Welfare Center. Highly trained surgeon will perform the surgery, and the good news is that person who will get the vasectomy done and the person who will motivate, they will be rewarded with a very good amount. So this is a request from IMA Mumbai branch. So any patient of yours who want to undergo vasectomy, you can refer to IMA Mumbai branch. Thank you. And now we go on to the next speaker, is Dr. Bipin Chandra Bhamre sir. I request Dr. Sachin Patharkar, the member of IMA CGP sub-faculty, to introduce Dr. Bhamre.
Good afternoon, everyone. I think I am audible enough.
Yes, yes.
So it is my pleasure to introduce a good friend of mine, Dr. Bipin Chandra Bhamre. He is a consultant cardiothoracic surgeon at Sir H.N. Reliance Foundation Hospital and Research Center. He is MBBS, MS, MCH, cardiovascular and thoracic surgery, MD, USA. He has been trained under the famous heart surgeon, Dr. Denton Cooley at Texas Heart Institute, USA. He received gold medal in surgery from University of Pune in 2005. He has been awarded with the Acharya Shushrut Sadbhavna Award for his exemplary medical services in 2009. He has also completed fellowship in minimally invasive cardiac surgery from Stuttgart, Germany and UCSD, California, USA. He has experience of more than 3,100 heart operations. He has a special expertise in coronary artery bypass grafting and wall repair and heart replacement surgery. His experience in treating complex aortic aneurysm with hybrid procedures through small incisions. He now offers transcatheter aortic wall replacement through a very small incisions in the groin in highly selected patients. Today, he will be talking on recent trends in cardiac surgery. Over to you, sir. Sir, you need to unmute yourself.
Okay. Can you see the presentation now?
No, sir, you are not shared.
Screen sharing is not done.
No, sir.
Okay.
Yes.
Is it okay?
Yes, yes, yes. Now it has come.
Can you see now? Yeah.
Yes,
So
yes.
thank you, IMA Mumbai and IMA Maharashtra. And thank you, Dr. Vitisha, Dr. Jitesh Mehta, and Dr. Anil Awad, and my friend Sachin for nice introduction. So we will go through what are the recent trends in clinical practice. Prior joining to HN Reliance, I was blessed to work with Dr. Denton Cooley and Dr. David Ott at Texas Heart Institute. So today I will be briefly touching the commonest clinical practices, what we do. Because of time limit, I think I'll be touching mainly coronary artery bypass graftings and newer advances in the heart failure surgery as well. So let us start with the CABG. So as Dr. Neeraj has already mentioned, what are the indications for CABG? And these are problems that we face every day in our clinic, that whether to go for CABG or angioplasty. So proximal LED lesion is one of the indication. And when we call it is a proximal LED lesion, so what is a proximal LED? We have to understand it from the origin of the LED to the septal branches and the first diagonal which takes off. So we should have this knowledge about angiographic films well prior to telling our patients which is best. So if you see the history of CABG surgery, so when it was introduced in Cleveland Clinic in 1960s, all veins were used and it was called as aortocoronary bypasses. And one Russian surgeon who introduced internal mammary artery in 1965. So then the surgeon started realizing that the arterial grafting and particularly this left internal mammary artery was used on the LED territory. So Cleveland Clinic published one paper in 1980s. They looked at the bypasses done last 10 years, and the paper clearly suggested that we must use left internal mammary artery to the LED, and the remaining grafts can be done by using the veins. But then the few surgeons from France, basically Alain Carpenter group, started using radial arteries. And in 70s and 80s, radial artery was also very popular. And at the same time, simultaneously, the right internal mammary artery was also introduced. So there was a lot of research and publications were for this. And then ultimately now we are much clear that we should use in all patients these bilateral internal mammary arteries. And newer techniques are introduced for this, that they should be skeletonized. So one paper was published in 2004, which stated that if you skeletonize the internal mammary arteries, the external blood supply is preserved almost 75% of what if you don't skeletonize the internal mammary arteries. So what operation used to look a few decades ago, like one left internal mammary artery on LED and vein grafts on the remaining vessels, should all now be replaced with this bilateral internal mammary artery. Even in the radial arteries, you see there is a definite survival benefit if you are using beta as a bilateral internal mammary artery. Over 15 years, now we should realize that how we are going to give the maximum benefit to our patients after 15 years, 20 years down the line. So why this IMA? Because the IMA secretes a very unique nitric oxide which dilates the circulation further, and there is a very minimal muscle in the media. So it is not affected by the spasm or anything, and the size is also comparable to the coronary arteries, and we can use it for multiple graftings. Up to 6-7 grafts we can do only by using bilateral internal mammary arteries. Other techniques which are newer, we should understand. One of the most important morbidity factor in bypass surgery is blood transfusions. So many of these patients get blood transfusions, and then we know they will have some morbidity associated with it. So we started using this cell saver machines in all patients, and what we have found that the blood transfusion rates in these patients have reduced significantly after using this. Another benefit of using bilateral internal mammary arteries, we are not touching aorta. One of the major complications after bypass surgery is getting a thromboembolism because of the clamping the aorta. So no touch aorta technique eliminates it, and the only 0.6% of the patients will develop these neurological events. And if you see, those patients will have some arrhythmias in post-operative period where some small thrombi are generated into the left atrium or in the ventricles. And also we start the antiplatelets, that aspirin immediate, after 4 to 6 hours after surgery, when the drains are very minimal, that also prevents this aggregation of platelets or small thrombus from the left atrium. So far from 2014 to 2021, we have operated almost 2,200 surgeries, and most of them are done on off pump, and in all patients, we are using bilateral internal mammary artery with skeletonized techniques. So I would just like to share one patient with you here, where you can see the angiography film, which is a diffuse disease in this patient. And this patient received 5 bypasses using internal mammary artery. You see the multiple blockages in the LAD diagonal and left dominant system. You can see, appreciate that. And then just a small video how this is done actually. I don't know why this video is not running actually. Can you see the video?
It is not running.
Yeah, I'm not. I don't know why it is not running.
So while sharing your screen, you need to turn on the sound.
Turn on
The sound. If you can share your screen again, while sharing the screen, there's a little box that says share sound. You have to turn that on.
Share.
Let me stop your sharing right now.
Yeah.
You'll need to share your screen again.
Okay.
And once you click on share screen, that green button, there's an option at the bottom that says share sound.
Okay. Share sound. Huh? And then it will share. Okay.
Yes.
Yeah. Optimize video clip.
That's not required.
Anyway.
Much later in life. My grandmother had her first child age 16 and she had 10 children. She was married at 14.
So let us move forward. That video is not working. So on beating heart, we are able to, you see sometimes in a very younger patients, we see a lot of diffuse disease in the LED territory and PD right territory. So we can all remove these plaques inside. I would have shown you. So another technical advancement in doing bypass surgeries is that you can use a minimal invasive direct coronary artery bypass that is called as mid-cap, and mainly it is done for single vessel LED disease, where you can see the disease starts at the origin and where the stenting, there is a lot of calcium, and then Lima to LED can be offered to such patients. So instead of going through the regular sternotomy, for such patients, we can advise to go for mid-cap surgery from the left fourth intercostal space. So I hope this video works. Yeah, it's loading now. I don't know why videos are not working. Anyway, so the benefit of the mid-cap surgery to such patient is we are getting the conduit, which has shown patency rate of about 88% after 15 years and 83% after 20 years. And the patient gets the benefit of shorter recovery. Instead of 6 weeks, they recover in 2 to 3 weeks time with less blood products requirement. So these are the scars that are seen after mid-cap surgery, and similarly for aortics and mitrals also in selected patient we can use these techniques. So there are a lot of newer techniques, surgical techniques available for mitral valve repair introduced by Dr. Alan Carpenter, and there are a lot of modifications on this. And some of these lesions, they really do very well after mitral valve repair, and these are supported by the annuloplasty rings. Once we decide to repair, it is a complex. You have to do transesophageal echocardiography to assess intraoperatively, and we must have those backups. So just slightly touch upon chronic pulmonary thromboembolism and CTPH surgery. Actually, the birth of cardiac surgery was in 1950s, was because of one of the resident doctor who was put on a duty um, in an emergency for one patient who had this pulmonary embolism. And in those days, 1940s and 50s, because there was no cardiopulmonary bypass machine available, the resident doctor will watch for the vitals of patient, and when they are succumbing at the last moment, the consultant will be called, and then the sternotomy is done. And after that, the pulmonary artery thrombosis used to be retrieved. And for that, Dr. Gibbon, who actually thought while sitting bedside that can we have a machine which will take care of heart and lungs function. And so this operation, for this operation, these machines were actually introduced into the clinical practice. And then, so how do we identify this chronic CTPH? So, of course, the first treatment for any pulmonary thromboembolism is a medical, and we keep them on warfarin for longer time, like 3 months, 6 months. And few of these patients will still continue to have a lot of load of these thrombosis in the pulmonary vessels. And these patients will have breathlessness, and clinically, if you do 2D echo, the heart, except for the right ventricle, the other, there you don't find any problem on the left side or the mitrals and And the first thing that we should do is a VQ scan for these patients, and it will show us this difference between the ventilation and perfusion. And then we reevaluate this patient with pulmonary CT angios after 6 months or 1 year of initial insult and right heart catheterization. Of course, these surgeries are very complex surgeries, and only few centers in the world offer successful results with mortality of less than 2.4% in the best centers. So I had this opportunity to work in California, UCLA, at San Diego, where they are doing excellent work, where the deep hypothermic arrest is done at 18 degrees and entire circulation is stopped to retrieve these pulmonary thrombosis. So we have done 3-4 patients which were very young, and these had this protein C and protein S deficiencies. I am sharing the screen of this patient preoperatively, where you can see this yellow line is pulmonary artery pressure, which is 153/43, which is suprasystemic, and this red line is the arterial pressure. And right heart catheterization was done in this patient. Dr. Bharat Dalvi has done, and on that we have seen all these thrombosis were there. So this was done in 2019, and you see the load of the thrombosis. This is the right pulmonary artery, and you enter into all these small segmental and subsegmental branches and retrieve all these thrombosis. This is on the left side. So immediately after post-op, the success rate or the result depends on how much the pulmonary vascular resistance has come down. So if it has come down drastically, at least half, then the operation will be successful and the patients do well. This is the 4th day after surgery, and we need to ventilate them for a little longer time because there will be a pulmonary arterial venous shunts which needs to be reorganized by the nature prior to extubating these patients. So we are also offering such services at our hospital with our cardiovascular team. Another recent advances I just want to touch is left ventricular aneurysms, which is one of the major problems with heart failure patients who earlier had anterior wall MI, and then they develop these aneurysms. This surgery was introduced by Dr. Denton Cooley. He just performed this LV plication using a big aneurysm needle. And after that, there are a lot of techniques like DORS procedure, surgical ventricular restoration, LV plication are available now. Depending on the patient's anatomy, we decide which technique to be used. So for beating heart aneurysm plication, the most important point is that there should not be any clot in the left ventricle. So if there is no clot in the left ventricle, then we can go ahead and do this procedure. So this patient had anterior wall MI in 2002, and he presented to our clinic in 2015, where LVF was 25%, and he had breathlessness and readmissions to the hospital because of the heart failure 4 to 5 times in last year. So we evaluated him with 2D echo and the cardiac MRI, which was showing less than 5 millimeter of the wall thickness, which is non-viable, but other lateral and inferior wall was preserved, and we did angiography showing blockages on the circumflex and RCA territory. So this patient also underwent, if this works, I don't know, this video is again not working. Is there any way we can show this, because this was a very nice video? Anyway, I don't think that these videos are working. Okay, so this operation is done on basically on a beating heart, and we use Teflon felt sutures where the big aneurysm needles are passed through this, and improvement in the ejection fraction is at least 5 to 7%, because the energy of the heart is not lost in dilating the aneurysm, and the forward flow through the aorta is maintained, so that the ejection fraction improves, and then the patient's quality of life also improves. One more topic that I just wanted to touch upon, aortic aneurysm disease. We all of us know about Dr. Crawford and his work in Houston for aortic aneurysms, and Dr. Koseli, who was the associate of Dr. Crawford, has developed a lot of new techniques that I just wanted to share with you. So these are the thoracoabdominal aneurysms, which normally starts from the left subclavian artery, and then they go to till the bifurcation of the aorta in the abdomen, and then some of them enter into the iliac vessels as well. So when these operations were started with Dr. Crawford, their team never used heparin, because we already know that there will be a lot of blood loss during these surgeries. But as the surgical experience increased, and then moderate heparinization was introduced, so that the clots are not generated at the spinal vessels, and those techniques were like just clamp and sew, means you just put two clamps very close to the aorta and do the graft anastomosis as quickly as possible. But now the introduction of the left heart bypass has given surgeons little more time for doing the precise suturing of the aorta and the graft. And for further protection of the spinal cord, we are using CSF drainages, and which includes also the machine I will show you in the next slide, and renal perfusion, because with the experience of this renal transplant, we are using cold renal perfusion during operation to protect the kidneys when we are doing the distal anastomosis on the aortic bifurcation. And to further protect the spinal cord, selective use of branch grafts to the spinal vessels. Here you can see on this spinal vessels, selective grafting is done. This is a special pumps comes for the left heart bypass, that is called a centrifugal pump, and it gives flow to the lower half of the body while we are performing the surgery, and the anastomosis at the subclavian, post subclavian aorta. If you see the results of this and the long-term follow-up, 5 years follow-up, is showing definitely a very good survival. If you don't do anything, most of these patients die within 5 years, and if you do the complete repair, surgical repair, 73% of these patients are survived after 5 years. And very quickly, I will go through what are the recent gadgets that we offer for heart failure and mechanical circulatory support at our hospital. And every one of us knows about this IBP and ECMO nowadays. We'll just touch upon this. IBP is the balloon which inflates and deflates at the descending thoracic aorta when the aortic wall closes, and then it supplies more blood to the coronary artery during diastole. But this has a limitation that we can use it for only few days. We can't keep it for more than 72 to 96 hours. And then what to do after that? If this heart still doesn't recover from the initial trauma, what we can do? So a lot of thinking went, and one of the fellow who was working with Dr. Fraser was from the Egypt. And then there are these Archimedes screw pump, which were ancient 2000 years back. They developed this. And can we make some smaller pumps like this and introduced into the clinical practice to support the failing heart? So this device called as Impella, which is inserted through the right subclavian artery, and then it supports the heart with full cardiac output about 8 to 10 liters. This again will be used only for 2 weeks time. So then left ventricular assist devices were developed by Texas Heart Institute team, which are called as along with the thoracic team HeartMate. And you see the photo here, which I have taken. This left-hand side machine was the first machine, which was kind of a bovine machine, which used to occupy entire anterior abdominal wall. And this was called as HeartMate 1. Then the second machine is on the right-hand side, is called as HeartMate 2. And the third now, which is developed, is just very small machine, and it sits into the pericardial cavity. And this is rotational pump, which is now also available in India. So basically, there was a lot of ethical discussion going on this, whether the human circulation will, how we are going to adopt to this, because these machines are for continuous flow and our circulation is a pulsatile circulation. So, but in the last 1 decade, the experience in the North American centers is showing that our body also adapts to this continuous flow, and it is just like a living without a pulse. And this is the HeartMate 2. We have also done one HeartMate 3 at Sir H.N. Reliance Hospital. And I will not go into all these details further because that is already covered. So in 2013, and we also, India also reached to the Mars. And so there was a lot of discussion going on that maybe we may colonize the Mars in next few decades time. So what is this as a medical fraternity we can offer to the people as a latest from the 21st century? So this is the concept of total artificial heart, and now was first done in 1969 by Dr. Denton Cooley. Those were very premature machines, but now SynCardia has developed the newest version. Basic principle for this machine is still the pneumatic machine. And you see, this photo was taken from the ICU of the Texas Heart Institute, where on the screen you can see there is no ECG. There is no ECG on this, but you see the blood pressure, saturation, and everything is there. And if you X-ray these patients, you can see right ventricle and left ventricle are filled with the air here. So these are the machines, and this patient starts walking after a few weeks of recovery in the hospital. So in next few decades time, probably we will also use these machines, and we can start seeing the patients in clinic with total artificial heart. So to summarize that, as a medical fraternity, what we are going to offer for our patients in the long run And as far as the coronary artery bypass surgery grafting is concerned, that we must use bilateral internal mammary artery. We must preserve the blood by using cell saver machines so that the morbidity of these surgeries are further reduced. Thank you.
Thanks, Dr. Bhamre, for that review of the advances in bypass surgery, especially the ones where no sternotomy has to be done and then you can put a Lima to LED.
Yes, sir.
Yeah, that would be much more practical for patients and for the post-op also. So what I would say is that over a period of years, you think that the cost of bypass surgery would come down still further?
Yeah, the cost of bypass surgery is already, I think, on the lower side, probably.
Yeah.
Yeah. So, because we are in our hospital, of course, we are not using any materials used for bypass surgery, but a lot of places, I think, reuse of these octopuses and all has reduced the cost of surgery. And it also depends on which class of hospital bed you are going.
Right, excellent. So what is your average stay of a CABG patient?
So normally the patient gets admitted 1 day prior and post surgery 3 days. So and after that too. So 6 to 7 days for a patient.
Yeah, and antibiotics?
Antibiotics we use only 48 hours IV antibiotics. After that, oral antibiotics are for 3 days. So 5 days we are using antibiotics.
And what about these antiplatelet agents? You know, some of them insist that they should be stopped 5 days before surgery. So do you still advocate that, or you can take patients on antiplatelet in an emergency also?
So in our practice, what even in Texas Heart Institute also, aspirin small dose 75 milligram will not affect the post-operative drainage in the patients. But we prefer to stop at least 3 days prior, not 5 days. And one study was there where we introduced these antiplatelets 4 hours after the surgery. Means like if the surgery is over by 2 o'clock, I start the small dose of aspirin after 4 hours. So that reduces further problems, and it recovers. I mean, patient recovery is also better after that. Neurological events are less.
So some people still give low molecular weight heparin after CABG. Is that your routine practice?
No, we are using these pneumatic pumps to prevent deep venous thrombosis. So the low molecular weight heparin is not needed. If any patient where the DVT pumps are contraindicated, only in such patients we are using low molecular weight heparin. That also we start after 4 to 6 hours after patient shifted to intensive care unit.
And how many percentage of your patients go on IBP, pre, post, or intra?
Yeah, pre-IBP we have set protocols. If the patient has right left main disease with right coronary also is having a disease, these all patients will get preoperative intra-aortic balloon pump. And then we use pulmonary artery pressure catheters in all patients. And once the PA catheter is placed by the anesthetist, it is done on prior to anesthesia on operating room, operating table. If the PA pressures are high, then only we use IBP. Otherwise, we don't use IBP.
And what about on-pump surgery? Do you electively, what group of patients you think you will take on pump?
Yeah, so this also depends on what are the pulmonary artery pressures, and if the PA pressures are very high, And after placing IBP, these PA pressures have not gone down, then those patients are clearly for cardiopulmonary bypass machine use.
Or else if you have to do associated valve surgery or any such repairs or...
Yes, so in such patients, what we do is the bypasses is done on beating heart, and then only for replacement of the valve, we use cardiopulmonary bypass. So to reduce the myocardial ischemic time.
Excellent, excellent. Thanks, Dr. Bhamre, for all those answers and clarifying points. So we now go on, Dr. Anil, are you ready?
Yes, sir. Yes, sir.
Yeah, please. So please go on for the next lecture now. And
Yeah,
thanks to all the attendees for all this patient hearing. And despite we are getting late, but I hope you please stay till the end for the next two interesting lectures. And we will be all happy to see you after those two lectures. Thank you very much.
Yeah. The next speaker is Dr. Bharat Dalvi, and I request Dr. Kajal Ahuja, Assistant Secretary IMA CGG Mumbai Sub-Faculty, to introduce Dr. Bharat Dalvi.
It is Dr. Komal Jatania.
Yeah.
Dr. Komal Jatania will introduce Dr. Bharat Dalvi.
Okay. Yeah.
Yeah. Good afternoon, everyone. Dr. Bharat Dalvi is consultant in the Department of Pediatric Cardiac Sciences at Sir H.N. Reliance Foundation Hospital and Research Center. He was trained in pediatric cardiology at Children's Hospital, Boston, the Hospital for Sick Children, Great Ormond Street, London, and Cleveland Clinic, USA. He has pioneered the technique of closing very large ASDs using balloon assistance. His area of interest is pediatric cardiology with an expertise in echocardiographic imaging and non-surgical cardiac interventions. He was editor-in-chief of Journal Annals of Pediatric Cardiology 2008 to 2010. Today, he will be talking on transcatheter interventions in congenital heart disease, bird's eye view. Welcome, Dr. Dalvi.
Good afternoon, friends. I hope you can see me and you can hear me.
Yes.
Yes, sir.
Okay, thank you. And I would request you to tell me when my time is over so that I don't overstep my time and encroach on somebody else's time. So what I'm going to do this afternoon is give you a bird's eye view on transcatheter interventions for congenital heart diseases. Let me begin with this famous quote from Mark Twain. For a man with a hammer in the hand and wants to use it, everything here looks like a nail needing hammering. So whenever you listen to an interventionist, you must take his talk with a pinch of salt because there is always likely to be some bias and some kind of prejudice in whatever he's trying to describe. And I am no exception to this rule. Let me begin by trying to discuss what is the scope of transcatheter interventions in congenital heart disease. So as all of you are aware that we dilate valves in the cath lab, and the commonest valves are the pulmonary and the aortic valves. We sometimes perforate valves when there is a severe form of stenosis, what is called as atresia, and the perforation of the valves is done usually on the pulmonary side. So pulmonary atresia with intact septum can be dealt with in the cath lab. You can dilate vessels like coarctation of aorta, pulmonary artery stenosis, systemic and pulmonary veins. Sometimes you are called to close abnormal communications in the cath lab, like the atrial septal defect, the ventricular septal defect, and the patent ductus arteriosus. Taking the scope further, you may be also called to close less common communications. These are not very usually seen in clinical practice, like aorticopulmonary window, coronary, pulmonary, and systemic AV fistulae, rupture sinus of Valsalva, and Fontan fenestration following Fontan operation. The surgical colleagues might call you to maintain the patency of communications as a palliative procedure so that a more definitive surgical procedure can be done at a later date. And so you can do balloon atrial septostomy for babies with transposition, and you can do PDA stenting instead of doing a BT shunt for those who have either pulmonary or systemic circulation, which is duct dependent. Normally, it is the surgeons who bail out the cardiologists, but once in a while, we also try and bail out our surgical colleagues. And the commonest indications for these bailout procedures are residual VSDs, either in tetralogy of Fallot or in child with multiple VSDs. Sometimes there are aorticopulmonary collaterals which go unnoticed, and post-operatively patient cannot be deventilated. So you can take this child in the cath lab, identify these collaterals, and can plug them in the cath lab. And quite uncommonly, you may take a child to the cath lab to open up a blocked BT shunt or a bidirectional Glenn shunt. And more recently, as you have heard from some of the earlier speakers, that now there is a trend for replacing valves percutaneously, and on the pediatric side or on the congenital heart side, it is mainly the pulmonary and the tricuspid valve, which is replaced percutaneously. So these are the two important messages that I would like you to take home. The first and foremost is that more than 95% of the pediatric problems are mechanical problems, and mechanical problems need mechanical solutions. So no amount of beta blockers in a child with tetralogy of Fallot, or no amount of diuretics, digoxin or ACE inhibitors in a child with VSD and heart failure are going to help till such time you repair tetralogy or till such time you patch left to right shunts. So it is very important not to waste time just treating these patients or conserving them on pharmacological interventions. And the second important message that I would like you to take home is, once a congenital heart disease, always a congenital heart disease. What does this mean? That if you have a congenital heart disease, you usually require lifelong follow-up. Of course, there are a few cases like, for example, a patent ductus arteriosus or an atrial septal defect, or sometimes even a corrected total anomalous pulmonary veins in early neonatal period. These patients can be discharged from the follow-up maybe 5 years or sometimes 10 years after surgery. But majority of congenital heart disease, which requires some form of surveillance, even after intervention, may be surgical or transcatheter. I'm not going to try and tell you what you already know. I'm just going to discuss with you what new is happening in some of these areas. So let us talk about valvuloplasties. What is new in aortic and pulmonary valvuloplasties? We have started treating patients who are very small, maybe even smaller than 2 kgs, and sometimes even those babies who are preemies, who are prematures. We have started dealing with many sick babies, those with heart failure, those with cardiogenic shock, those with multi-organ failure, because now we have a very great setup in the form of a good intensive care environment, very good intensivists. So these babies can be stabilized to some extent before taking them to the lab and doing the necessary procedure, either a pulmonary or the aortic valvuloplasty. We have started using alternative approaches, like, for example, in pulmonary valvuloplasties in small newborns and infants, we have started using internal jugular vein. Before, we were only trying to use a femoral vein, but there are some cases where approach to pulmonary valve is far easier through internal jugular vein. On the aortic side, we have started using the axillary approach, and you will ask me why, because axillary artery is not an end artery. So even if there is a thrombus, there is a very little chance that you will compromise on upper limb circulation. Unlike that, a femoral artery is an end artery. So if you end up with a thrombosis of femoral artery, sometimes even the ischemia of the limb can jeopardize the survival of the limb. And that can be a very, very major complication. And of course, many centers are now using carotid approach for aortic stenosis. And this is in many centers is done as a hybrid procedure. Surgeon gives you a carotid access and the cardiologist does the balloon aortic valvuloplasty, because from the carotid to the aorta is a straight shot and entry into the aortic valve is not an issue. Of course, over the last couple of decades, results have improved significantly, mainly because of proper patient selection, because of improvement in hardware, and of course, the experience and expertise of the operators all over the country. What about perforating the valves? What is new in pulmonary atresia intact septum? I think that many centers have now learned how to modify hardwares. In these small babies with hypertrophic right ventricles, many times we used to wedge the catheters. In order to prevent wedging, now people make small holes so that there is always a continuous flow. We use a three-way, or rather than three-way, we use a Y connector so that from one side you can use the wire, from the other side you can make small injections, and you will be able to know where your catheter is and which direction the wire should go. Many groups, including ours, are using chronic total occlusion wires, which we have borrowed from our adult interventionists to cross these atretic valves. Here again, sometimes in atretic valves, it is difficult to use a femoral access. So many groups have been using internal jugular access. And lastly, when we started this program sometime in early 2000, I think we didn't stent every patient with pulmonary atresia, and we lost some of the patients when we started coming down on prostaglandins because the duct would close, and these small RVs with pulmonary vascular resistance being high in neonates, I think the cardiac output was not maintained, and these patients again became blue and died of reduced pulmonary blood flow. So now we have become very aggressive in stenting the patent ductus arteriosus, and certainly that has helped in improving the results. What about coarctation and pulmonary artery stenosis? I think in this area, there are quite a few modifications or quite a few new things that have come into play. On the diagnostic side, I think use of rotational angiography and 3D reconstruction, I think it has made a huge impact when you want to do a very precise stenting in the pulmonary arteries, very close to the ostium of the branches. I think rotational angiography helps a lot. 3D reconstruction, along with its roadmap, can also help you in positioning your stents very appropriately. There are now new stents, what are called as formula stents. These are very useful because they are low profile stents and they can be post-dilated to adult size. I think this is very, very important. In a child, the problem is if you put a 6 millimeter stent and tomorrow the child becomes, say, 40 kgs or 50 kgs, you have to keep dilating this stent. And formerly, we never had a stent which could be either post-dilated or which could be zipped open. Now, this formula stent is one such stent which is quite commonly available in India, which you can deploy at 8 millimeters as the child grows. You can go on to 12 millimeters, 16 millimeters. So a 10 millimeter stent can be post-dilated up to 20 millimeters. And very few adults will require stent more than 20 millimeters. The other beauty of formula stent is that despite increasing the diameter, you don't shorten the stent. The stent continues to remain long. And now, of course, even in India, we have got covered stents, which was otherwise a monopoly of the Western world. But for last, I think, maybe 5 years or more, I think covered stents are very regularly available. However, our policy has been to use covered stents only when indicated. I know of many groups in the Western world which use covered stents for every patient of coarctation. We don't do it that way for two reasons. One is it requires a larger vascular access. So in Indian population, which sometimes is small in terms of stature, you may end up with vascular complications. And of course, the cost of the procedure, which is so very crucial in countries with limited resources. Now let's move on to the closure of left to right shunts. We have really widened the horizon of closing ASDs. We have closed very large ASDs, more than 36, 37 millimeters, large ASDs in small children, as small as 6 or 7 kgs. We have closed ASDs 17, 18 millimeters. We have closed ASDs with severe pulmonary hypertension, provided the pulmonary arterial hypertension was reversible, not in those with irreversible hypertension, because if you close ASDs, I mean, you may actually do them more harm than doing them good. ASDs in elderly, which is another subset and which is not uncommonly seen in India. Multiple ASDs, we have evolved our own philosophy of treating multiple ASDs by interrogating the septum and interrogating the defects, and of course, fenestrated interatrial septum with the use of what we call as the cribriform ampullatus septal occluder. We are now able to close ASDs, which are like 5, 6, 7 in number, what we call as a multi-fenestrated interatrial septum. Now, how this has been made possible? One is because of the availability of large devices. As you know, now you can get devices as large as 46, 48 millimeters. Second is we have standardized some of the modified techniques, because the routine technique of closing ASDs, of opening the left atrial disc just outside the left superior pulmonary vein, works in maybe 75 to 80%. And if you are going to widen the horizon, it might work only in 50%. As you start doing more and more complex cases, the standard way of deploying device doesn't work. So balloon assisted technique, which we described in 2004, and the left atrial disc engagement disengagement technique, which we described in 2013. And I'm happy to say that both these techniques have withstood the test of time for over a decade. That shows, that these techniques really work. And as I said, that now there is an availability of fenestrated device, there is an availability of cribriform device. And of course, like for many other procedures, we have now a far increased experience, and along with that, expertise in closing these complex defects. What about VSD closure? So first, I'm going to tell you something about the world scene. What is happening in the world over? So the indications are getting softer. People are closing 3 millimeters, 2 millimeters VSDs, which once upon a time we left to the natural history. And in our practice, even today, we have left it to the natural history. And the reason is that there are more and more cases of infective endocarditis. So indications are getting softer. More number of centers and more operators are closing VSDs because the procedure is getting simpler because of the newer designs of the devices, like for example, Konar multifunctional occluder, which is designed by one of my good friends from Hyderabad. So this is something which has come into being and has made the procedure much simpler. Of course, the success rate has also improved, and in most of the literature, the complications are reported to be much less, at least immediate ones. What is happening in our own experience? In our own experience, it is to the contrary. As a matter of fact, we have had a couple of patients with tricuspid valve injury. We have had, again, one patient with aortic valve issues, having produced almost moderate aortic regurgitation. There is a finite incidence of residual shunt. There are a couple of cases with device embolization. And the worst is a conduction disturbance. We had one patient in whom there was a left bundle branch block causing ventricular dyssynchrony and dilated cardiomyopathy. So looking at all these complications, they are not huge numbers. I mean, the total complications may be to the tune of 2 or 3%. But I think for a VSD where the results are so very predictable with surgical closure, I think I would let the patients go to the surgical colleague and get the VSD closed. So we have moved away from device closure of VSD based on our own experience. We don't have to depend on somebody else's or reports from other countries or other groups. I think our own experience of over 200 cases can teach us much more if there is a good audit of what you're doing. As far as PDA is concerned, I think it's the procedure of choice, no matter what age, and more people are now doing PDA closures in newborns, small infants, and even in preemies. There are two new devices. One is the Piccolo and second is the microvascular plug. Piccolo from Abbott, microvascular plug from Medtronic. They are really doing a great job in closing PDAs in preemies. I must say that closing PDAs in preemies is not so easy. It requires a lot of adrenaline. And although I have probably exhausted my store of adrenaline. But some of my colleagues, even in Reliance Hospital, close preemies with PDAs, although I have moved away from it. And of course, like any other procedure, this procedure also has finite complications. The two of the most serious complications is if your device embolizes in the aorta, or if device moves a little anteriorly, little posteriorly towards the aorta and causes aortic ischemic narrowing, because then removing the device and repairing the coarctation is really a surgeon's nightmare. So you have to be very choosy. Just because you have got a patient of PDA, suppose if it's a 3 kg, 4 kg, having an 8 millimeter ductus, I would hand over this patient to the surgeon. Surgery is definitely a very, very safe option. So it's not necessary that you have to take every patient in the cath lab and try and do everything in the cath lab. I think that is the most important lesson that we have learned over the last 25 to 30 years. some of the uncommon shunts like coronary AV fistulae, pulmonary AV fistulae, and we have a large experience of rupture sinus of Valsalva. Or one of the groups in our own country, I think from KEM, they also have one of the largest experiences in the world. And vein of Galen aneurysm, as you know, in small babies presenting as heart failure or pulmonary arterial hypertension. So these are also some of the uncommon shunts which can be safely and effectively closed in the cath lab. As I said earlier, rarely we also extend our helping hand to our surgical colleagues by closing residual VSDs or by opening block BT shunts or bidirectional Glenn shunts, and sometimes closing the undetected MAPCAs, which then become evident after intracardiac repair. Just a last few words on percutaneous pulmonary valve implantation, which is a rather new technique. And we at Reliance Foundation are probably the only center to be approved officially by Medtronic for use of Melody valve. We have done 9 cases so far, all of whom had 2 to 5 previous surgeries. 5 of them had right ventricle to pulmonary artery conduits, and 4 of them had bioprosthetic valves. All became dysfunctional over a period of time. Most of them had pulmonary stenosis predominantly, and almost all of them had associated pulmonary regurgitation of some severity. All of them had excellent immediate results, but the proof of the pudding is ultimately in eating, and we need to see how the results are in the long term, because these are young individuals. They are not like in their 70s and 80s. So there is a likelihood that their valve might degenerate and they may require one more valve replacement, who knows. So this is an example of a straightforward Melody valve. This patient had 4 surgeries before, and this is the Melody valve. This is a pulmonary artery injection, and you can see that there is no pulmonary regurgitation, and this is the lateral picture. You can see an extremely competent valve there. So this is how we started with a systemic right ventricular pressure, and you can see here that there is hardly any gradient across the pulmonary outflow now, and the right ventricular pressure is less than 50% of the systemic pressure. We have even done some of the complex cases. This is a case of truncus arteriosus, having had undergone already 3 operations, and you can see that this patient has a pulmonary artery stenosis with severe calcification of the conduit and severe degeneration of the conduit with conduit dysfunction. So this is, again, you can see that there is a bilateral stenosis of the branch pulmonary arteries. So we have dilated with the balloon. You can see this, that there is a significant improvement in the caliber of the pulmonary arteries. Not ideal, but certainly better than before. And this is after we have done the pulmonary artery dilatation. This is the Melody valve, which is coming up. The previous stent is called the stent which is used for preparing the landing zone for the Melody valve, and this is the final angiogram. See that competent pulmonary valve, no regurgitation whatsoever. And if I show you the hemodynamics, you can see this. We started with systemic RV pressure, and you can see here again, the RV pressure is around 45 to 50% of the systemic pressure. So ladies and gentlemen, in conclusion, transcatheter interventions for a variety of congenital heart diseases are here to stay. They are pretty safe and effective. They significantly reduce morbidity and in some cases, even mortality. But I think what is most important is patient selection. You can't say that I will try and do every patient in the cath lab. It is just not possible. You have to be very choosy if you want to get good results. What is more important than actually pushing the catheters and deploying the devices is meticulous planning and perfect execution of your plan. And more important than that is auditing your results. I think that is the most important thing. Even if you do 1,000 cases, but if you don't audit your results, it is like doing 1 case 1,000 times. So your experience is going to be only of 1 case because you're going to repeatedly make the same mistakes over and over again. And lastly, this is a team effort. This cannot be done by one individual. It requires a battery of professionals, right from pediatricians, neonatologists, adult cardiologists, the anesthesiologists, intensivists, cardiac surgeons, nurses, technicians, and what have you. And unless you are prepared to work as a team and lead the team in a positive direction, I think the programs for transcatheter interventions are unlikely to succeed. Thanks for your patient hearing, ladies and gentlemen.
Thanks, Bharat. First of all, for all the attendees, you heard him saying that if you go to an interventionalist, he will be biased. But let me tell you that amongst all the pediatric cardiologists, Bharat is the most or one of the most balanced, I would say, pediatrician without much bias, the least I would say. So that is it. And you can see from his slides the way he included the word audit, which is most important, I think, because all these procedures are developing over a period of time since the time he started and since the time now the devices are available. They have all been in progress, and therefore over a period of time it's important to. Now, Bharat, just a couple of questions. First of all, we all know for the general practitioners who are attending, blue babies are diagnosed very easily. But without being blue, what do you would say that how they should pick up these cases and send them to a referral center?
I think that's a good question, VT. I think for making a diagnosis of congenital heart disease in a busy general practice or a pediatric practice, I think requires a very high degree of suspicion. So if you have a baby where the mother complains, I will tell you very frankly, I give a lot of importance to what the mother says. I don't care what the father says. Mothers are so observant, and I don't care what their educational background is. Believe me, even if they are not educated, their observational power and their instincts are so good, they are better than any other investigation. So when the mother says that the child is either breathless or child is excessively irritable, child is excessively lethargic, or if he says that, the precordium is moving a little fast, I would give a lot of importance to that. And these are the babies. Or if the child gets repeated infection, repeated cough, these are some of the babies who would probably be candidates for further evaluation. I think that if you evaluate these children, even by simple things like taking an X-ray chest, putting your stethoscope on the chest, if you hear a murmur, if you see a cardiomegaly, I think these are some of the ways in which you can predict or you can suspect a congenital heart disease. And as you said, if they are blue, then of course the parents will know, but a subtle cyanosis is difficult to pick up. And even for that matter, even for cardiologists, subtle cyanosis is not very easy to pick up. But these are some of the symptoms that should ring alarm bells in your mind, and you should not hesitate in investigating.
With the advent of oximeters being so easily available and people aware of it, do you think that now people are more aware of this desaturation or subtle cyanosis which pick up?
Yeah, no, I agree with you. I think it's a good addition to the armamentarium. But I think you must understand one thing. Ultimately, you must know how to use oximeter. See, I'll tell you, many of the oximeters don't have associated polygraph to tell you whether it is sensing it correctly or not.
Right.
Many of the newborns or infants sometimes have cold periphery. So the pickup of the signals may not be good. And although once I make a diagnosis, I tell them that you could use oximeter to see whether the baby is getting cyanosed or baby is getting desaturated or not. But de novo, to use the oximeter can be a double-edged weapon. It may ring alarm bells too many times if you don't pick up the right signals. If you pick up a lot of noise, then it may not be a great idea to use oximeter. But once having made a diagnosis of congenital heart, certainly oximeters have a role.
Yeah. And I think oximeters with graphs are more better than the ones which just show the bars.
Absolutely. I think those are the better ones, also with audio signals, so that you can, time it with the pulse and all those things. But very frankly, oximeters, even to train the registrars or the residents and the nurses in the intensive care for newborns especially, is quite difficult. So to let the oximeters be used by general public may unnecessarily evoke anxiety in many parents. So I would not really...
that's for newborns, but for regular children, 2, 3 years, 5 years, 7 years down the line.
That may not be a bad idea. In a little older population, definitely that would pick up some of the patients with borderline saturations.
And the other question you said about VHDs, What about, are you saying VSDs in general or muscular VSDs can still be closed?
Excellent. So that's a good question, VT. And I think that muscular VSDs, even your surgical colleagues will tell you that go ahead and close it in the cath lab. Because to find a muscular VSD on a non-beating heart is not as simple as on a beating heart. Also, the chances of you causing injury to the tricuspid valve, to the aortic valve, or to the conduction system are minuscule. And the results are really very gratifying. And not only that we do it in the cath lab, but some of the very large VSDs in very small children, we do as a hybrid procedure. We have a hybrid lab at Reliance, and me and Dr. Shiva Prakash has done at least 4 or 5 VSDs and many other procedures in the hybrid lab, where instead of puncturing the femoral vein or the jugular vein, we have punctured the right ventricle. And you will ask me why? Because these are very small babies. Our hardware is not geared for treating 4 and 5 kg children. Our hardware is good for 8, 9, 10 kgs. And these are really large VSDs requiring 10 millimeters, 12 millimeter devices. So you puncture the right ventricle and do the same procedure from the right ventricle instead of doing it from the internal jugular vein or the femoral vein. The biggest advantage, they don't require cardiopulmonary bypass, and the recuperation time is 24 to 48 hours. They are home by that time. So it's a great advantage.
What about transesophageal echo in pediatrics? Like, do you take the help of that on the table?
Of course, it's a great question. I think transesophageal echo is a part and parcel of transcatheter interventions in pediatrics, more so for atrial septal defect closure. And most of these children require a general anesthesia. That is the downside of it. But then the kind of information that it gives is amazing. So there are, I know of groups who do only on transthoracic, but as a policy at Reliance Foundation, at least the patients who come to us, every patient gets a transesophageal echo. We have had hardly any morbidity, touch wood, so far with transesophageal echo. And that is the reason why we don't think that we should be changing our policy as far as imaging is concerned during transcatheter closure of atrial septal defects or ventricular septal defects.
Once upon a time, always the pediatric cardiologist or the pediatric surgeon would say, let the baby grow up, let it come to 10 kgs, 15 kgs, then we will operate. Is it still true?
No, I think that is a misconcept. And I think that's a very good question that you asked me, because through this question, I would like to tell you that that concept is relegated to the books of history, to tell you the truth.
Fantastic.
Now we have such good teams available that our surgical colleagues, our intensivists, our anesthesiologists can take care of children as small as 2 kgs with cardiopulmonary bypass, even less than 2 kgs. To tell you the truth, TAPVCs, 1200, 1300 grammars, we have been able to fix. So there has been so much of improvement in every subspecialty of pediatric cardiology, pediatric cardiac surgery, pediatric anesthesia, intensive care, myocardial preservation, every part of it, the perfusions, and they are so well trained that, and not only that we can do it, but the results are outstanding. The results are really outstanding. I would not say that, just because some 1200 grammar has a problem, let's repair it. Not like that. But if somebody requires it, we can offer it. It's not that we will drag our feet because somebody is 2 kgs. No more. We will bite the bullet if it comes to that, even in a 2 kg or less than 2 kg child. But we won't offer it to him on a platter because, of course, smaller kids, premature kids have their own problems. Their systems are not that well developed. So they will have problems with cardiopulmonary bypass. But if we require, we would definitely go ahead and do it.
Sir, how about intrauterine interventions?
Intrauterine interventions are done. I'll tell you, in India, I know only of one center, Nageshwar Rao at Hyderabad, the same person who invented this device, Konar. He is the only guy who does fetal interventions. But otherwise, no other center I am aware of does fetal interventions. Fetal interventions are done in Europe, in United States, and even on the eastern side, there are a few centers who do it. But 2 things you need to remember. One is that you require a great team: sonologists, obstetricians, fetal medicine guys, and interventionists. Second important thing, many people think that fetal intervention is once done and it's all hunky-dory. It's not like that. You will require multiple interventions on this child. And sometimes, despite doing fetal intervention, the commonest indication is aortic stenosis, to convert a hypoplastic left heart syndrome into a biventricular heart. But the success rate, even after a fetal intervention, is not even 50%. And that is not with single intervention. Believe me, you require multiple interventions postnatally, transcatheter and surgical, so as to make these patients go from univentricular heart to a biventricular heart, which is, of course, ultimate aim of any cardiac unit, whether it's surgical or intervention.
Yeah. Thanks, Bharat, for those eye-opening advances in pediatric cardiology, and especially with the passage of time, and of course the infrastructure provided by the institution also becomes very important.
Of course. I can assure you that unless you have a team and a solid support from the organization, these things cannot be done. And we are fortunate at Reliance to get a great support from the organization for doing these cases, and some of them absolutely free of cost.
Absolutely.
Thanks for giving me this opportunity to share our experience.
Thanks. So, Anil, can we go to the last lecture now?
Yes, sir. So, friends, we have almost come to the end of this program. And the last speaker is Dr. Shiv Prakash Krishna Naik. And to introduce, sir, I request Dr. Kajal Ahuja, Assistant Secretary, IMA CGP Mumbai Sub-Faculty. Kajal.
And before you introduce, let me tell Dr. Shiva, please don't get disheartened because you are the last. Still more than 500 people are attending this show.
Yes.
That shows India has a great future.
Good morning, everybody.
Good afternoon, sir. Good afternoon.
Thank you. Yeah, please go ahead with the introduction.
Dr. Kajal.
You're on mute. Please unmute yourself. Yeah, we can hear you now. Come on.
Dr. Shiv Prakash Krishna Naik is the head of Department of Pediatric Cardiac Science at Sir H.N. Reliance Foundation Hospital and Research Center. He did his MBBS and MS in general surgery from Bangalore Medical College with a gold medal. He then completed MCH from the Postgraduate Institute of Medical Education and Research, Chandigarh. Later, he received fellowship in pediatric cardiac surgery from Royal Alexandra Hospital, Westmead, Sydney, Australia. He is a former professor, pediatric cardiac surgery at Amrita Institute, Kerala. He is the founder member of Pediatric Cardiac Society of India. He is former president, Pediatric Cardiac Society of India from 2016 to 2018. His technical skills and areas of clinical expertise include complex reconstructions, neonatal cardiac surgery, cosmetic congenital heart surgery, and valve repairs in children. Today, he'll be speaking on pediatric and congenital heart anomaly surgery and overview. Over to Dr. Shiv Prakash Krishna Naik.
Good afternoon, friends. दोस्तों, मेरा बात कुछ is it well heard? Am I clear?
Yes, you are very audible.
You are clear. Go ahead. You are visible, clear, and your slides are seen.
Loud and clear, sir.
Good afternoon to all of you. And before I forget, because I am aging fast, मैं भूल जाता हूँ. पहले मैं जितेश भाई को और VT जी को और अनिल भाई को मेरा I want to express my gratitude to giving me this opportunity really to speak to all of you. And let me tell that pediatric cardiac surgery overview मुझे मिला था 2 साल में PGI चंडीगढ़ में. It was a overview. So 2 साल का ट्रेनिंग को मैं actually 20 मिनट में देना मेरे लिए मुश्किल है. मेरे पास still because it is lunch time मैं 14 slides किया हूँ आपके लिए. And please bear with me those 14 slides, and I'll try to make it as lighter as possible for the heart and soul of it. And let me start straight away telling that about something about my field. It's a general talk, and it will be superficial for most of the professionals in pediatric cardiology and pediatric cardiac surgery. But the whole purpose is actually to enlighten about my field, what's happening in the current times. And to be honest with you, मैं शायद पहला 2-3 हिंदुस्तानियों में एक आदमी था जो पीडियाट्रिक कार्डियक सर्जरी को एज ए सोल स्पेशलिटी लेने का आफ्टर MCH. So from that perspective, as long as I tell about myself, I will be telling about the overview of the pediatric cardiac surgery itself. So I will be using my own life as a metaphor to explain about my field. This is our good colleague from All India Institute, Dr. Anita Saxena ने article लिखा था February 2008 में, and telling that 90,000 children suffer from critical cardiac lesions requiring early interventions. And उन्होंने one important message which is probably good for the IMA members, that 10% of the infant mortality rate in India can be addressed if we address the entire congenital heart diseases in India. So that's a significant number. In that way, I think pediatric and congenital heart diseases, particularly for the World Heart Day, somehow I feel that most of the time the stress is on the adults rather than children. But I want to say that these are the future adults. So that's the reason it's important to remember that we need to do something for them. So in that context, let me just tell that the field, what is so challenging? क्यों ये field के बारे में मैं बात कर रहा हूँ rather than picking a subset of congenital heart surgery? That's basically, as I've shown the picture, it's a synchronized skydiving, requires enormous amount of trial runs and recce before we give a perfect synchronized skydiving, which is a treat to watch. So pediatric cardiac surgery is something like that. It is coming together of several specialties, and you can pick up each one of those uniforms, red, blue, black, and whatever which is seen, and put a name to them as pediatric cardiac surgeon, cardiologist, anesthetist, perfusionist. You name the team players. They all are necessary to give a great outcomes. The second challenge which comes is that the parents are generally young, unable to take the stress of it. And this is not only for psychological stress, but it's a funding stress also will come to them. And requirement of multiple surgeries and interventions for this age group of children. So just to let you know that only maybe let us say 50% of the children will require these sort of interventions rather than the entire specialty. It is a resource intensive field. There is absolutely no doubt about it. Probably the most important aspect is the timely referral. All the other above mentioned the variables have been addressed by India in the last quarter of a century since my MCH. But timely referral is one of those variables which still continues to challenge us. मेरा एक स्पेशलिटी का एक पिक्चर आपको दिखा रहा हूँ. This is an ICU dilemma, a fever in an infant after open heart surgery. This requires coming together of three specialties: surgeon, pediatrician, and a cardiologist. Because this fever could be by any of these variables what I mentioned. It could be a simple wound infection, or it could be a general sepsis for the neonate, or it could be just most grim endocarditis. So it could be any one of them, and we need to crack the code, identify the problem precisely, and address this child. Otherwise, this child is not going to make it. And that's the reason why my field becomes stressful. This is my own first original article of my career. And this gives a insight to you. When I was doing my MCH and started doing pediatric cardiac surgery in 1990, this was the article which I published along with Dr. K.M. Cherian in Madras, where I spent about 10 years of my professional career, that 1 in 3 children with these complex heart defects, we were losing, and we published it. And the data got published at that time, mind you, in a European journal, which is supposed to be number 3 on the planet at that time, simply because 33% mortality was accepted and was supposed to be satisfactory in those times. But much has water flown from that time. And now we have got the outcomes which are here. I have just outlined some of the complex lesions, what are called as tetralogies, transpositions, AV canals, and total anomalous pulmonary venous connections. Some of the well-established complex heart defects. And as you can see, something which is there in 1990 and what is there in 2020 for the same lesions. We have got, by and large, success rates amounting to more than 95% to 97% in all these lesions, simply because, as Bharat Bhai earlier mentioned, that it is just that the technology and the science as a whole progressed to a phenomenal extent, and that knowledge doubling time really has compounded itself to give the benefit to this generation much faster than what happened in the last 75 years. So this is one more slide just to tell you that when I started my pediatric cardiac surgery, the centers in India, we had only 2. This is the one, the blue in the histogram. And what's happening in 2019 right now, we have got in Maharashtra itself, 10 centers are there, which are delivering pediatric cardiac surgery. So that is a rapid growth of the specialty. And that shows that the infrastructure to take care of these children, number one. Number two, the manpower to deliver this sort of care. Both have increased exponentially. And I think society is not complaining about it, even though by the number, the sheer number, the burden of the congenital heart diseases in India, even now, this number is considered inadequate. We require some more specialists in this specialty. So the present challenges, as I said, I put 4 of them: prompt and precise diagnosis, setting up an ideal ICU, finance, and prompt referrals. These were the 4 variables which have dogged as my specialty for the last quarter century. And in that, prompt and precise diagnosis and setting up an ideal ICU has been addressed fully for the entire country. At least in pockets, we have got centers of excellence now in this nation. But when compared to that, the present problem is a prompt referral and funding of these procedures. Those remain the bigger challenges even now. The one sentence I want to add, the timing of intervention. Already Bharat has mentioned in the comment to a query that it requires very, very intimate knowledge of the disease. What is going to happen to the disease if you do not treat it? And a deep understanding of what happens if you do surgery, and after the end of 20 years or 30 years to these patients, what's going to happen? That is what we call as modified history. In दोनों का knowledge जो है वो pediatric cardiologist के पास रहता है, नहीं तो pediatric cardiac surgeons के पास रहता है. And that is the reason the child first point of contact from the IMA member, it has to be a pediatrician who is proficient in congenital heart disease, or otherwise a qualified pediatric cardiologist. I want to give this entire maybe 30 minutes of message I could have given in this just one slide, but I want to put it just as one slide to make it easy for you. There are subsets of congenital heart diseases in our field which require surgery mandatorily in the neonatal period. Transpositions, TAPVCs, arch interruptions, pulmonary-atresias, hypoplastic left hearts. Some of the complex lesions, inko dosto, we can't allow them to go without procedures beyond 30 days because they're not going to make it. You make a diagnosis like this, I think in the next 24 hours or 48 hours, these children should reach the hospital, should reach programs of pediatric cardiac surgery and should get operated. It's very important that we should not be waiting for the weight or the age of the child to see to it that the child will have a safer surgery, because the child has to have surgery for it to become safe. There are some groups of children whom we should operate before they turn 365 days old, and that's what we call it as an infant heart surgery. Again, the operative risk, I have put it in the smaller fonts there. They're all in the range of 3% with the present centers of excellence, whatever India has got. And the entire aim of pediatric cardiac surgery is that we need to send, this is global, we need to send the children to school with a completely normal heart. That's the aim, what we have got around the world right now. And these are some of the photographs I have given it for you. These are a spectrum of transpositions. The one which is blue doesn't have any hole in the heart. The one which has got pink image there, that shows that essentially the child has got a large hole in the heart and there is a transposition, and this is a complex coronary, what we call as an inverted coronary artery arrangement. Some of these photographs I will show you so that you don't sleep off or you don't want to get up to have your lunch. I know that. So please don't worry. I already finished my 50% of the lecture to you. This is an arterial switch in progress. And this is a large ventricular septal defect, what is called as a perimembranous VSD. And then adjacent to it, you're seeing one more large hole. This is called as additional muscular VSD. And this is, if you open a heart, particularly right atrium or upper chambers of the heart, you see 2 walls. And here you are seeing one large wall and with a large hole which should have actually covered this area. And this is what is called as complete AV canal, or otherwise endocardial cushion defect. My friend Dr. Ajit Pradhan keeps mentioning that, Shiva, I feel as if when I open the heart, it's like a large rose which is sitting inside the heart. I just want to close it back because I can't fix it. So to get oriented to these lesions and then to start putting first suture, generally after MCH, it takes 3 to 4 years, because this is one of the known complex lesions. And we are supposed to be a little experts in these subsets right now. This is a mini sternotomy surgeries. I want to highlight to all of you that Bharat Bhai is coming out and his team are coming out with lots of devices and interventions to address a lot of congenital heart diseases, which is welcome because it's development of science. But at the same time, surgeons should not be lagging behind and should be sitting, celebrating the laurels of the past. So that is the reason we keep doing these surgeries, which are minimally invasive, which are cosmetically much more superior than a conventional sternotomy. And some of these tetralogies, VSTs, ASDs, lots of those lesions which can be operated from the upper chambers of the surgery, we end up doing them with these approaches. And this is a approach which is, we are quite well known around the country for this, what is called as posterior thoracotomy closures. And it's a cosmetic incision where the child herself, when she grows up, does not know that she has got a scar in the back. And if you don't tell her, after 3-4 years of surgery, they generally forget and they lead a normal life. This actually restores the self-esteem and self-confidence to these children because there is no disfiguring scar in the front. And these are some of the special work what we do and what we are known for. These are some of the last 4-5 years of cutting edge work what has gone in our program. What we have published in some of the leading journals of the world. These are all complex heart surgeries where the heart is on the right side and the entire chambers are all reversed with what is called as dextrocardia with situs inversus. And we are known to operate these children in larger number. This is one of our European publication which practically states that we enjoy the extreme popularity with these approaches. This is one of the largest series of experiences of operating on these hearts. We have done from VST closure to double switch operations in setting up these situs inversus and dextrocardia. And I don't know why it is not moving. This is one more operation which is very well suited for our society. And this innovation, I take pride in the fact that before this we were struggling, wherein we used to open the chest, a case of tetralogy, and suddenly we see that the coronary artery is crossing the right ventricular outflow tract, and we used to close it back simply because it required a conduit and there was no other way for us to fix it. So we came up with a technique what is called as double barrel outflow repair, which has sort of stood the test of time. And last maybe 15 years of my experience with this technique since I explained it first time, we have operated somewhere around 53 cases of these double barrel outflow repairs, and with nobody requiring any reintervention for one more redo surgery for them. So this is one more where what is called as a Swiss cheese septum, where dosto interventricular septum is just riddled with hundreds of holes there. And this particular ventricular septal defect pathology, we have addressed by what is called as an intraoperative customized double patch device. Again, got published in a European journal about 3 years back, which effectively closes most of the holes, if not all, and thereby resulting in a lasting cure for these children rather than them getting operated repeatedly and still having residual defects. So thereby we have made some attempts to decrease the number of surgeries, or otherwise we have made some attempts to simplify the existing surgical solutions for these children so that it is reproducible and it reduces the number of operations for these children. Having said all these things, I want IMA members to remember this. There are certain subsets which are remaining in the realms of congenital heart diseases, which have got even now extremely poor outcomes, come what may, regardless of our surgical approaches. And there are 4 of them. I want you to remember that one is called as diffuse pulmonary vein stenosis, which is recurrent. Second one is a hypoplastic left heart with severe tricuspid regurgitation. Third one is a pulmonary atresia VST collateral with complete absence of any pulmonary arteries within the pericardium. Now, these are the 4 subsets for which probably a heart or a lung or otherwise a heart-lung transplant both should be advised, and probably they are the mathematical solutions for them. I'm not sure that whether they're pragmatic solutions for South Asia, but the fact is that you can fix them by only doing the transplants. So at HN Reliance, since September 2015, we have started this program. We do about 250 to 300 surgeries a year. Number of interventions have really gone up to 200 per year, thanks to the brilliance of Dr. Bharat, who is there with us as a mentor for the program. We operate a lot of neonates, approximately 70 to 75 per year. We have got cumulatively 10 consultants in surgical and cardiological and ICU units to take care of these children. And these are some of the features what we are doing in HN Reliance Foundation. But I just want to tell you that we have this hybrid heart surgery which carry zero mortality. And the youngest baby which underwent surgery was 3 hours. And the smallest child to undergo complex congenital heart surgery was an infracardiac TPVC weighing 1,600 grams. And we have got some of these complex lesions we are doing, which I should say very proudly, because thanks to my team, we have got exceedingly good results, matching or maybe a little superior to the Western standards when all those operable lesions what we are doing. And we are noted for our percutaneous pulmonary valve replacements because of Bharat Bhai's leadership here. It is an accredited center thanks to him for training and also for doing these procedures in large number here. And it is a center known for cosmetic congenital heart surgeries and for double switch operations. These are the infrastructure what Anil Bhai, I think possibly was mentioning it. This is the exceptional infrastructure and support of manpower what we get here. And if you get this sort of manpower and infrastructure, to be honest with you, you don't require Shiva Prakash also. Anybody else with 5 years or 10 years of experience after his MCH, I think can deliver. These are some of the images of hybrid OTs and the ICU and the our customized singles children or single infant ICUs, what you can see there with giraffes. And these infrastructures are necessary to deliver great outcomes, because without them, there is always post-operative morbidity, if not mortality, which challenges the outcome. So that's the reason it's important to remember that it is not a single man show, it is not a loop who is delivering here. It is a system which delivers these outcomes. And these systems are necessities for delivering exceptionally good results in pediatric cardiac surgery. And ultimately, at the end of the day, you want to see that, he is the king. The child is the king, and we are all, I think, fringe players who are trying to do our best to see to it that we make him smile rather than make him angrier. So the outcomes, if you want to really good outcomes in the present scenario, early elective surgeries, again, I told you, prompt referrals, and they are the only ones which are actually going to make a difference in the present day. Cardiologists and cardiac surgeons, we are adequate in number, at least in the state of Maharashtra now. There are more centers, and there are very well-informed pediatricians these days, I find, in the last 15 years of my working here. And along with that, the IMA members, if they remember that we can...
A little here, not little more.
Hello?
Yeah, we can hear you. Go ahead, sir.
So this is, I am putting Ganapati Papa's, my one of my favorite images, a cyanotic Ganesha and a cyanotic Ganesha, just to for cyanotic heart diseases. And as you remember, Mahadev, much time, it was a very early correction of a accident which happened. Whatever the xenotransmission, I just want to use that opportunity to say that early corrections, even during those days, it produced useful persons for mankind for thousands of years. Ganapati has been a mentoring force or a god to us, all of us. So in a way, it symbolizes pediatric cardiac surgery. So you want me to tell about present scenario, what's happening in my field? It was much better than what it was in 2009 when I came to Mumbai. There is a substantial number of pediatric cardiac surgeons, pediatric cardiologists, but they are still considered not enough. We still require more surgeons and cardiologists. Timely referrals have become more frequent. There is no doubt about it. I have not had time, otherwise I would have shown you some of the very interesting, very inspiring slides where from the periphery of the state where children have been brought here and where the short of resuscitation them in the emergency, we have pulled out those children amazingly because of brilliant transportation by pediatricians in the periphery. And almost all the children with congenital heart diseases are treated here only in the state of Maharashtra, in the city of Mumbai. Mumbaikar or the Marathis, they need not go anywhere else. They can get the treatment of entire gamut of congenital heart diseases in our state. Whether it is invisible surgery, or a intervention, or a double switch, or a Norwood surgery, or a transplant, all of them are performed in our state. And outcomes what we have in our select centers, they match Western standards, or possibly I think we are much better than them given the constraints in which we follow. I want the IMA members to remember this one particular slide. Breathlessness, precardial activity which is high, blueness of the baby, episodes of the altered sensorium, anything other than regular heartbeat, a pulsation, pedal pulsations is feeble or otherwise not felt, saturation below 90%. These are the things. If the baby is blue, that means the saturation is definitely less than 90%. If you have got this in your clinic, please see to it that the child is shown to the pediatrician who is proficient in congenital heart diseases or to a pediatric cardiologist. And then only people like Shiva Prakash, I think, will come into place. So to conclude my talk, I hope I have not bored you. 98% of our structural cardiac defects can be addressed with excellent outcomes, regardless of the weight, regardless of the age, regardless of the prematurity or maturity of the baby. If the child requires surgery, then it has to be recommended and we have to pursue the surgical pathway. The coordination between the referring doctor and us is very critical for timely transport and timely intervention for these children. And cosmetic approaches, what we are doing right now, they are necessary adjuvants in our practice in the face of ever-expanding international field. And as Bharat Bhai earlier mentioned in his talk, there is nothing extraordinary about any of these programs, any of us. It is just that the science as a whole has improved in all spheres, whether it is perfusion, surgery, anesthesia. It's just that the open heart surgery has become much more safer. We have got some defects which require immediate surgery and intervention. So we should not be delaying in getting in touch with each other so that we will help that child. So ultimately, as I said, he is the king and we are here to help him. Thank you very much.
Thank you, Dr. Shiva. Thanks for being so modest, humble, in all humility. We all know that yours is the most challenging job and you have godowns and godowns of adrenaline with you stored up. So you can take up all these challenges. They can be seen in your slides also. Fantastic work and nice pioneering work also at the same time to lead this branch into such status of international standard. So I am sure that now with all these advances and results, you have been able to show us all the latest advances in this. Can you please stop sharing so that others can be seen? Yeah.
Thank you.
Thank you. Thank you very much, Dr. Shiva. Now just a couple of questions. You gave both clinical slides also to all our IMA members as to when to refer, what are the conditions, and I'm sure that at least if they remember that last important slide of yours as to when to refer, much more would be served and we'll be able to help many patients with this. I am sorry, actually, I'm dumbfounded with the presentation that I have not answered to you. And there are no chat questions. There are no chat questions also. But it was wonderful overall to hear all of you and the advances in the field of cardiology. So, Dr. Awad, can we request concluding remarks by our IMA member?
Jitesh. Dr. Jitesh.
Yes.
Dr.
As I told you, one of my classmates is also a pediatric surgeon, Dr. Suresh Rao, and you have worked with him closely. And I've seen pediatric surgeons have such a nice and humble way of approaching life. So fantastic. All the speakers of today were wonderful, absolutely great. And of course, the main in charge person, Dr. VT Shah, He was the man who brought out the best from all of them. And the question answers were also very interesting. And I thank each one of them. Thank you very much. Right from Dr. Bansal and Dr. Ajit Menon, Dr. Mashru, Dr. Maulik Parekh, Dr. Nihar Mehta, Dr. Bhamre, Dr. Kamath, Dr. Shiva Prakash, and Dr. Bharat Dalvi. All of you, thank you very much for giving us your valuable time and sharing your knowledge, the latest of knowledge. Thank you so much. All of us are very indebted. And of course, I also thank our delegates who have been so patiently hearing and listening to all the speakers. Thank you very much. And a big thank you to Dr. Pragji Vaja also being the MMC observer for today's program.
Kajal is there to tell all these things, Jitesh.
No, that's all right.
Okay.
Now, before we wind up, I request Dr. Kajal Ahuja, Assistant Secretary, IMA CGP, to propose the vote of thanks.
Good afternoon, all. I would like to thank our speakers of today's webinar, namely Dr. Narendra Bansal, Dr. Ajit Menon, Dr. Maulik Parekh, Dr. Nihar Mehta, Dr. Manoj Mashru, Dr. Neeraj Kamath, Dr. Bipin Chandra Bhamre, Dr. Bharat Dalvi, and Dr. Shiv Prakash. I also thank our knowledge partners for the day, Sir H.N. Reliance Hospital. I thank Mr. Dipin Mehta, Mr. Piyush Kale, and Ms. Vaishali Tanpure from DigiShield, who have given us the platform for this webinar and handled all the technical details at the same time. I thank Dr. Anil Award, President-elect, and Dr. V.T. Shah, Chairperson of the World Heart Day Committee, for conducting this webinar smoothly and efficiently. A big thank you to Dr. Pragji Vaja for being the MMC observer for today's session. Last but not the least, I thank you all the delegates for participating in this webinar in large numbers and making it a grand success. Thank you very much.
Thank you, all of you. Stay safe. Take care. See you physically. Bye-bye. See you. Thank you very much.
Thank you, sir. Thank you,
you.
sir.
Yeah.
Piyush.
Yes, sir.
Close down.
All right.